Good morning. Secretary Dr. Mark Galley, Dr. David Carlisle,
Present.
Dr. Sandra Hernandez,
Present.
Richard Kroenig,
Present.
Ian Lewis,
Present.
Elizabeth Mitchell,
Present.
Dr. Richard Pan,
Present.
Don Molds. All right. 6 present, 2 absent.
Great, I think we have a quorum, correct? Yeah, okay. So maybe let's move to our executive updates. I'll give it over to you, Elizabeth.
Thank you very much, Dr. Hernandez. Good morning, everyone. I'll start by reviewing our agenda slide for today. We have a very full agenda. After more than a year of work together, we're going to have our action item on the spending growth target. We will be taking item 5A out of order. So after our executive updates and the meeting minutes, we will do items 5A, which constitute the follow-up that the board requested about the spending growth target. And after those items, then we will move to item 4, which is the action item. I'd like to note that we hope to have that action item before lunch. After lunch, we have 3 very substantial items related to our performance measures work stream. So we have sections on APMs, on the workforce stability standards, and on the primary care spending definition and threshold. We've had very meaningful work with a work group on these items, appreciate their participation as well as the feedback from the advisory committee. Of course, this board has heard and given us feedback on the alternative payment models, so we have some revisions to propose to you all today, and then look forward to the first discussions with this board on the workforce stability standards and on the primary care spend definitions, which we'll come back to and try to have a firm approach by this summer as we are required to do. In terms of executive updates, I'll keep it very brief given the robust agenda that we have. I would like to note that earlier this month, HCI approved the last of our distressed hospital loan program loans to the Madera Community Hospital. And that loan is being used to help reopen the hospital as early as this summer. As you know, that hospital has been closed since January. In terms of our health workforce development programs, we continue to make progress on our wellness coaches. Our wellness coach scholarship program recently launched and is currently accepting applications for students pursuing associate or bachelor's degrees in programs that qualify for the certified wellness coach profession. So we're trying to get the word out in every venue possible, including this one. So with that, I'm pleased to turn it over to Deputy Director Pagani.
Thank you, Director Landsberg. So as we do at every meeting, I'd like to remind the board and the public about our slide formatting key. As many of you know, the statute denotes different roles for the board in different areas. We use a yellow area in the presentation for areas over which OCA or the office has decision-making authority. It's important to get stakeholder input on these areas, and these meetings are an important way to engage with both the board and members of the public. For areas where the board has ultimate decision-making authority, we note it with the green arrow. Next, I'll review our quarterly work plan and future topics under consideration. So we have the April items listed here, which is consistent with the agenda that's been presented. In May, we do have a placeholder for the statewide spending target in case action isn't taken in this meeting. We'll provide an update on the workforce stability standards, as well as an update on the primary care investment benchmark. And then we have made some progress on with the subcommittee, so we may appoint advisory committee members in the May meeting. And moving to the right column for May, with the advisory committee, we plan to discuss examples of cost reducing strategies. So these are presentations typically made by a healthcare entity on how they're reducing costs while maintaining quality and or equity. We'll provide a presentation on out-of-pocket, out-of-plan spending. We covered it previously with the board, and we plan to also socialize it with the advisory committee. We'll also have a presentation from the UC Berkeley Labor Center on consumer affordability measures. And then we'll, similar to the way we've presented to the board, we'll also provide updates to the advisory committee on the workforce stability standards, primary care investment, and the APM standards and adoption goal. And then lastly, for June, we have some topics listed here, which is an action item for approving the APM or alternative payment model standards and adoption goal. We'll discuss the workforce stability standards, continue discussion on that topic. We'll also have another presentation from a healthcare entity on cost reducing strategies they're undertaking. And then just in case no action is taken on the advisory committee, we have a placeholder for the June meeting as well. And with that, I'll just turn it over to the chair to facilitate any questions.
Thank you, Vishal. Let me welcome Don Molds, who joined us, and maybe just take a moment to also acknowledge Assemblyman Wood, who's with us this morning. Welcome, Assemblyman. As we were all talking this morning, just acknowledging that this work and this effort wouldn't be taking place without your leadership, and so we want to formally acknowledge that. Appreciate you being with us today and your leadership on many things health-related. Too numerous to name here, but want to really appreciate your leadership in healthcare in the state. So thank you for being with us today, and we look forward to hearing with you whenever it's appropriate. So thank you. Comments from the board on the update, executive update? Any comments from the public?
Dr. Hernandez, I overlooked covering this slide. This is just a high-level list of topics for topics that we plan to cover with the board and the public beyond June. So we'll continue items for total healthcare expenditures and spending target, including an introductory conversation on administrative costs and profits for health plans. We'll discuss OCA's approach for public reporting and analysis in the baseline report. We'll continue the discussions we've been having on progressive enforcement, introductory conversations on sector targets, and then for promoting high value system performance, I've covered these as well. The last bullet under that category, progress defining behavioral health and developing behavioral health spending benchmark. So that's going to be a new topic that's going to be starting to be presented to the board, and we have a work group that's going to be working through the definitions, types of providers and settings in which behavioral health services occur. And then lastly, for assessing market consolidation, we do plan to return to the board to provide updates on any notices of material change that have been submitted to the office and providing some summary statistics on those. And turning it back over to the chair.
Thank you. Any public comment? Anything from the board?
Okay. We will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. If you're dialing into this meeting on the conference phone line and you would like to provide public comment, we ask that you submit your comments via email at ohca@hcai.ca.gov, or please join this meeting online if you would make verbal public comment. Please keep your comments to 2 minutes or less so that we can hear from as many members of the public as possible. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. Looking to individuals on the podium, seeing none. Looking individuals virtually, noting for the record that we have an estimated 120 people attending virtually. Seeing no hands raised at this time, that concludes public comment.
Great, thank you. So with that, I think the next item would be to approve our March 25th board meeting minutes. Um,
Actually, I
Pan,
do wish to ask for a correction in the minutes.
please.
So I would make notes in the minutes in the presentation from our director and deputy director. It makes reference to the Brown Primary Care Residency Program. I believe that's supposed to be the Song Brown. I think it's really important because unfortunately Asian Americans are too often rendered invisible. Senator Alfred Song, was the first Asian American ever elected to the California legislature. He was first elected to the assembly in 1961. He then was elected to the state senate in 1965. He represented the San Gabriel area. At the time, that was not a heavily Asian area, as we might think about it now. But he was the first, he was a veteran, a Korean American. And of course, he worked with Assembly Member Willie Brown. That's why it's called Song Brown. But let's not forget him. And he did make a mark in California, particularly as an attorney, as chair of the Judiciary Committee, and leader of the Senate, the Democratic Senate Caucus. But certainly his work on workforce, which also not only established this program, but also the Workforce Commission, were particularly important to California. So let's not forget him. Thank you.
Thank you for that very important correction, Dr. Pan.
So with that correction, I would move approval.
Great, J.R. Second. Okay, public comments?
We'll now take public comment on this item. Anybody would like to make public comment in the room, please step to the podium. Those attending virtually, please raise your hand. Seeing no members of the public in the room stepping to the podium, no hands raised virtually. That concludes public comment on this item.
Great. Any other comments from the board? Again, thank you, Dr. Pan, for both the history and the clarification on the minutes. Let's take a vote.
Dr. Mark Galley. Dr. David Carlisle.
Aye.
Dr. Sandra Hernandez.
Aye.
Richard Kroenig.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Aye.
We have 6 yeses, 1 absent.
Great, thank you. Minutes are approved. Okay. Director Landsberg, you want to open up the next item? Or?
So I'll be presenting this informational item. Next slide, please. So today, OCA will provide information about the 4 items listed here. The first is information about how OCA attributes members and how it will apply the target to fully integrated delivery systems, as well as how OCA will measure hospitals without attributed lives. Second, board member Kroenig requested that we discuss a slide showing 5-year rolling averages that we previously covered in January. Third, we'll share information about Medi-Cal historical and projected per member spending. And lastly, we'll share industry ideas for cost savings from the public comment letters we received. Next slide. So Kaiser Permanente is currently the only healthcare entity meeting the definition of a FIDS or fully integrated delivery system. We've provided the definition in the footnote because the statutory definition references an exclusive contract between a healthcare services plan and a single physician organization in each geographic region. OCA will instruct Kaiser to attribute member spending, including hospital spending, to each of Kaiser's 2 physician organizations, which are Kaiser Permanente Medical Group in Northern California and the Southern California Permanente Medical Group in Southern California. OCA will apply the statewide spending target to each of these fully integrated delivery systems. I'll go on to the next slide. Yeah, we could pause for questions.
Just clarification on, so Kaiser is not only a medical group, Permanente Medical Group, and their hospital system, they're also a health plan. So are we evaluating their health plan separately from the hospital physician group that you're putting together here?
It's Kaiser has their own definition in the statute.
Right, I'm
Yeah.
right aware of that.
Okay. They
I don't know how you're operationalizing that.
Yeah,
because we're talking about the medical group and the hospitals, but
Yeah.
there's no reference to the health plan.
Yeah, the health plan, the total medical expenses, you could add the admin costs and profits portion, which is going to be derived from the medical loss ratio reports. So once you add the total medical expense plus admin costs and profits, then you get the total healthcare expenditures. So that's going to be inclusive of the health plan.
Okay. So you get a number for the health plan, but depending on what that quote medical loss ratio is, there may be different rates of growth of the plan part versus the group hospital part.
Yeah, I mean,
Recognize that.
we will start, as you note, there's three different entities. There's
Right.
the foundation, the Kaiser Foundation Health Plan, the two different medical groups, and the hospital system. So we will absolutely start with the Kaiser Foundation Health Plan numbers for the and as you know, the fully integrated delivery system, we're looking uniquely at them as a health plan, a medical group, and a hospital system together with the North and the South. And we will be evaluating them against the spending growth target with those two regions, and then separately as a health plan also for their admin costs and profits.
Okay. All right. I wanted some clarifications. They haven't made reference to the health plan part until now. Thank you.
So unless there's other questions, I'll go on to the next follow-up item. Following up from March, we also review how OCA instructs payers to attribute spending to provider organizations, including physician organizations affiliated or under common ownership with hospitals. The order of operations in our data submission guide refers to an attribution addendum, which is essentially a list of identifying provider organizations for which submitters can attribute total medical expenses for California members. I'd note that the attribution addendum is not a comprehensive list of provider organizations, but a living document that we will periodically update with each reporting period. Step one in the order of operations is capitated delegated arrangement. If members for whom utilization management and claims payment functions have been delegated to an organization listed in the addendum through a capitated arrangement, the members' TME or total medical expenses are attributed to that organization. Step two is total cost of care ACO arrangement. After step one, if there are any remaining members, which we expect, and they're enrolled in a total cost of care ACO arrangement, we ask that these members' total medical expenses are attributed to an organization listed on the attribution addendum. Specifically, this would be the physician organization participating in the ACO arrangement. Step three involves organizations not listed in the attribution addendum. So we would ask that remaining members be attributed to an organization not listed in the OCA attribution addendum using steps 1 and 2 that I just covered. The attributed TME for those organizations can be reported along with the organization's legal name. So this would be a process where the payer or submitter identifies additional organizations for which steps 1 and 2 can be performed. And then, this will provide new information to OCA about additional organizations, and we'll later add these organizations to the attribution addendum for future reporting periods. And then going on to the next slide, after attributing members using steps 1 to 3, we attribute total medical expenses for remaining members using the following order of operations. Step 4 is a payer developed rules-based attribution. we ask that remaining members be attributed to an organization using a payer-developed rules-based attribution methodology. And then lastly, step 5 is the category of not attributed. There's we note that not all members will be attributed. Data for members who cannot be attributed to any organization using any of the methods I discussed are expected to be reported using the not attributed attribution method, or not attributed category. So I know I covered a lot. I want to just pause here in case there's any questions. Yes.
Michelle, this mostly makes sense to me. I know sort of going back one slide to number 2, and I know that for many ACOs, members aren't enrolled with an organization, but there is an attribution process that the payer engages in to attribute members to an organization. And I'm assuming that those members would be assigned in number 4 on the next slide. Is that correct, or am I misunderstanding something?
So number 2 is intended to be ACOs. So if there's, for example, like a PPO ACO, and they are, they kind of know this population is going to be in the PPO ACO, we'll be able to identify those organizations. But step 4 would be the typically payers use a look back approach on.
Right.
Yeah.
Yeah. I mean, certainly for Medicare ACOs, Medicare beneficiaries don't enroll with a physician organization, right? Medicare uses this look back approach to attribute members, or sometimes prospectively attribute members to a physician group. And for many non-Medicare ACOs, I'd look to Don and others who are closer to it, I think it's a pretty similar process. But it's relatively rare, I think, for an ACO person to be enrolled. Yeah.
Step 2, we really want to narrow in on ACOs. So we have that as a distinct category. And step 4 would be it's not necessarily an ACO. It could just be through methods that payers use.
Yeah, but I guess my point and concern is that even for the ACOs, that is typically done through an attribution method. And I think it's important to get information both in step 2 and in step 4 about the attribution methods that are being used, so that 2 years from now or 5 years from now, we might be able to move towards a common attribution method, or at least understanding, what's being done.
Yeah, we do. We will be gathering information when the submission comes in. We do intend to engage the payers to understand how they perform the attribution, and this is our initial approach for the baseline report, and we will learn a lot, and that could inform a standard attribution approach in the future.
Thank you.
Other questions or comments from the board? Michelle, so the payer developed rules-based attribution, that will be standard across all payers?
No, it will not. It's typically, generally attribution of spending occurs through that historical look back of member utilization. So it's typically based on a preponderance of visits with a provider, and then they'll link that member spending to a PCP and then up to a provider organization. So what we do know about is that payers each have an approach. We do think there's commonality, but there could be differences. So as part of our baseline reporting and data collection process, we do intend to learn a lot, and then that could potentially inform a standard approach later.
Great. So there is some commonalities, but we expect some variations, at least at the beginning. Is that?
There could be variations in terms of some of them may look at utilization. Some of them look at a claims history. There could be differences among them. Dr. Pan, you had a question?
So just to clarify, recognizing that in the beginning, that is there the intent to create a more standardized measure, because, or are we just referring to the plans to do attribution? I mean, I recognize in the beginning, but is the intent then to review them and eventually develop a standardized methodology?
Yeah, this is our initial approach for baseline reporting. It's a little too early to tell if there will be a standard approach, but we do want to learn about what payers are doing, and it could inform a standard approach later on.
So at least there's an intent then. This way. Obviously, the attribution starts becoming very important, much more important than it was prior to what we're going to be doing. So it's going to be important that that methodology is one that's acceptable and that people have confidence in. So I understand certainly that we're deferring to the plans using their existing methodology, but it's, I would think that we want to first review them, be sure we're okay, right? Because if someone comes back to us and says, hey, you misattributed us, I don't think the answer is like, well, the plan assigned it to you, so that's, I think some people need to be able to appeal if there's an issue there, right? And that there should be some review of the rules-based attribution, and that I guess it's just as you mentioned to Dr. Hernandez, that if there's variations and that's leading to differences in attribution, we need to know what those are and then see if we need to fix them or not, right? So I guess I would say is that you will be reviewing these payer developed rules attributions to be sure that we have confidence in them. If you're not going to develop, we're going to eventually develop our own. And I hear what you're saying, you got to learn, right? Learning's important. And so I understand initially that's where we're going, but that's why I asked the intent in the end. Not saying that you have to do it right off, is that we would at least at minimum review these and ideally perhaps then develop a standardized methodology, especially if there's issues that are raised by people who feel like they've been misattributed. And what happens, you have one group of people with one plan being attributed and other people that be attributed a bit differently because their payer used a different methodology.
Yeah, I would agree with what you're saying. And so a member of our advisory committee said if you had to kind of pick an existing one that payers are already using, such as for Medicare, and that way kind of everyone's using one approach. So we have gotten recommendations on that. If OCA does not have confidence in the way that the data is coming in, we wouldn't publicly report on it.
Okay. All right. I just want to be sure someone's looking at them, that we're not just deferring without looking at them. Thank you.
Well, and I'm catching up. I think it's also fair to say that the board will get a sense of the office's confidence. Assessment of that, and we'll have a chance before it has any broad impact, whether our approach to attribution makes sense, whether we need to take something that's a bit more off the shelf for industry practice. I think that there's, as you said, the learning is really key, and the humility in the learning needs to continue. So I think that is what we should expect as a board, for sure.
So I'll go on to the next slide. So in January, we had a presentation on hospital spending as it relates to measuring performance relative to the target. OCA expects the total medical expenses approach to measure spending performance for provider organizations with attributed lives to include physician organizations affiliated or under common ownership with hospitals. Because nearly 40% of healthcare spending occurs in hospitals, and to achieve success in spending targets, there's a need for additional strategies to better understand hospital spending across all patients, in addition to in addition to those ones that are able to be attributed to have lives attributed using the TME approach. To that end, OCA is convening a multi-stakeholder work group and technical advisory panel to inform development of measurement methodologies for hospitals and enable more effective accountability for performance relative to the target. And then I'll go on to the next slide. So we are resharing this slide from the January meeting at the request of board member Kronik. The left graph shows the 5-year rolling averages. This means taking 5-year averages starting from 2018 to 2022, then 2017 to 2021, 2016 to 2020, and so on. From 2002 to 2022, the average of the 5-year rolling averages is 2.9% and yields a minimum of negative 0.7% and a maximum of 5.3%. And then, as shown on the right, in the absence of 5-year rolling averages, the minimum and maximum values are negative 3.3% to 10.8% respectively. I'll now turn it back to board member Kronik if he has any follow-up questions or discussion related to this slide.
Thank you, Vishal, and no questions. Thank you for resharing this. Just a comment which I've made before. I have spent 40 plus years analyzing data and trying to figure out, what does a particular set of data imply about causal relationships or the future or forecasting. I have no crystal balls. This is a kind of remarkable data series in showing stability from 2012 to the present. So, the 2012 to 2016 period centered in 2013, 2014, it's about 10 years ago. You see the little blip down in 2014, a little blip up in the next data point. But, a person doesn't commonly see this sort of stability in data. I mean, sometimes, depends on what you're looking at. And I've got no crystal balls, but it is, looking at this, it does seem much more likely than not, in the absence of expecting a recession, which obviously could happen, but to the extent that economists are talking about it, it's not what people are expecting. Sort of makes most sense to think that this stability is what we're likely to see over the next 5 years, or more likely than not to see it over the next 5 years. And, it's hard to interpolate, but I'm pretty sure that this line is stable at about 4%, maybe even a little more, 4.1, I forget. And clearly it could go down to 3% or to 2% or to 0, or it could go up. But as I look at that, it does seem hard to get from this line to an expectation that median income growth is going to be 3%. And even if median income growth is going to be 4%, it might be good to set a target at 3%, that we want to give folks 1% savings. I can certainly see that argument. That is a little different than what we have previously said, which is that we adopted this sort of 20-year notion about affordability. I think under the least implicit assumption that was sort of our best estimate of what median income growth was going to be. And I think our best estimate of median income growth should be closer to 4%. Again, we might want a 3% target for commercial insurance per person, saying we've been paying too much and shaving off 1% is a good idea, but it would be at least a little bit different method or a little different assumption, I think, than what we had previously discussed, which is we wanted to set this at the level of expected median income growth.
Yeah, I totally agree, Dr. Cronick. And I was going to note that these are gross median household income numbers. Are not inflation adjusted. And I think if you added an inflation adjuster to this metric, we'd probably see even more flatness or even a downward trend in the growth of MHI over time.
Go ahead, Richard.
Yeah, I first of all, I appreciate Dr. Koenig bringing this back up again, because I think we need to be, the data is quite obvious. Sorry, I'd say it. You look at the line. I mean, and trying to keep talking about 20 years, but really the last 10 years, it's pretty stable. I certainly agree that, perhaps we should put in an inflation adjuster, so it's constant dollars or whatever, and maybe. But also the reason for a 5-year rolling average is we're discussing, looking at generally doing 5 years, is that it does even things out. But what you see is that on the rolling average, you can see a remarkable amount of stability here. Now, again, I agree. There's no crystal ball. Actually, interesting enough, even in that 10-year period, we've had various events happen. I would actually make note that one of the events that happened, although probably isn't directly correlated, is that we had the implementation of the ACA. Right, that really started kicking in. Although it was passed in 2010, really, most of the implementation didn't happen until 2012, 2013, right? And that's when it started really kicking in. So I do think the 10 years, there's a lot of reasons for saying 10-year look back makes a lot of sense. And I agree with Dr. Koenig, that doesn't, in itself, that doesn't mean you can't stick a lower crossstep, but at least we're much more straightforward with people to say, you know what? We recognize that the median age, right, perhaps adjusted for inflation, is whatever, right? So, and we are intentionally setting a target that is below that. That's okay to say that too. But I think if we try to say, well, actually what we're doing is setting it at, because we used a 20-year look back because it gave us the number we wanted. Whereas we look at the chart and you go, well, actually, what the future, which of course is always uncertain. We've been at this constant level for 10 years. Essentially, if you do a roll, normal things people would do to sort of level things out a little bit, so that in terms of presentation, right? That we're not doing anything remarkable here by doing a 5-year rolling average, right? I think it's a strong argument. He said that if you're going to say that it's based on median wage, we're actually going under, and that's okay as long as we explicitly say, but that's okay to say that then. But let's not pretend like, oh no, we're just basing it on it. And what happens is we picked a 20-year because people are going to go, well, I think you're cherry picking a little bit. Now if this thing had been going up and down all 20 years, right? Like that'd be different. But what we're seeing is this really last 10 years, this plateau. That's relatively level, and 10 years is not a short amount of time. I mean, 20 years is still longer than my kids have been around, and one's about to graduate from high school. So I'm just like, why 20 years? That's a pretty long period of time, right? 10 years is still a long period of time, and it would represent a certain amount of stability. It certainly represents a typical economic cycle with recessions and so forth. Usually take place within 10 years. So I think it's important that what we present to the public reflects that understanding. Thank you.
Great. Elizabeth first, then Ian.
Thank you, and thanks for the conversation. I'm still focused on our aim of making healthcare affordable, and I think that this is, important information, but I also have, 2 daughters in their 20s, and if you were to not factor inflation in, they would be doing great right now. But housing, education, gas, everything is truly taking away from what they can pay for health insurance. Right now I'm paying for it, but next year I won't be. And I really think, to David's point, that if we do not think about actual consumer purchasing ability, we're missing the point of the entire exercise. And, you know, let's say inflation takes this down, we are still, you know, we are not addressing affordability of healthcare. And I think that is the overriding point.
Just so we sort of clearly state a few of the points that are being made, what I hear couple people, Rick, you started it, that understanding how we arrived at using median household income and what period of time we're using isn't necessarily the only way to then justify what your growth target might be. We might say it's whatever percent and we're aiming lower for a reason around affordability is, I think, your point. I think the question it raises, of course, is, and I'll turn back to staff after Ian, just that, you know, rehash of the discussion around 20 versus 10 and a little bit about what we've been through. I think, David, your point, what you brought up first, and a lot of people agree with, it's hard, especially given the last couple of years of what inflation has felt like for every Californian, not just in the space of healthcare, but in other areas, how that would play in. I think it's an important point. But I do want to just make sure that we're addressing, Elizabeth, your, you know, ultimately we're here to talk about affordability and setting a cost target that makes sense in that way. We're using median household income as a guide to that. But as Rick, you said, doesn't have to be, hey, it's a 1-for-1. This is what it was over whatever period, and that's where we're going to set the target. So I do want to just reconcile that I think that there's a path here with these comments to both get clarity on our approach, but still pay attention to the ultimate aim of what we're here to do and why that cost target and how we set it matters for affordability for where healthcare costs are going overall. Go ahead, Ian.
Yeah, I mean, I do want to point out there has been huge variability in household income over the last 10 years. Just look at the slide to the right. Now the 5-year average smooths that out, you know, and that's what 5-year averages are for. I don't have any problem, and in fact, I appreciate a 20-year look back because, you know, to the very point that that period includes a great recession, that was the last time prior to this past 12 or 18 months that we were seeing 10, 15, in some cases 20% rate increases for large group premiums. Every time I look at this chart, I overlay it in my mind with what we're paying for healthcare, which far exceeds either of these charts. So I think the method, the 20-year look back, is totally appropriate. And I don't see the inconsistency here. I keep going back to something Don said maybe 6 months ago to paraphrase that, you know, the method is important, but the question here is how aggressive do we want to be in containing health costs? And I don't see an inconsistency there. And I do think that if that 3% happens to be under the arbitrary 5-year rolling average that we have for this last period, so much the better.
Yeah, I appreciate the conversation, and we've talked about methodology quite a bit. I do think that it's very hard to predict recessions. I do think the point of what we're trying to achieve here is to try to lean into affordability. I want to just go on record that I don't think we cherry-picked any date to hit a number. And so that I want to be clear about. And we've talked about, do we look back 10 years? Do we look back 20 years? We could have looked back 15 years. I think the idea here was to get as much information as we possibly could and not really cherry-pick a methodology to hit a number. But I'm generally, and if the point is to be clear that we're proposing a number that's under the 5-year rolling average, I'm perfectly okay with that.
Great. Other comments from board on this? Okay. Vishal, Elizabeth, CJ, anything you want to add?
So I'll move on to the next topic, which is about historical and projected per member Medi-Cal spending. So this slide shows Medicaid budget and expenditure system quarterly CMS 64 expenditure data for California. From 2014 to 2023, the annual average growth in per member Medi-Cal spending was 5.9%. There was market variation, as you see in the table, ranging from a low of negative 5.4% to a high of 29.5%. There were significant policy changes that drove the 29.5% increase for 2015, including implementation of the ACA expansion, coordinated care initiative implementation, and an 1115 waiver renewal related to the Bridge to Reform Low-Income Health Program, or LIP. And then I'd note that the ACA expansion is the biggest contributor to this 29.5% increase. Excluding the 29.5% change from 2014 to 2015, yields an overall average change of 3% for the period 2015 to 2023. And then I just have one more slide to cover about projected per member national Medicaid spending. Long-term state level per member Medi-Cal projections are not available, but we do have fiscal year 2024, 2025 numbers from the DHCS budget estimate. For fiscal year 24-25, the budget includes a 9% increase in per member spending. This above average per capita growth reflects several policy changes, including a full year of full scope benefits expansion for the undocumented population aged 26 to 49, and the proposed new managed care organization tax and related provider payment increases. So in addition, I'd note that CMS projects national Medicaid per member spending growing at an annual average of 5.4% from 2024 to 2031. And that's at the national level. Any questions on these two slides?
Go ahead, Richard, and then David.
A couple of first of all, is this including LTSS services for Medicaid? Because that's what drives a lot of cost in the Medicaid program.
I believe it includes it.
Okay, all right. So just want to recognize that we have someone who takes care of kids, but we may be large number, but small percentage. Mm-hmm. But okay. Also, it's interesting. You did make note that the ACA expansion led to a very large increase, 29.5. Now this is per member cost, so this was not we added a bunch of people. It's that people got much more expensive. Did you want to elaborate on why the per member costs jumped up so high? I have some guesses, but you had a 29.5 and then a 10.2 increase the year after per member.
Yeah. Thank you very much, Dr. Pan. We did coordinate with the HCS on this data, and we've have asked them for. We posed exactly that question and don't have a lot of detailed information, but are happy to follow up. They didn't have anything readily available. I mean, I don't know if it was partly going from the LIP to the expansion adults that expansion, they were more limited benefits, as I recall, at the county level than at the state level. But we're happy to follow up to get more detail about the specific reasons.
That would be helpful. My guess is part of it is that what happens is you have a large population with essentially a lot of unmet need that wasn't met, and then now they finally got insurance, and so boom, right? You got.
I also think it took a little while for us to calibrate the right capitation level for the expansion adults, as I recall.
Okay, all right. As I said, there may people out there. So I would also make note that, as you said, and the percentage so here is from DHCS, right? And this second table, the projections in the future, right? Sorry, that's the next slide. And then those are DHCS projections for future years.
The table is from CMS.
The table is from CMS. Okay, so this is a CMS projection,
yeah.
not for our state. Okay. Well, all right. Well, I would make note that they are projecting 5.4% for the next 7 years. So I guess one question I have there is that I know that in the prior discussion you talked about how for the plans, right, you have different products, right? You have the Medicare side, you have the Medicaid side. You don't want to punish, after all, we've been underpaying on the Medicaid side, so we want to punish people. But are we looking at down the provider side? So if you're mainly a Medicaid provider and the per member, not change projected spending is going to be 5.4%, you're a dish hospital or you're a clinic and take disproportionate care, is that going to be factored into on the provider side as to, and I'm not even sure how you're going to collect the data because that's something that's not divvied up that way. So on the plan side, of course, they have their product lines. Right? I have a Medicaid line, I have a Medicare line, Medicare Advantage line, I have my commercial line. How are we doing it on the provider side? If you have someone who takes a higher percentage of Medi-Cal, or your hospital or your clinic or your practice actually in a low-income area, we're setting a target 3. They're projecting a 5. We know that there's been chronic uninvestment. So are you going to get dinged for that? Or your group that focuses on have a disproportionate number of Medi-Cal patients? How's that going to work on the provider side?
Yeah, we would intend to enforce the target by market. So the commercial Medicare and Medicaid markets.
Also on the provider side, not just on the plan side. That's why I want to clarify, because I think there's some concern about how accurate the data may be on the provider side, because we don't sit there and go, always do a, wallet biopsy of everybody. So, obviously we know in the front desk, whatever, but so on providers, the provider is going to be reporting it based on lines as well. I just want to clarify that.
The providers themselves wouldn't be directly reporting, but the payers that pay for the claims and non-claim spending, we would attribute it to a provider, and then the members themselves can be identified by the plan if they're a commercial member versus a Medicaid.
So you're going to go back and then create a profile for each provider based on the payer data to figure that out?
Yes, our data submission guide, through the attribution approach, we ask that they report by to each physician organization by market.
Okay, and the physician organization perhaps disputes the attribution. This goes back to why the attribution gets really important, because like I'm a medical group and I'm okay, you know what? I know from our billing, our arrangements, this percentage is Medi-Cal, this percentage is Medicare Advantage, this is commercial. And what you're saying, your attribution comes up with a different set. And especially we're saying, okay, Medicaid's allowed to go up 5.4, let's say, and Medicare, blah, blah, blah. And so commercial's only 3. That distribution is going to be really important when it comes down to, well, do you get dinged or not, right? So you have a process for the plan, for the provider group to go back and say, or the hospital, if you're a hospital, to go back and say, hey, by the way, your attribution doesn't line up with the data we have about who our payers are.
Yeah, those are all good points. We would, have a process to validate the data, with the both the payer, and then share the data with the provider as well for their review. Because of the dominance of HMO capitated products in Medi-Cal, they're typically is a cleaner way to do attribution under that first step that I covered about capitated delegated arrangements. So that the HMO MCOs essentially assign patients to a group. I know Medi-Cal members can switch, and that can happen, but we would be able to. It wouldn't be as that other step 4 that I showed, where it's not as tight as step 1. Yeah.
And since it is on the agenda, although we may decide where we decide today or next month, since our deadline is June 1st, but the target eventually going to decide on, and we have to decide on by June 1st. Again, so Medi-Cal, so the Medi-Cal, does Medi-Cal get its own exception, or how does that work? You know, how do we average in the 5.7%? I mean, you talked about like, oh, well, we're actually not going to if you have, and then we have the Medicare side of things, right? And that, you know, federal. So previously you talked about how essentially those are those exceptions that they don't count. We're just looking at the rest of it. So can you perhaps elaborate how this all starts coming together for a provider entity, group or hospital? Okay, now you got different lines, right? And so the target we're going to be voting on eventually, you know, today, this month or today or next month, is going to apply to what?
Yeah, so since what the board will be doing in the next month or two is adopting a statewide growth target, we have to apply it on a statewide basis. But what we've discussed is, and had slides about it previously, is that we will look at it by lines of business and plan to enforce it by lines of business.
Thank you. There might be more questions about it. But
yeah, and I'd add, we talked about if there's policy changes, if the growth is driven solely by policy decisions made by, for example, DHCS,
sure. Right.
that would be a mitigating factor for enforcement.
I'll just add two things. I appreciate all of your questions, Richard, in part because I think it highlights this, just coming back to the other point that you made, learning. We're going to see a lot of things. We're going to see a lot of things develop. We have, you know, sector targets to set and define the sectors, et cetera. I mean, there's going to be a lot that goes into this, of course. And then more specifically on the Medicaid piece, important thing DHCS did in the last 2 years was a new model contract, which creates a lot of reporting transparency requirements for the plans around who they delegate to, which providers they have. And I think for the attribution work, wasn't designed to facilitate attribution work. It was designed for transparency and understanding what we were getting for the dollars the state and the feds are spending in Medicaid. But I think it will naturally help a bit with this attribution question as it relates to Medicaid beneficiaries, which is, I think, good news on the whole. Okay, I know there was a question. David, you're next.
It was really more of a comment, maybe a question. You know, I was probably somewhat comforted when I looked at California's spending compared to the 24 and 25 projections for national Medicaid. But then I realized that nationally we have a large variation in Medicaid expenditures. And these national projections include states like, you know, just speaking Mississippi, Arkansas, Louisiana, where per member expenditures in Medicaid are pretty dismal. And the other thing that's going on here is that we're still seeing the slow trickle of universal adoption of Medicaid expansion across the country that may be driving up some of these rates as well. So I just wanted to say that it might be more interesting or relevant to compare California to maybe more successful Medicaid programs in the country like New York, for example, and look at their per member expenses in Medicaid as a benchmark rather than a national average that includes a number of very low numbers.
I think definitely a good comment and something we should keep our eye on. And I think, as everyone in this room knows, and on up here, that we have made quite a few investments as a state in health-related social needs and a number of sort of new benefits, if you will, that move from pilot phase, waiver phase into sort of core parts of our Medicaid managed care program, which of course not every state is even considering, and that is changing what we spend per beneficiary in our Medicaid program. So I think there's a lot of apples to oranges for sure on the national scene, but looking at how other sort of like-minded states are pushing forward is a good consideration. Okay, other questions on this side? Anywhere else? Okay, keep on moving, Vishal.
Yeah. So this is the last board follow-up item. So in the March meeting, Board Member Mitchell asked about industry ideas for reducing costs. We couldn't adequately answer the question in real time, but have since taken another look at the comments we received. The key themes for cost savings from the public comment letters received from hospitals, health systems, and healthcare industry stakeholders include the items listed here: paying differently for healthcare, shifting away from a fragmented system and pursuing legislative policy changes. On the next slide, for the theme of paying differently for healthcare, stakeholders mention reducing the share of healthcare expenditures paid via fee-for-service, including a market shift to HMO rather than PPO or fee-for-service plans. Stakeholders suggested tying providers to a risk-adjusted global budget that encompasses the full spectrum of population health needs. Creating new performance requirements and incentive funds for accessing or for achieving cost containment, productivity, efficiency, and access goals. They also suggested changing physician compensation models to incentivize primary care practice in underserved areas and reduce the income gap between PCPs and other specialties. Moving on to the theme of shifting away from a fragmented system, stakeholders commented about the need to shift towards integrated care systems composed of sufficiently scaled medical groups, hospitals, and health systems that can provide the platform for effective stewardship of both the health and financial risk of a population across settings, conditions, and time. They also suggested reorganizing delivery models with a comprehensive focus on health equity because of the potential for long-term savings. And then these last two bullets, they noted studies about the benefits of robust systems of primary care, and also that strong primary care may also reduce the negative effects of income inequality and is associated with more effective and equitable health services. And then the last theme is pursuing legislative policy changes. Stakeholders suggested the following: statutory requirements for offering coverage models that provide lower total cost of care and higher quality outcomes. With regard to prescription drugs, they mentioned a few reforms, including preventing harmful markups and increased costs for patients by protecting the use of specialty pharmacies to access lower drug costs, and increasing drug cost transparency by requiring pricing disclosures from manufacturers at the time of launch. And then another idea was to prohibit billing by off-campus hospital-owned providers. The commenters also noted the importance of addressing anti-competitive contracting practices by consolidated health systems, such as all or nothing provisions, anti-tiering, and anti-steering clauses in provider contracts. And then lastly, they noted the need to address administrative efficiencies, including requiring payers to standardize and streamline their or utilization management and payment rules. So I'll just pause here for any
Less a question than a comment. First of all, thank you for following up on this. And I'm actually encouraged. These are a lot of good ideas, and it sounds like the industry does know how to reduce costs. So I'm excited to see the progress, and we support many of these legislative changes, like prohibiting anti-competitive practices. So it sounds like there's alignment on ways forward. So I'm encouraged. Thank you.
Go ahead, Richard.
In the discussion, and I know we're going to later be talking about primary care spend, is there any discussion about continuity? And if you look at the work on advanced primary care that was done by Barbara Starfield, really a lot of the benefits derived from the relationship between the patient and their care team and the physician running the care team. So, and of that's, and of course, some of that's tied to continuity. You're not always seeing a different person each time, right? You actually can develop a relationship. So was there any discussion about incentives or other types of efforts to try to promote? So I know they sort of say primary care, but is there some discussion about actually recognizing the value of that continuity? And so, because every year you change plan, you change whatever, you change group, you change and I don't, this is someone who's on the front lines as a physician. I can certainly understand the exacerbation of patients saying, you're the umpteenth person I've had to explain this to again, because I keep seeing a different person. So was there any discussion about that?
Not specifically in these comment letters, but that is a theme in the investment and payment work group on having that continuous relationship with your PCP. So that'd be a good topic to return to in this meeting.
Yeah, I'll just echo that. I mean, in primary care, we talk about continuity is king, right? It's really where the benefit comes from as your, or queen, or whatever. Yes, it's a high priority. But I think it's a really fantastic point that not only we should dig into, but it'd be great to bring that concept a little closer here. And what does it mean, to your point, Elizabeth, that we're learning, we know what to do in some of these spaces. There are some real good, strong concepts on how to maintain continuity. You can't prevent people from shifting out of your provider group, but you can make sure that that provider and that team does see a patient in an ongoing way when that's achievable. So I think it's a great flag for us to follow.
I just say it's one thing. If the patient wants to change, that of course. If the patient doesn't want to change, we got to think like what kind of, what can we do so that the patient can stay with the team that they want? Obviously, as long as if the team's behaving well, they should be able to stay.
Oh, please.
So I really appreciated sort of extracting the comments we've gotten from letters and from stakeholders. I think it's also important to keep in mind that there are other legislative programs that are in play in the state that also should be helpful in cost savings. And the one that I want to call out and name is really the data exchange work that's going on in the state, because I think there's a tremendous amount of inefficiency that happens from data, real-time data that you're not able to see, and that then requires clinicians to repeat and do additional things. And so this work is happening in the context of other reform efforts in the state that should also help us with cost containment, and data exchange seems to me to be a very important one.
Thank you for that very important addition. Elizabeth?
Just building on that, I think another related but separate initiative that we should have full visibility into is the new primary care technical assistance funding that has been authorized by DHCS. And I think understanding how that is being managed and distributed and what benefits it's having for primary care practices, which we see that they need that support, will be very important to OCA's success as well.
Other comments? Thank you.
So we can move on to the action item. So on the next slide, we've shown this before, a visual timeline conveying the board process for adopting the spending target. And the next slide shows the statutory requirements for setting a target that we previously shared. And moving on to the next couple set of slides. So OCA has summarized the discussions we've had to date on the spending target. In September of 2023, OCA and the board reviewed the requirements in state law and considerations, including board and office responsibilities for the target and the timeline. We reviewed other states' methodologies. We assessed economic indicators and population-based measures, including the ones listed here. We also discussed use of historical and forecasted data and reviewed adjustment factors in the statute. Next slide. So in October, some of the highlights of our discussion include that we discussed historical spending growth in California over varying time horizons. We continue to discuss economic indicators and the difference between actual historical data versus forecasted data. The board discussed OCA's preliminary recommendation that the statewide spending target should be a single economic indicator, rely on median household income, use historical data. We discussed population-based research to inform the target value, including the topics listed here. There was discussion on the pros and cons of multi-year targets, including the duration of the target and a fixed versus phase-in approach. Next, the board discussed OCA's preliminary recommendation of a 5-year target duration that includes a target value that phased in and then remained fixed. Lastly, in October, we discussed the impacts of revisiting the target mid-year or mid-cycle. And then in the next slide, this covers our discussions from December. We discussed potential adjustments related to trends in technology and the price of healthcare technologies, for which OCA recommended no adjustment. OCA presented its preliminary proposal, which was a 3% target for 2025 to 2029, based on a weighted average of historical median household income change with no phase-in. We also presented background on median household income changes from 2002 to 2021. Our conversations also included OCA's reasoning for not recommending population-based adjustments. Lastly, we proposed that the board commit to evaluating the target for potential adjustments on an annual basis. And then the next slide, for January, our discussion history included a recap of consumer affordability challenges in California, including the disproportionate impacts on communities of color, identification of research literature on opportunities for savings that could slow spending growth, the rationale for OCA's recommendation for the statewide spending target, including tying the target value to a consumer-centric economic indicator of median household income, not applying population or technology-based adjustments, meeting annually to consider whether there are needed updates to the target, including adjustments for unforeseen circumstances. And then my last slide on the discussion history is in February, OCA and the board discussed advisory committee summary feedback on OCA's recommendation. We discussed factors for consideration that may contextualize spending growth when assessing performance relative to the target, including mitigating factors. Lastly, in March, OCA and the board discussed written public comment summary feedback on OCA's recommendation, as well as advisory committee responses to public comments. And then just have one more slide to cover on population-based aging. So we wanted to take a moment to acknowledge that an aging population will impact spending growth, but improving the quality of healthcare for seniors and end-of-life care represents an opportunity to not only improve care and enhance patient satisfaction, but to also lower healthcare costs and improve consumer affordability. We do know the proportion of Californians age 65 and older is projected to increase, but the costs of this population are predominantly borne by Medicare. As far as OCA's current approach for population aging, we will report total healthcare expenditures, or THCE, adjusted for changes in the age and sex composition of an entity's population. These adjustments will account for year-over-year changes in an entity's population. OCA is committed to continually evaluate the impact of aging on total healthcare expenditures. As we collect data for the baseline report and subsequent annually reported data, we will assess whether we need modifications to the way we apply the age-sex adjustment to spending data, or whether it is merited for the board to make adjustments to the target itself. And then I just want to pause in case there's any discussion.
Go ahead, Rick, and then Richard.
Thank you, Vishal. On this last point, I I think it's important for us to be internally consistent and clear about the target and the statements we're making about it. And, you know, in the comment letter this month from Health Access, there's a strong and well-reasoned argument about applying targets separately by line of business, that is Medicare, Medi-Cal, and commercial. And we talked about that last month. You know, to me, that makes a lot of sense. If we were to decide that the targets for commercial, Medi-Cal, and Medicare should each be 3% per person, that would imply that the statewide health spending growth would be 3.5 to 3.6%, because there are, as you note on this slide, an increasingly large number or increasing proportion of state residents who are over 65, and people over 65 are more expensive. So, you know, if we want to adopt a 3% statewide growth target, either initially or phasing down to it, we should just be clear that what we intend is that commercial, Medicare, and Medi-Cal growth each are at about 2.4 to 2.5%. And again, maybe that's what we want. It will be more affordable at 2.4 or 2.5% than at 3 or at 4. But we haven't had that discussion explicitly here. And I think, you know, I am very appreciative of the work, Vishal, that you and your staff have done, you know, just excellent management over the last year of the information. There was a mistake in the initial presentation in which you presented information, or Michael, that kind of aging wouldn't really matter much. And we've had some subsequent discussion, and I think it's pretty clear that aging does have a, you know, 0.5, 0.6, 0.7% per year, other things equal, increase in health spending. And again, I can imagine that we are collectively comfortable saying that what we want is for health spending to grow at 2.4% per commercially insured person, and 2.4% per Medi-Cal Benny, and 2.4% per Medicare Benny. And that would be consistent with a 3% statewide target. But we should just, you know, be clear that if we're adopting a 3% target, we are looking at targets of 2.4 to 2.5 for each of the three sectors. And if what we want is a target of 3% for each of the three sectors, then the statewide target to be consistent with that should be 3.5 or 3.7.
Go ahead, Elizabeth.
Thank you very much, Rick. One note I do want to make, I think there is some difference of opinion as to what that number is, whether it's 0.4, 0.5, 0.6. But any of those numbers sort of assume the way we're providing care today. And what I have so appreciated is that we've had many opportunities to have the discussion about really changing the way we're providing care. And so, I mean, I did write this last bullet point on the slide, and we think there, of course, you're right that care for seniors does take up a disproportionate amount of healthcare spending. And so therefore, we think there are some unique opportunities really to change the way we are providing care for seniors and end-of-life care that is a win-win-win, as noted here. So we would push back a little bit on the notion that those numbers are correct.
Well, I couldn't agree more. I mean, I think we're all here because we want to see the way that care is being provided change, and in many ways, including to become more affordable. My point is simply that we should be internally consistent and straightforward and clear about the targets that we're looking for. And if we want a target of 3% statewide, that is a target of 2.5% for each of the three sectors, more or less, maybe 2.4, maybe 2.6. But it's not, it would be internally inconsistent to say that we want 3% for each sector and 3% statewide, because that wouldn't happen. if we achieved 3% for each of the three sectors, statewide would be 3.5-ish, maybe 3.4, maybe 3.6. But because of, the increasing numbers of Medicare beneficiaries, while I have the 4.1, we talked about Medi-Cal. We haven't talked much about Medicare. We did, mention last meeting that I think we were presented information that the Office of the Actuary is projecting nationwide Medicare growth at about 5.4% per beneficiary. I completely agree. We want to change that. It's not completely clear to me. I mean, we all know that more than half of Medicare beneficiaries in California are in Medicare Advantage plans. And I've thought about this a little, and I've studied the MA a lot. It's still not completely clear to me if we were to bring spending growth down to 3%, given the way CMS is paying Medicare Advantage plans, what the implication of that would be. I think the main implication would be actually more profit for the plans, which is not what any of us want. Maybe even less affordability for consumers. That's a complex part of the story that we haven't really talked about, and probably we're not set up to do that today, obviously.
Yeah, and you've raised that point before, and as I've thought about it, obviously that's a conversation. We don't have the right people around this dais to understand what the potential opportunities are in that space, I would say, right? And so it's a very important, interesting question, and I want to make sure, Elizabeth, before we come to you, to go to you, Richard, in part because we've had, you've raised the aging population as well, and just want to hear your thoughts.
First of all, I want to recognize Dr. Cronin's tremendous experience as the former director of ARC, his record, his knowledge of healthcare, health policy, and I agree with him, and I think we need to be more transparent. Frankly, I actually think we need to have a population adjuster in the whatever targets we pick. Now, you know what? As we talked about with median income, right? If you want to say you want 1% below what was in the last 10 years, which has been pretty stable, then say that. If we want 3% and we want the population that, and if you really want 3% in the end, then fine. Say your target is whatever, 2.6 or 2.5 or 2.7, and we're doing the 0.3 population adjuster and we land at 3. I think that's a lot more honest and direct than hiding it, right? Because the reality is, first of all, yes, people are older, costs more, but it's just not that they cost more. It's that actually they have higher healthcare needs. I hope no one disagrees with that. Their needs are higher. They need more services to address those needs. And those services are going to cost something. Now, I agree. Yeah, we can do more efficiently. By the way, if we can hold for the same age population, right? Let's just say, if we can actually reduce the spending down to 3 or 3.5 or 2 or whatever, right? From what it was before, but yet because people are getting older, it went up. We still got efficiency. We still increased efficiency there. But we need to acknowledge the reality that, probably it's not necessarily in the realm of the healthcare sector, although, maybe we put a little more in prevention and so forth, but it's really societal that basically people who, when you get older, have more healthcare needs. It's both biological and societal, social determinants of health, right? And so the population adjuster acknowledges that in the end, what happens is you have a patient who comes who has needs and you need to try to address those, and that the general population is getting older. So we should have a population adjuster built in, and that's explicit in there. And if you want the target to land at 3, fine. Then say what we're going to do is we're going to put a cap of 2.4, whatever you want to say it's 0.3, 0.4. But we can have we can go through the math and be sure we have but basically say that the real target, what we're saying is that we want to contain healthcare spending, and because people are getting older, and therefore we're going to end up at 3, 3.5, whatever that final number is. Because I think that's a lot more transparent to people. And guess what? If we suddenly have a huge wave of young immigrants and that's it, then the population adjuster changes, right? Because the distribution will be different. But we need to acknowledge the fact that an older population has greater healthcare needs. And unless we are planning not to meet those needs, that needs to be built in and put in explicitly in whatever target we put in. And then we know what the actual, what the actual room is. And again, I as I said, it's, you can say, fine, let's squeeze more water out of it. That's fine. But let's just acknowledge the fact that you do have old people who have greater needs. The population is going to have greater needs because it's aging. And so far, no one's provided any data to show that that's incorrect. So let's just face that reality.
Go ahead, Elizabeth.
Thank you. I want to go back to Elizabeth's comment about thinking differently about the system. I think everything you're saying is true if no changes happen in the system. And I had the privilege of co-chairing PTAC, which was not quite as successful as one would have hoped, but we were appointed by the GAO to identify alternative payment and delivery models led by clinicians. And so it was so really inspiring to hear all of the ideas that physicians and clinicians had to make care better and more affordable. And they brought us multiple models that would achieve everything we're talking about here, one of them being hospital at home. And we're starting to see that just really take off around the country through commercial incentives and the need to meet care needs differently. So it's not just about them having care needs that might grow, but we could be so much more effective at how we meet them, not just in an inpatient setting, but in homes, in communities with, different makeups of care teams. And I think we are underestimating the ability of the industry to innovate. Clearly, they have the ideas. We saw them at PTAC, we saw them today. And I think that with the right flexibility and support, they will make care more affordable while actually being more effective at meeting those needs. So I don't want to underestimate that.
Other comments? Go ahead, Rick.
I don't disagree with you at all. I only, and apologies for the repetition, but I will repeat, that if we are going to talk about sector-specific targets, it would be inconsistent and sort of incoherent if we were to set sector-specific targets of 3% for Medi-Cal, Medicare, and commercial, and a statewide target of 3%, because those things wouldn't add up. If we have sector-specific targets of 3%, the statewide target should be 3.5 or 3.4 or 3.6. If we have a statewide target of 3, the sector-specific target should be 2.4 or 2.5. That's and 2.4 or 2.5 might be great. 0 might be great. I'm simply making a plea that we be at least internally consistent.
And the potential decision in front of the board today, not the decision in front of the board today, how we act is yet to be determined, doesn't preclude some consideration around the sectors, right? So that I think, as we talk down the road, to your point, so we're certainly making decisions as we go in the next many months on these issues. Ian.
Yeah, I keep coming back to something you, Rick, said about the goal of this target to shift incentives away from revenue maximization, and I find that very compelling. But we're in this jam because we do have to set a statewide target, but we're setting a statewide target across 3 different markets. Roughly, 16, 17 million people receive coverage through a system that has the benefit of price setting, and 20-some million people get their care through a system that does not. And the strategies for achieving these targets are going to be different across those. I really appreciated the health access letter and that particular point, because it gives me some comfort, looking at those Medi-Cal per beneficiary numbers, which are several $1,000s per year less than the commercial market is spending, and relatively stable compared to the commercial market. How we go about scrutinizing the performance and enforcing performance improvement plans, I think there's a good case to be made to look at those differently and to really focus on the commercial market. But I do think, I mean, obfuscate, talking about age adjustment, whether explicit or implicit in the statewide target, is less transparent. A 3% is a 3%, and I am comforted by the idea that if the Medicare population here, which is much more expensive than your typical commercial population, the strategies for reducing that, there may be much bigger opportunities, as Elizabeth said, for achieving greater cost savings in that market through reorganization of how care is delivered, as compared to the commercial market, where I think rates are going to be a more critical factor.
Go ahead, David.
Yes, thank you. And I just want to return to the last bullet on slide 30, which talks about a proposal to commit to evaluating the target on an annual basis. It may seem like a relatively small item, but I think this is actually a really good proposal. And we may want to consider taking some action at a future point to actually move this to an action rather than simply a proposal, so that we're revisiting this regularly.
I think that comment is in this conversation because it allows us to sort of look at this issue of aging in more detail. I think one point I want to make clear, because I think our process has been robust. We've taken into account a lot of different information from the folks around our table, from the public, from our advisory committee meetings, and it's important to note that today's presentation does raise in a very transparent way that there is a question and an issue around aging, and that this board is going to continue to consider whether it's whichever number you want to choose, how it fits into the sectors, whether there's greater opportunities in Medicare to have innovations and challenge the systems to do more. I think those are all terrific opportunities, and today's presentation notes the importance specifically at looking at aging, both as a driver, but also as a tremendous opportunity to change what we can do as a state, and whether that turns into affordability in California or whether that's just absorbed in a national system that's too big for us to influence is a good question, and something we'll have to sort of work through and towards down the road. Okay, next.
So for reference, this slide includes the office's recommendation from January. And the next slide, as we shared last month, the board can vote to adopt the office's recommendation, or the board can propose another target value or methodology for discussion and ultimate adoption. We covered the other options listed here last month. And in a few slides, I'll present an additional option to the OCA staff recommendation that was crafted based on last month's board discussion of a target phase-in. And then lastly, if action is not taken today, this item will be placed on the May agenda. And next slide. So the first option presented here is OCA's staff recommendation to establish a 3% spending target based on the average annual rate of change in historical median household income from 2002 to 2022 for performance years 2025 through 2029. And on the next slide, the second option shown here is 3% with phase-in, which reflects the board discussion from March. Under this option, the board would establish a base 3% spending target based on the average annual rate of change in historical median household income from 2002 to 2022 for performance year 2029. 0.5% would be added to the 3% base for performance year 2025 and 2026, and 0.2% added to the 3% base in performance year 2027 and 2028. And now I'll turn it over to Chair Galley to facilitate board discussion.
Okay, I think first I just want to thank the staff for the second motion, or the, not motion, but option for the board to consider. I know the staff has its recommendation. I proposed towards the end of the last meeting an alternative, which I appreciate you working on and having available for us to consider. I think that obviously we've had quite a bit of feedback and input and discussion together to get to this point, not to exclude today. Today was very rich as well. I would certainly hope that through the next bit of discussion about these specific options that the board will start now, that my hope is that we'll end in a motion today that we're able to vote on. So with that, open up a conversation among the board. After we conclude that conversation, I'll seek a motion for a recommendation and then hopefully a second, and then we'll move into public comment, of which I expect we'll have quite a bit of good feedback, and then we'll have a chance to consider whether we're in a position to vote or not. So with that, I open it up to all of you to sort of comment on our different options. Ian, go for it.
Yeah, and I'd like to express my gratitude to the staff for going through this history. It is a reminder of just how much work you have done to support us in this last 12 months, especially the last 6 months as we've kicked this around. I'm glad to hear, Secretary Galley, that you're encouraging of a motion today, because I think we have done our due diligence on this question. I personally would like to see the staff's recommendation put to a vote at the appropriate time today. I continue to support it, as I've said before, although I do share, with no surprise to you, Elizabeth's opinion that anything north of 0 is too high, arguably. That's because of the discussion we've had and the presentations we've had from plans and providers. I'm not ideologically opposed to a phase-in or a glide path or whatever we want to call it, but I point out that the way the statute is written, it's been implemented, has given the industry a 6 or 7 year phase-in as it is, from 2022 to when the first enforcement's going to be enacted, circa 2029. And we've been seeing monumental price increases in the last short period of time, which makes me think the industry is taking full advantage of that phase-in. As I mentioned before, the 20 million Californians who don't benefit from Medi-Cal or Medicare or even ACA subsidies, they're on a phase out of the benefit of meaningful insurance coverage, as we've heard. And what's been striking about the public testimony today, 8-10 years ago, it was hospitality workers and janitors and retail workers who are on the front lines of this crisis of affordability and access. But we're hearing more and more from teachers and carpenters and even healthcare workers themselves. And that should be the clarion call to back to Don's point about being very aggressive with, not that you necessarily put it this way, Don, but being really aggressive with our ambitions here in controlling costs. So I do hope we put the 3% 5-year proposal.
Elizabeth, and then to this side. And then Sam.
Thank you, and I appreciate being associated with the position that anything north of 0 is too high. My question, I guess, for you, Dr. Galley, is what is the rationale behind the phase-in?
I think it's responsive. The reason I made the proposal and repeating comments responsive to a lot of the feedback. I mean, we want to be aggressive, as I think we have said, and that aggressive really translates into a major challenge to our healthcare partners to really look at the different strategies that can help us reduce costs and make sure that we set that target. Ultimately, it will be a couple years down the road from when enforcement actually takes place, right? And so it allows us that ability to bring along all of our valued partners. Nobody wants to see, you know, the partnership strained in a way. And I think it allows us to move ultimately and directionally in this really important way towards affordability. And we'll have that opportunity to reassess where we are as we go. So I think it's really responsive to the feedback, paying attention to this sort of monumental moment for California to put this out there and move towards ultimately, right? The target is the same. It just allows us a little bit more of a runway to make sure that some of the strategies that we're employing give the board some time to continue to look at how we're setting other targets that this group will be setting in the months to come, and make sure that that is salient and comes together well. I do want to just lift up Ian's point that we've heard from a lot of people about the affordability challenge that they themselves face, that it's a growing population, and this phase in no way takes away from the ultimate focus and frankly challenge to our systems to pay attention to affordability in a way that they've never necessarily been incentivized to do before. Okay, I know that Richard, you had your hand up.
Yeah. So I have to admit, I have many concerns with both proposals actually. But I guess I would, first of all, I'd make note that so far I haven't heard anyone said we have an excess of people working in healthcare. We know healthcare workers, there's a lot of burnout. We have shortages of nurses. We know that I've been on the picket lines with healthcare workers. I myself am a union member on the front lines. And so, yes, there are opportunities for transformation, but we also know we're going to have to make investments to make those happen. They don't just happen spontaneously. And I think we've also discussed, so whatever target we spend, whether it's 3 or 3.5, what percentage of entities are now going to get referred for performance improvement plans and ongoing, right? And what does it say when, 25, 30, 40, 50, 60% of all the entities are now, over the target? And do we performance improvement plans for all of them? Are we dictating how they operate their businesses, et cetera? I mean, we'll have some discussion later, but what's the implication of a target that frankly is not, that's going to end up landing, high percentage of entities into, basically in excess of the target because it's not realistic, right? And I think that's something we really need to think about. I appreciate, I mean, ideally, if there's a way we can just wave a magic wand and say suddenly, but that's not the case. And by the way, we have housing shortages. I think about all the homelessness that's going on here, right? I realize that people talk about rent control, but we haven't regulated housing costs. Cars are getting more expensive. People drive around. We still haven't, there's a lot of other things that people are spending money on too. And so first of all, I appreciate what Dr. Carl said, right? So I think we're going to have to be revisiting this. We're not going to, just set it and run. I do have concerns about 5 years, but okay, fine, we'll revisit it. I do think it's really important we're transparent, so we put a population adjuster. Now, what happens is that what I mean by that, as I said before, is that fine, if If you want to do a glide path, you do 3.5, you know, population adjusters. So actually what happens is that it's really a 3.1, you add the 0.4, it becomes 3.5, right? And you want to do it that way, but you know, we should figure out what the population change is because there is an increased need. Great if we can provide care to them more efficiently, but the population adjuster is actually to reflect the fact that there's going to be greater needs, right? The number we eventually pick and how far down we want to drive it, right? So by the way, doing a population adjuster doesn't mean that you can't set a really low growth rate. It just means you acknowledge the fact that you have an aging population, and inherently, at least no innovation I've seen has decreased the healthcare needs of of an aging population. All right. Now, certain social determinants of health issues we could address perhaps can mitigate some of that, but I have not seen anybody demonstrate that an aging group of people don't have increasing healthcare needs. Maybe not as rapidly as before, depending on whatever types of public health measures we do. So we need to acknowledge that, right? That the adjuster acknowledges that. And so I think we definitely need to have a population adjuster. We can build it in a way that doesn't necessarily, you know, if you want to land on a certain number, fine. But we should definitely explicitly have a population adjuster in there. I think that's really important. I think that gives credibility to what we're trying to do. And especially if we're going to do 5 years, right? 1 year, maybe not so important. 5 years, definitely we have an aging population. And it turns out, by the way, if our population changes, then the adjuster goes the other way, right? But I think most of us, you know, are looking at looking at projections, and that's probably not unlikely to happen. So I think that's really important. I think, you know, the glide path basically I think is an acknowledgement that we just, you know, how many entities do we want that just, you know, that are going to exceed those targets. And then I think, you know, again, I am curious as to we have the different sectors pay, you know, then we have the Medicare, the Medicaid, the commercial, and exactly how that's going to really play out, right? Because this target, people want to say statewide spending target, so it's really 3%. So, but we're going to allow, is Medicaid going to be 5 or 4%? All right. And then that means everyone else has to go down. You know, Medicare, of course, the federal program. So exactly how does that get applied? What message are we really sending to people about when we say it's 3 or whatever it is, 3.5, 3 or whatever the number it is? So, but fundamentally, I want to see a population adjuster because I think it acknowledges the fact that we have an aging population. Now, by the way, again, population adjusters can go either way. All right. So if the population starts somehow getting younger here in California, right, then will go, you know, it'll either drop or even go, you know, et cetera. So, but I think that's just an acknowledgement of the reality of what we're dealing with. And so saying that we shouldn't have that, and I agree that I was disappointed when there was a comment that, oh, it's small. Well, at least you acknowledge that it's important. You just don't think it's important enough because you think it's small. Well, if it's small, then still put it in there. Then what's the big deal? Because that's reality. So I definitely want to see a population adjuster in there. It doesn't have to be on top of the number, but it should be explicitly put into the number for the second, third, fourth, fifth year if we're deciding on a 4-year, on a 5-year thing. I'll be happy for a shorter period, but that's not, at least unless someone else in this group wants to do that. If that sounds like it's going to happen, then at least you put a population adjuster for throughout the 2, 3, 4, 5. Thank you.
David next.
Well, thank you. And I just wanted to reflect on where we are versus where we were. You know, we've been doing this for over a year now, and we've finally gotten to the auspicious point that we're ready to take a vote. I just want to recognize staff for the great work, you know, really sophisticated analysis that has gone into this, some of the consultants that informed the board as well. I also want to recognize our legislative leadership who you know, have the vision to introduce this and bring us to this point. I'm noting that California, as has been said, is bigger than all the other states with spending targets essentially put together. So whatever we do here is going to have a major impact on the rest of the country. I note that that simply setting a target is an accomplishment in and of itself. I think that there's a lot of attractiveness to the glide path approach. I can understand the rationale for it. But I also reflect on the fact that for each increment in that glide path, there are individuals who continue to suffer the effects of increasing healthcare cost. And I think, literally, we're talking about things like, medical bankruptcies, and we've heard the public testify very significantly about the impact of healthcare cost. So this is it's not an easy decision. I think the board has been appropriately modest in how it's gone about arriving at this point. And I think that there are benefits in either direction. But I want to recognize that we've heard from the public who are actually on the personally being penalized by healthcare costs that are increasing excessively in the state of California.
Thanks, David. Sandra?
Yeah, I'll add to my appreciation of staff, not just in the analytic component, but also in their attempt to summarize the tremendously robust amount of input that all kinds of stakeholders, and in particular consumers, have given to this board over the last many months that we've been deliberating on this. I think that the sector analysis will actually be very important, and we're making this decision in advance of that. So just to acknowledge that that is something that we will also be doing, because I think we don't yet know how the intersection between the sectors will actually play out. I think on the sheer content of these motions, the attractiveness for me a bit with the phase-in approach is that it allows us over the next 2 years, when we're looking at a 3.5%, to learn a tremendous amount that we don't yet know. One of the, a lot of people talk about the implications to plans or hospitals or our delivery system of not meeting a target as it being punitive. But I think one of the beauties of the way that this was designed is that we will start with a tremendous amount of transparency that we do not have today. And I think there's enormous power in transparency, because I think there's tremendous examples of innovation in places where folks are really trying to improve outcomes and reduce costs. And so the transparency component to this, I think, is going to be incredibly powerful. And that is before any performance plan, and it's certainly before any penalties. So the beauty that I think lies in this phase-in approach is the ability to get transparency, the ability to understand how these sectors interplay, and still aim for what I think is aggressive at 3% spending target as our goal overall. So in the spirit of learning more, and as Dr. Carlisle said, we're going to look at this every year. I could get behind a phase-in approach, recognizing that the costs, CHCF did an enormous poll. We talked to Californians periodically, and the cost of health care and their access to care is very much top of mind for Californians. And so I think it's important for us to be aggressive, to take a long view, and to recognize we will learn a tremendous amount in the first year or two of this sort of phased-in approach.
Elizabeth, I saw your hand up, and then we'll come to you.
Thank you. One of the things that I want to make sure we do is thank the members of the public who have come here, taken days off from work, and told very difficult personal stories about the real life impacts of the affordability crisis, because I just want to make sure that that is the audience we are truly oriented to, because they're the ones suffering the consequences of inaction. And one of the things that I guess I'm so surprised by is, despite these incredible, effective stories from the people that our industry is supposed to serve, there continues to be such intense resistance to meeting those needs. To me, that's just quite stunning. And I'm thankful that we have had this forum to sort of see these dynamics play out in real time, because hopefully there will be an impact on the industry and they will take it upon themselves to lead towards affordability. Frankly, the fact that we even need government intervention to me is disappointing, but it actually also explains why we just did a survey a couple years ago with the Kaiser Family Foundation, and over 85% of C-suite executives in for-profit corporations want more government intervention because the lack of responsiveness, because we are not addressing affordability, access, and quality. So here we are. We have that opportunity. We have a forum to do that. I think everybody knows I've been very clear that even a 3% target does not make care more affordable. Even if we're successful, in 5 years, that's 15% higher costs. That said, I am very supportive of this direction. And frankly, what I'm excited to see is, on behalf of our members, large employers and purchasers, we are seeing innovative industry partners step up, say, we'd love to beat that target. We'll do 0%, sign us up today. So I think there is a healthy competition now that it is so clear how important this is to the people paying for care. So I will be inclined to sort of support the direction that we take, knowing that this is a backstop. This is, worst case scenario, because there are partners in the industry who want to make this change, and we're excited to work with them. And frankly, I literally just looked up U.S. compared to every other developed country on healthcare spending, because I knew it, but I just wanted to check. They do all of what we do better for half the cost. There is no reason we cannot be successful here. I spent 5 years at the London School of Economics doing comparative health policy studies. It is doable to get better outcomes, longer life, better access, better experience for way less than we are spending now. So I remain very confident in the leadership and ingenuity of our industry, and I feel very comfortable that we can get there. But obviously, I hope for a more ambitious target, but I am supportive of whatever steps we can take.
Thanks, Elizabeth. Rick?
Thank you. I add my thanks to the staff for getting us here, having been staff for efforts that were some successful and some not. I am quite appreciative of how difficult it is to herd an unruly set of cats. I am also, not comfortable, completely comfortable with either of these recommendations. I think it will be no surprise given my previous comments, but would be supportive of the glide path recommendation. I continue to think that our main challenge is establishing the legitimacy of the efforts of the office and the board, and maintaining that legitimacy over the next 6 to 8 years, as was mentioned. The first enforcement will not be probably till 2030, 2031. We'll likely be facing different legislature, different governor, and to maintain that legitimacy, I do think that we need to be establishing targets that some reasonable fraction of the industry will meet. And Elizabeth, I appreciate your comments. You said this was sort of a worst case scenario that looked better. I would disagree and think this is probably a best case scenario, and that most folks will do worse. I mean, we've been doing worse for decades, and the existence of this statute, and I add my thanks to the legislative leaders who enact this, provide the opportunity to change that path that we've been on for decades. But it is an opportunity that is tenuous, and I think we will need to be seen as legitimate and credible. I think the glide path is closer to that, although to Richard Pan's, Dr. Pan's earlier points, I think being transparent about what we're expecting is also an important part of establishing that legitimacy moving forward. I said this close, I think last month. I'm sure we've all seen the dashboards of hospitals and health systems, and for most of those dashboards, the arrows are green when admissions and ED visits are above the previous year level, and the arrows are red when admissions and ED visits are below. And a kind of fundamental challenge is getting the people who design those dashboards and to manage those health systems to think about that differently. And to do that, I think, that people need to be convinced that if they don't make whatever target we set, that there will be serious consequences. And if I don't know how we can accomplish that. The statute makes it seem like there'll be serious consequences, but if nobody makes the targets, then it may be hard to actually enforce. Although, as has been pointed out, if some people are going 70 in a 65-mile zone and other people are going 100, maybe you enforce against the 100, and that may be, where we are here. So I appreciate Secretary Galley, your suggestion of motion 2 and or option 2, and of the 2 options on the table, that is certainly the one that I prefer.
Go ahead, Richard, and then Don.
So a question for staff. So if we had a population adjuster, I know you made some comment about it, and we've been talking about it for a while. What would it be? So population adjuster, by the way, is just simply saying, okay, the population is this distribution of this right now, and next year it will be, and people are a little older, right? So the percentage isn't even increase in healthcare spend, right? Because it's like just what's the shift in the population. So if the aging population is aging, then it should be adjusted by that amount. So what is the shift in population that's going to happen each year over the next 5 years? Demographic question.
That if you have the answer, respond. Otherwise, we obviously can come back to it. But I think it's.
Yeah, we don't have a valid method to estimate a population-based adjustment.
Wait. Don't say you don't have a valid method. Just say you don't have the information right now. That we have methodologies to figure out. I mean, Department of Finance does it all the time. Okay.
DOF has that. We can access that.
Okay.
If we don't have it now, we'll.
That's fine. Just don't tell me there isn't a methodology. Just say I don't have it right now. My fingertips. That's fine. So okay.
And in presentations not related to OCA, whether it was the master plan on aging or other things,
right.
We've shown those publicly and can update them and see where they are today.
Yes, I've even held a hearing on age, where we had presentations about the demographic change in California. So, so if we can get that number, I think again, to me, it's fundamental that we have a population adjuster, right? That doesn't necessarily affect the endpoint. So for example, if it's 0.4, you can do a 3.5, 3.1 if you were doing a glide path, whatever, 3.5, 2.8, 2.6, right, and still land at the same place. But I think we need to acknowledge that. I appreciate what Dr. Kroenig said. If without credibility, the work that we did, and I'm proud to have worked on this legislation. I appreciate that Assemblymember Wood is here as well. So because both of us worked on this legislation, as well as, of course, the administration, that if this work's going to be sustainable, it has to have credibility amongst all the various interested parties. And by the way, as a physician, I look at people in the eyes directly when it comes to, I'm not standing in a distance, and trying to get them care. And I certainly understand, and I've seen firsthand, not only as a public servant, but also as a provider, as a physician, the challenges that affordability presents to families. And I've heard also in the public comment as well. And what I hear is that, of course, people are, cost is a barrier to care, but ultimately they want the care. And if we drive away the care, so it's not even available at any cost, that is an outcome that I think is unacceptable to them, and it should be an outcome that's unacceptable to us. So it's important we do this right. It's important that people have confidence in what we do. Otherwise, they'll try to upend this in the future. I'm out now. I know Assemblyman Wood's leaving the legislature. The work that we did, if it's going to sustain itself, people have to have confidence in it. They may not always agree. That happens all the time. But if they're like, hey, there's really obvious things that you're not being clear about, you're not being transparent about, like an aging population, that just becomes another argument to say that this is not working. And if we have a whole bunch of people who are way over the target, right, and then that starts raising questions, and then it depends on how we do enforcement, right, and so forth. So I think we need to recognize this, that and whatever, and frankly, and again, back to the enforcement part, right? So we don't want to set people's expectations that, oh, we picked a number and that's what it's going to be next year. I mean, I realize I hear a lot of people hoping that, but we also have to know that if we pick a number that doesn't really work well, isn't realistic, that's not going to happen. And there are going to be a lot of disappointed people in us.
I think a few responses to some of the comments and welcome more from board members before we move to public comment, but I'm going to just reiterate the thanks to the staff and to all of you, frankly, for your commitment to this work, coming to the meetings, digging in, helping us do get the committee meetings set up, and just the value of all of your input to get us to this point. I want to appreciate Dr. Wood as well. It's been a long journey, and your leadership was should be acknowledged to get to this point. I'm grateful that you're here today in the event that we do end up voting on one of these or a different option that emerges. I will say, as somebody who, like you, Dr. Pan, has spent time, frankly, almost every patient I've had the privilege of taking care of doesn't end up paying for their care directly, right? They're Medicaid beneficiaries, but we've spent so much time over the past decade thinking, moving into now a very consistent dialogue about health-related social needs. And I think some of the conversation in the public testimony makes me wonder, and to the point of healthcare providers themselves struggling with the affordability, how do we incorporate affordability of the product that you say needs to be accessible as a health-related social need, right? And the cost of it. And today's vote really moves us to acknowledge that that pressure, that challenge to our healthcare delivery partners to pay attention to that piece more closely, more thoughtfully, whether it's get as close to zero or below as possible, should be seen as a way to advance health. I think the access, the quality, equity, all of those issues were part of the legislation for a reason. We were not meant to dismiss them at the expense of the lowest cost thing we can find. But I think just our sophistication in the last decade has really stepped up and come up. And wherever we land, I think it's an important challenge. And I use that word repeatedly because I'm not sure that we've had that same level of challenge on our systems to pay attention to this piece as much as the direction we're moving in today. And that in itself is important. I think the expectation that people will step up and achieve versus the expectation that maybe some won't and they won't hit the target really is an opinion at this point. We have some data that shows both sides, and today, and this work of us moving forward is going to be to monitor that, to check that, and make adjustments as appropriate, whether it's because we didn't fully account for population or something else. This board, to David, your point, we're going to have a chance on an annual basis and more frequently if we so wanted to understand how we pivot or how we make some changes. And today's decision, I think, is monumental because it sets us down that path. So I just, I close by saying, I think it is such an important day and such an important moment. And it gives us a chance to do what California has, at least in my time in leadership in California, tried to do, is lean in on something that's maybe a little different than what the rest of the nation is doing, adding penalties and some enforcement actions of meaning, I think is really going to be important to this process. And whether you believe we're starting in a realistic or unrealistic place, or we're not being aggressive enough, this is a starting point that I think is important to get us down the path towards. Don, I was saving my comments as the last, but then I remembered midway that I failed to bring you in. So please, well, please no, jump in. Yeah.
A couple of things. So first, I just want to remind folks that that high healthcare costs hurt health, and one of the things that we're here to do is to lean into the health of California. And just as a reminder, there are a lot of different ways. One way in which high healthcare costs hurt health is people don't seek healthcare when it is prohibitively expensive. We see that in literature. I see it at CalPERS when we look at our PPO and the cadence over the course of the year as people access health. They are very reluctant to access. I'm just leaning back. It's on, but I'll.
It's the mic's fault.
I'll even scoot up in my chair. How about that? But we see that at CalPERS. People are very reluctant to access healthcare early in the year when they're facing all of their cost sharing, and they put off their care towards the end of the year when those barriers are less. That's a real problem, and it's going to continue until we're aggressively lowering healthcare costs. The other one, which we talk about a lot less in this room, that I think is important, is that when we're spending 18-19% of GDP on healthcare, we're not spending, investing, I should say, the dollars that we need to be in housing, in social services, in education, all of which contribute, and Dr. Galley, you know this because you've leaned into this in California, but all of which are healthcare affirming. So in countries that are at 12%, they're making those investments in ways we just aren't here. So I just want to keep that front and center as we have this conversation about how aggressively or not we're addressing this challenge. So that's one sort of separate track. I want to express my support for a phase-in, and I want to do that primarily because I think, you know, I spoke early on in this about the importance of being aggressive and looking at this as a North Star, and I still see it that way. 3% is an aggressive target. But I take Rick's points to heart, and I think we do need to thread a needle here and identify something that is conceivably achievable. I think the threat, if we miss a lot, is very real. As I start to have conversations, as we start to have conversations with our carriers at CalPERS about how they are going to meet these targets, there are sort of two buckets of reactions. One is to look at the watch or the shoes, which is not uncommon, and the other one is to start talking about how you do it over time. And doing it over time is much more likely to result, I think, in the kinds of investments that we've been talking about here, fixes for addressing the high healthcare costs associated with the end of life, other more thoughtful approaches. This creates something of a ramp so that we can be having those conversations. So I think, and it also just, it is not universally rejected as within the realm of the possible. So I do think we're getting closer to something that's achievable. I certainly think that we're going to see variation across the industry, but we knew that, and there are always going to be folks who say no, and who you're going to have to drag forward. And part of setting an aggressive goal is working with the folks who you think can get there, and putting added pressure on the folks who are reluctant to make changes. So.
This is so important. I'm going to make sure that we have any other comments. Go ahead, Richard.
A procedural question, because technically what you did is you presented two different options. If we want to make a modification, at what point would we do that?
So go ahead. Why don't you jump? Just tell us procedurally how to do this.
Once a motion is made, you can propose an amendment. If it's a friendly amendment, there doesn't need to be debate on it. If it's an unfriendly amendment or the body wants to debate it because the standard is more discussion, then it can be discussed.
Okay. Well, who would decide whether it's friendly or not? I mean,
the maker of the motion.
Okay. Well, the maker of the staff motion is the staff who doesn't actually can't make the motion, right? It's so okay.
So what I will say, if it is fair, and tell me if this is procedurally problematic, if a motion is made and seconded, we will have a chance. I mean, this is so important that if the board, any board member wants to make the recommendation around an amendment, we will have a conversation about that amendment. We are going to try to move forward together, because that, I think, is not just symbolic, but very important that everybody, as you come back to the next many meetings, that we have that confidence in our process. So friendly or unfriendly, I won't even try to imagine that. I'm going to.
We probably shouldn't get away from friendly or unfriendly. And
we will create the space to have
a discussion.
The appropriate conversation.
Thank you.
So it won't be a surprise that I'm going to take a stab at making what has, actually, we invite a motion. Before we vote, we will take public comment. That's certainly the way that we do it.
Okay, so
yeah.
Sorry, I'm getting another procedural question.
Okay.
So amendments would be proposed before or after public comment?
We didn't, but that's the beauty of public process, right? Open meetings and public process, which is great. So the answer is that we will take amendments before public comment. So, okay, any other procedural questions? Yes, Richard, no, go. We should spend the time doing it.
So I appreciate that, we want the public to hear. So are we just going to take the amendments and then hear public comment and then discuss and then vote, or we're going to take amendments, discuss? Obviously, well, I presume we're not voting on any of the amendments until after the public comment, because we'd like to hear the public comment before we actually cast any votes on anything, right? So I just want to clarify exactly what the process will be in terms of, so you have a main motion, you have an amendment that's proposed. We obviously can't close out the amendment until we have a vote. But I presume you want public comment before we actually vote, because otherwise it's sort of an afterthought in the public comment. So would we just be taking amendments? So we have accumulation of amendments. These are the amendments we'll be considering, and people can comment on those in public comment.
So I'm going to just reflect what I imagine is the right approach here, and correct me if I'm wrong. A motion would be made. It could be seconded. We would have amendments. We would adopt or not adopt the motion altogether, the amendments into what we would ultimately vote on, but we would have that all come together before public comment, so that ultimately what we're voting on is an amended or not amended motion. So we would have that discussion together as to whether.
And that the public gets to give input on that, on that motion, amended or otherwise.
Right.
Okay, so the public doesn't get to comment on the amendments before. Basically, they only can comment on the final motion before we vote on as amended or not amended.
Well, we're in no position to tell the public what they can comment on. They should comment on
That's right.
all of the above.
They can comment on it, but it's after the fact on the amendments, unless so. On the amendment itself, obviously, we would have either amended or not amended it beforehand.
Right. We won't vote on anything until after public comment, and the public will have a chance to hear both a motion and with or without an amendment. Ultimately, what we settle on, saying this is what we plan to vote on after public comment.
There seems to be a little contradiction here. What you previously said is that we would actually decide on what the final form of the motion would be and then take public comment and then vote on that as or not amended. Now you're saying that actually we take amendments, we take public comment, and then we decide on the amendments and then the final motion?
No.
Yeah,
please go ahead.
Yeah, so, please, thank you.
The process is just like when you're the chair of a health committee. The proposal is laid before the committee. You can have a member say, I suggest we change this word to that word. And then you have somebody second that proposal. And then there's a public discussion. Once the public's had a chance to discuss and give us input, because they can talk on any item we've discussed, and they will have all the information they need on the proposed amendment. Now, if you were to propose amendment and you did not get a second, then we would just fall straight back to the original proposal. We're just giving the public a chance to understand what the board is considering at that point for a vote.
So to clarify, so someone makes an amendment, let's say it gets a second, do we vote on it first?
No.
No, okay.
Because then you would be voting before you have public comment.
Okay, so then that amendment just sort of sits on the table until after the public comment.
Yes.
And then it would be considered by the board.
Then it would be considered by the board.
Okay. All right, just wanted to clarify.
Yep.
So, okay.
Other procedural questions? Seeing none. Okay. We'll say start again. It won't surprise any of you that I would like to make a motion that we consider a 3% cost target with a glide path as presented by the board, starting at 3.5% for 2 years, down to 3.2% for the next 2 years, and then the fifth year, a flat 3.0%, with as is presented here on the slide.
I'll second that motion.
Now, as we talked about, any amendments or comments before we go to public comment? Go ahead.
So I would propose an amendment where actually the end number doesn't change, but that we incorporate a population adjuster. So therefore, I guess and realize that's why I asked the question of staff, what that would be. They had made some mention earlier today that probably around 0.4. I'm just kind of looking at you, be sure that don't vote, I won't hold you to that. So, but I heard anything from 0.4 to 0.6, but let's say it's 0.4 because it seemed like staff said it was going to be smaller. So that basically we would have a 3.5. We do a population adjuster plus the base. So the base would then drop down to 3.1 plus a 0.4. That would get you 3.5. Go down to a 2.8. Right, that would get you to 3.2. So exactly the same glide path, but we would actually, for full transparency, incorporate a population adjustment into the end result, so that we have a population adjustment that's built in and that's explicit in that. So I think it's important for people to know what we're asking and how that sits in the context of the fact that we do have an aging population.
Go ahead, David.
Another perspective on the population adjustment proposed by my colleague to the left here. I've actually spoken in favor of such an adjustment previously in meetings, but I'm recognizing the complexity of arriving at it at this point in the process, knowing that we're approaching a deadline that's statutorily mandated. My suggestion might be to maybe procedurally decouple the consideration of the adjustment and come back to it so we can look at it in great detail, whether it's aging or some other measure. I'm not sure what an appropriate number is right now. Not sure how to add it in right now. Not really ready to talk about that, although I think that it is germane to the discussion. I propose that we move forward with the original motion and then come back to consider how to apply a population adjuster if the board feels it's appropriate subsequently.
I want to, before coming back to you, see if there's any other comments from board members. Rick?
Yeah, I guess, David, if I understood your comments, they would be that if we were to eventually adopt a population adjustment, that it might actually change the spending targets. And I think that what Richard was suggesting was leaving the spending targets in place, but simply changing the way we describe them. That, if I understood your suggestion, Richard, that we would establish a base 2.5% spending target with a 0.5% population adjustment, or if we're not ready today to say that it's 0.5, that we're establishing a 3 minus point X population adjustment with the point X to be determined, which is a little bit odd. I think, David, did I understand you that your remarks might, if we eventually were to adopt a population adjustment, they might affect the actual spending targets?
I think hypothetically the answer is yes.
Yeah.
And I guess the point is, I'm not sure. And if I'm not sure, I'm not ready to go down that pathway.
Go ahead, Richard.
First of all, I would point out the deadline's June 1st, so we still have one more meeting before then. Also, we've been talking about population adjusting for over a year, as presented by staff. So it's not that this is a new topic that shouldn't have been investigated by the staff. In fact, we've been presented with fairly compelling evidence that the aging population does have greater needs and, as a result, greater costs. And while certainly people may develop efficiencies in the future, those needs are still there, right? So I do think in terms of transparency, and I appreciate the previous comments from Kronik, and I appreciate, Carlisle, your previous comments. I don't think this is unmanageable. And I think that it's an important reflection of the work that we're doing, and to build confidence that we are taking account of factors that this is not a factor that people would say, well, we don't think that aging actually increases healthcare needs. I mean, I think that's very little in dispute, and that should be a factor taken into account. So if we can't immediately do it today, we still have another month on a topic that we've been discussing for over a year. So we should be able to come up with a projection for that number at some point in time. I guess we could also try to engineer it reverse, where you say it's X and we'll figure out what X will be if it takes more than a month. But I do think, if we're going to talk about a 5-year run, which I do have concerns about, then I think that's going to be important that we explicitly build in a population adjustment that's explicit into what we're approving, and that's part of the part of the proposal.
Thank you. Other comments?
This is actually a question. So Dr. Pan, are you saying you're not suggesting any changes to 3.5, 3.5, 3.2, 3.2, 3.0? So we could theoretically vote on that. There's no proposed amendments to that. It's then sort of how we talk about the methodology.
How we talk about it's really important. Process is important, and so actually go to the point Dr. Carlisle says. I'm not just throwing that number out because I'm trying to get it. Frankly, a population adjuster reflects that change in population. And guess what? If the population portion changes, then the adjustment changes because of that as well, right? I mean, it's just the fundamental recognition that that an aging population, and guess what? If the population doesn't age as quickly, or even, who knows, we don't usually have huge demographic shifts of that nature in 5 years, but if there's a large demographic change, then that should be reflected. If there is a decreased need for healthcare, then fine, we should be spending less, right? Because of the population. And if we have innovations on top of that, then even less, right? So the purpose of a population adjuster is not a way to say, well, let's figure out how I can put something in to make us spend more. It's a reflection of the actual need in the population, right? And so that's what I'm saying. I want to see a population adjuster put in. And guess what? If the population changes in a way that works in the favor of less healthcare needs, then great, target goes down. That's what should happen, right? That's why I want a population adjuster. I don't, it's not about picking a number and saying this, et cetera. It's also saying that these are factors that we want built into our thing, so that if those changes happen, that we will adjust for that, because so anyway, I think I made my point. Thank you.
Elizabeth, I'm sorry, Mark. I think your point is exactly what I was suggesting, that we can move forward with the motion and then revisit this question, which is really important, actually, subsequently, and it could be next month even.
And just to punctuate it, I think, I don't want to put words in your mouth, but you're both suggesting that doesn't impede to your worry, Richard, about transparency, that allows that to still have broad implications or considerations for what we might be thinking about in months and years to come.
That was my assumption.
Yeah.
If it's the same numbers, we can, all of these meetings are public and transparent. We could talk about it at a later date.
I want to make sure that if that was your intent with your comment, that's made clear. Okay, Rick and then Sandra.
So, sort of minor wordsmithing, and maybe this is so clear to everybody that it's not needed, but it would make more sense to me to establish a base 3% per person spending target. Maybe that's clear, but 3% could be interpreted as 3% aggregate. And then more substantively, it would make more sense to me, and this is picking up on what Richard was saying, to establish a 2.5% per age standardized person spending target. We would then need some definition of what does an age standardized person mean. But with a 2.5% target per age standardized person, we would be at these numbers or something close to it. And that's, back to sort of transparency and clarity about what we're doing here.
Okay, I want Sandra, I know you were next. I don't know if there hands shot up in maybe to engage with Rick a little bit, if those were the comments, Ian or Elizabeth, if that was the vein. Otherwise, I'll go to Sandra first. Okay, let's wait on that. Ian, wasn't sure if you were responding to.
Yeah, this may be moot if I haven't heard any seconds, but I do disagree about the point about transparency. When I go back home tonight, I'm going to have to explain to some people, you know, what did we vote on? Are we aiming to have health costs go up by 3.5% next year? And to explain, no, well, it's 2.5%, but they've added on a percent for, you know, in the population, in the funds that I'm associated with, there hasn't been aging. And then I'm going to have to explain why, no, the target for that population is 3.5%, but really it's not, it's 2.5%. It really, that makes little sense to me. This is crystal clear to me. How much more, understanding per capita, are we spending 3.5% more per person, and regardless of age? That's pretty direct.
Can I respond directly? Yeah. So I hear you, but you're going to have to explain to them why, even though the statewide target is 3.5%, the target for your fund is 3%. Because if your fund makes 3.5% and Medicare makes 3.5% and Medi-Cal makes 3.5%, the statewide is going to come in at 4%. The weighted average of these 3.5% things is going to be 4%. And so it's, you know, it's not an easy thing to explain either way. Right?
I did admit in a previous meeting that math was not my strongest.
I would dispute that. You seem very proficient. Ian, Sandra, go ahead.
So, Dr. Pan, if I understand what you're trying to get at, you're willing to support the numbers that are in the motion that's on the floor. What you want is an acknowledgement by the board that our population in California is aging. Your point as a clinician, which I wouldn't disagree with, in general, as people age, they need more health care. And the way we provide care today is hardly optimal from an outcomes point of view for the very population that we care about. And so I think if we're willing to stipulate to those things, we're mostly in agreement as a board. Because you're agreeing to these numbers, as I heard your motion.
So,
Yeah, please, respond.
So basically, I think it's important we reflect. So the thing is that to me, it's not just a number, it's the process. It's also how we reflect what that number represents. And that's why I made my motion. So yes, in the end, you're saying, well, you know what, the numbers are the same, right? At the end, when it comes to your explanation. But I think also part of the explanation is that we also recognize that people are getting older, and therefore as the population gets older, what we're really asking people to do is actually, at that point, even cut even further, because as the population is getting older, it's going out. Now, interesting enough, by the way, if we're really, saying that this is what should happen, right? We should have a lower, right? We should be tanking down at 2.5, 2.6, et cetera, down. Then what happens is, and then, again, if the population shifts, that population adjuster will shift too. But I'm not sure why, if we really believe in our baseline thing, then why wouldn't we stick to that as well? So I do think that the reason for the population adjuster is that we have to acknowledge that there's going to be greater needs of that population than so therefore you take that off the edge and right, but we acknowledge that because we're still going to need, and then what we have to work with is what's left, and I think it's important to be explicit about that. So that's why I am not in agreement with simply just presenting a set of percentages. Although you're right, in the end, the numbers is not just a number. It's also I want the adjustment to be clear. So therefore, we would say this is what we're saying. This is the population adjuster. This is what the actual target is. This is after population adjuster. We land on a number, and that number, I'm fine with it. Basically saying that, okay, the number we land on is the number that is being proposed for the glide path. So I don't want to just vote for the glide path number.
Sandra, I'm not sure that completely answers your question.
No, I was just trying to,
Yeah.
I was trying to address the concept
Yeah.
that Dr. Pan has raised and that we have talked about in terms of what our opportunities are. I have a hard time imagining our population getting younger. I'll just stipulate to that as well. But I was mainly saying we as the board have actually talked about the population adjuster. We've had it on our agenda. We've looked at the numbers. We have talked about it. So I feel like in the due diligence of coming to a decision, we have these numbers that have been proposed on the glide path. And it acknowledges a robust conversation that we've had, which you've been a champion of and I think have articulated quite well, as we have as well, saying we have a lot of elderly people who can't use their coverage now. And so affordability is important to the population that you're addressing, and I think all of us share that opinion. And so that was really what I was trying to get at in my remarks.
No, I appreciate that. I think, but I'd like to see it explicitly. I mean, we've talked about a lot of adjusters, and people said don't do this one, but I mean, population is so fundamental, and there's there's less gamesmanship, right? People complain about gamesmanship of risk adjusting and so forth, which I don't entirely, I certainly opportunities for, but there's ways you do it. We will have an equity adjuster that's in the statute, right? That we haven't talked much about, but probably going to be more applicable when we start talking about sectors and other types of things, and also perhaps when we do enforcement as well. But population is, is less subject to manipulation, right? I mean, we have demographic data, we have it from the census, DOF does it, et cetera, and so we can put that in there. I don't, hopefully no one's concerned about manipulation in relation to an age adjuster, right? We have pretty, public sound data projections are usually pretty good, at least so far I've seen, right? So, and it does affect the need for healthcare.
I don't think your question, Sandra, is inconsistent with what you're saying, frankly. I think the acknowledgement is what I hear from you, Richard, is your suggestion is we just need to explicitly acknowledge the role of an aging population in this motion somehow. Okay. Yes. Hearing that, Elizabeth, did you had a procedural question? Before you go with your procedural question, sorry, Rick, you brought up the per capita piece, the team. Do you want to just clearly state what the statute says on this point so that we could, it is hopefully seen as implicit, but we can add it.
The target, the definition of cost target in the statute is about per capita spending.
I mean, if the board wishes to clarify that, you could certainly add it to the motion. We just wanted to clarify that it is in the statute.
Yeah. All right, Elizabeth, go for it.
I was just trying to understand if and when we were going to vote on the amendment, and I would put out as maybe a competing amendment that we don't have a population adjuster, because I think given the data that we're going to have and our commitment to reviewing progress and impact and understanding how it's affecting all the populations, we will have plenty of opportunity to see that throughout the work.
So just to be clear, Richard Pan has put an amendment out. It hasn't been seconded. So we've had a lot of discussion. Obviously, any board member could second, and then we would consider that vote. And then, if I understand procedurally, if that weren't to pass, we would be able to vote on the unamended or the original motion. After public comment. No vote is being taken yet.
What is the wording of the motion that you're proposing that would be voted on?
So basically, it would be that the amendment would be that we would see, establish faith with meeting historical performance. Well, frankly, performance here, I would say is that would basically say that we would incorporate I would amend this to say that we would adjust the per capita spending growth target proposed by reducing it by a population adjuster and then adding the population adjuster to it, adjustment to it. So essentially you end up with a similar number. I mean, I was not given the opportunity
you're put
to,
it on the
in
spot.
fact,
Yeah.
yeah, so to actually draft specific language. In fact, we had a little break. I could sit down and try to actually draft something more specific, but I think hopefully the intent is pretty clear. And if we don't know what that adjustment number actually is, I will, as much as I hate delay things, we do have one more meeting. If the staff needs to do some work to tell us what the official population adjustment would be. I said we've been talking about it for over a year. I did ask the question. I certainly understand why staff would not necessarily have it at their fingertips immediately, but hopefully that's pretty accessible. And then we'd have a more specific motion that would actually have the number. So I want to be sure I could come up with a number myself, but I think that, again, I think it should have a number coming up from staff, not from individual board members.
Okay.
It seems like it would, in some ways be more confusing, but in some ways be helpful to be clear that that's what we're voting on. And Ian, to your earlier point, when I said, if commercial goes up at 3% and Medicare goes up at 3% and Medi-Cal goes up 3%, statewide will go up at 3.5%. And you pulled the Sam Irvin, odd shucks, I'm just a country lawyer. They are going to go up at 3.5%, and I think I know that your math is good enough to understand that. That is that the changing share of people in Medicare and the fact that Medicare spending per person is so much higher than commercial or Medi-Cal means that each of these things go up at 3, statewide goes up at 3.5. And I think that, the sort of rationale for 3 is we want this to be affordable for employed for all of us, and we're trying to peg this to median income. We discussed earlier, I think it's actually already a point below what median household income growth is likely to be, and it doesn't get to 0, but it's -1. It's really -1.5, which may also be good, but at least we should be explicit about that and take credit.
Other Elizabeth and then Richard.
Is there a motion now that we are voting on that?
Well, there, I think Richard articulated one. I have not an amendment to my original motion, which has been seconded, right? I'll let you go next, but as it's been stated, we don't have a seconded amendment, and we need that. So go ahead, Richard.
So actually, Dr. Kronik, can you repeat your proposed amendment for me again?
Establish a base 2.5% per person spending target. And then no change based on the average annual rate of change in historical median, blah, 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 for performance year 2029, comma, minus 0.5%. As we get to the 2.5% spending target based on historical median income minus 0.5%. And then add to that 2.5% per person spending target an adjustment for the aging of the population.
Okay, and then
leaving in
the other
add
part.
0.5% to the 2% base.
So to help move the discussion along, I will second that. All right. No, he made a motion. I can't second.
Your amendment is still on?
So that has to be a formal amendment.
Well, I'm happy to substitute. I think you just heard a second to a proposal.
So, it's
I
fair
can
to say
withdraw my
you're withdrawing.
motion. Okay, I'll withdraw my motion. I'll second.
So the only amendment on the floor is the one that Rick laid out.
So then I will
Are you
second
moving
Rick's.
that, Rick? We just need to understand if you're formally moving an amendment.
Yes, I am moving that.
Okay, then I will second that amendment.
I think that's a question for, I don't want to speak for Rick who made that. Well, why don't you, did you write down what you were hearing from Rick? I certainly did. So let's go ahead and maybe, you have it written down. Yes. Could we put it up? Again, to assure everyone watching this, listening, that we have not figured this out ahead of time for sure.
Actually, plus a minus 0.5, and then it was plus a population adjustment. So that was after the minus 0.5. Okay, yeah, they add, actually it wasn't 2.5%. That's too high.
I'm sorry, Megan.
Last sentence.
No.
Was not changed. You're editing the wrong sentence.
Sure, I can. Just for people online, we are, as you've all heard, a lot of really rich discussion and an amendment that has been seconded to make sure that we have a motion with an amendment that would be considered. And just to remind everyone and make sure I understand it, if after, well, we will move next to public comment and we will power through public comment. Thank you for everyone's patience. And then we will vote on the motion with the amendment, and the fate of that vote will determine whether we have another vote of on the motion that I originally laid out that was seconded by Dr. Hernandez that would then be voted on separate and apart. And as we get the language of this amendment right, there'll be just a brief pause on how we, you have a question, Rich?
I do have one other amendment I'd like to make after we dispose of this one.
Okay. All right, let's get our board back. Thank you to the public for starting to line up in the shared optimism that we're moving to your comments pretty soon, but you might be standing for another minute or two. All right. Is it fair to ask John Paul to read it? Okay. Everyone's back. John Paul, do you mind reading what we know the author or the author of the amendment? That's not it. What is up on the board is not it. It is now? Okay, Megan, do you want to? All right, give it one more moment. It almost feels like one I should read out loud, but I'm going to allow everyone to read it themselves. And I'm going to look to you, Rick, to confirm that is
the wording certainly represents my intent. I think that the chart below would not be part of the proposed, not part of the motion. I would expect that the numbers would come out very close to what the chart below shows, but in the absence of knowing what the H adjustment is, it might be somewhat different.
Okay. I think that's an important point that 2025 should be 2.5 plus 0.5.
Plus age adjustment, right?
Well, the way that it's written, but the way that it's written, it's 2.5 plus 5. We can jump to 3, but the point is the way it's written is 0.5 plus in population adjuster.
Right. Age adjustment.
Yeah. Age adjuster, yeah. Sorry.
Yeah. Mm-hmm.
Tell me, Rick, if that is right, and it would follow, that would be what you see in 2026 as well, based on this. And then the 0.5 would change to 0.2. And then again, 2028, 0.2, thank you. You'd be a great clinician. That a leading 0, thank you. Yeah, and then the last year is just 2.5 plus age adjustment. Okay. No, we have a second to it, so we essentially have. You have a clarification?
Yeah, clarification question. So, how do you do it? So the first year is the baseline year, 2025. So there would be no age adjustment for the baseline year, right? Because the base adjustment would be 0. I mean, there's the baseline, right? An adjustment is compared to a baseline. So we have an aging population, but you got to start someplace, right? You got to start baseline. And I will also say that the first year is unenforceable. So, right. So it's more simply a marker. So I'm not so worried about
I guess
that.
One comment about this, which the public might make or fellow board members might make, is, what is the age adjustment? How would that be calculated? I have in mind a way of doing it. Staff has done it. I don't think this is likely to be a point of big contention, but other board members might say, well, what's that? What am I voting on? That would be a fair comment. Given another 20 minutes, I could write that down if the other board members were interested in what did I have in mind. To Richard's point, what I would have in mind is that even in year one, there would be an adjustment, that is in 2025, an adjustment for the effects of the changing age distribution from 2024 to 2025.
Okay.
Go ahead, Richard.
I realize there's a great desire to go ahead and, vote on something right away. I think some clarity. Again, this is not, it's not that complicated per se, but, and I said, we've had, many agencies come up with it. I think whether it's an after lunch thing or it's the next meeting thing, because deadline's June. It'd be good to be sure we're all in agreement with the methodology and we know what that number is. As I said, my intention is not simply to try to simply hit a number. I actually think that that's something, but again, I think if we can get some clarity, that would be helpful, just so that when people are voting, they know exactly what they're voting on.
I think as people are voting, that's certainly going to play into the discussion. I think we all, I don't know that there's a board member that if you support adding an age adjustment to our target, that there'll be some work to do for staff in what is a fairly narrow range already to determine what that should be, and it could be addressed on an annual basis like everything that we're considering. So I'm not sure that needs to slow our progress towards some consideration of the two various motions, one with the age adjustment, which is the amended, and then depending on its fate, what we would do with the other motion that I made originally, but Sandra seconded. So with all of that said, I want to go to public comment unless the board, okay, Richard?
I think I did mention there was another amendment I wanted to propose, especially since we've decided we're doing a 5-year projection. I actually appreciate a comment that Dr. Carline made that we explicitly make as part of this proposal is that we will have agendized annually at the meeting in the spring, I guess before June 1st, updates to review and updates to the targets, so that is explicitly part of our process. So I know that it was presented in there, but I wanted to make part of the motion because if we're really going to do a 5-year, I want us to be looking at it every year. And so before June 1st of each year, we will have agendized on our meeting a discussion and of an opportunity to talk about updates to the target.
All right. I think that it's an additional amendment to one or both current motions and amended motions. Curious what the board, I'm not hearing a second, so. Okay. I think part of why I am not going to second that is because I think that is something that's on the table. We've talked about it pretty extensively, and I think there's opportunities if we're failing to do that in some form or fashion that we can bring it formally in a different meeting, different conversation. And I think it doesn't just apply. I think it's going to frankly be the underlying principle of this entire effort moving forward, that there's learning, there's chances to bring more information and pivot down the road. So just in full explaining why I wouldn't be prepared to second that at this point, even though I agree, David, with your point that that's an important part of our proposal. Okay, do you want to comment back?
If we were really going to do that, I'm not sure what the problem is making that explicit, especially since we're doing a 5-year target. I have expressed some concerns about going out that far, at least for our first set, but obviously the board gets to decide. And I will, I am a little disturbed that there's no desire to actually hold ourselves accountable.
Okay. All right, seeing no second to that proposed amendment, I am going to move to public comment, and I am going to, as we first, to acknowledge and just sort of appreciate and respect the time of the public who's come. I don't know that you expected to wait this long for this rich conversation to get a chance to make your public comment. I'm going to do something a little unusual, but ask one of our first commenters, the first commenter, to be Dr. Wood. And not that his or any of our schedules is more important than somebody else's, but just out of respect, appreciation to your role here, I want to turn the first public comment to you and acknowledge, if we can, go ahead, Dr. Wood.
First of all, thank you very much, Dr. Galley. And I just want to say how appreciative I've been of the opportunity to work with the administration, the governor, you, and pretty much everybody on this board now on this issue. It's been quite a journey. For someone like myself who lives in a world where the status quo is jealously guarded and protected, discussions like this, where we're actually pushing the limit on people, are really, really refreshing. And it's really, really important if we're going to make progress moving forward. I do want to say that regardless of what you end up voting on, because I'm still a little confused myself, and I've chaired meetings for almost 20 years, and I don't envy you at all, Dr. Galley. So this is a difficult one. Whatever you ultimately end up on, it needs to be some messaging to be really clear to the public, because what you have up there to try to convey that to the public, to Ian's point, I believe, is a challenge, and we needs to be something that's clear. This is a 3% target, and all the other substitute things underneath there, how you get there, I don't think anybody really cares so much about, other than people like us. But anyway, that's just mine. I want to say this is because I really believe this. Perfect should not be the enemy of the good. And if we strive for the greater good, I think we're all going to be better off for it. We got here, in my world, I started working with people in the community and also with organized labor about this, with the constant drumbeat of the fact that there was organized labor negotiating salaries and benefits for their employees, and finding that most of those negotiations went to healthcare. And that, so how do you get ahead in the rest of your life if everything you're negotiating for ends up at healthcare? And that's why I started working in this arena. I worked in this area in the legislature for not the last 9.5 years, with the goal of increasing high quality and access and affordable healthcare. And I have the scars to prove it. From PBM transparency to the battles over nurse practitioners and their scope of practice, battling with skilled nursing facilities to protect those patients, some of the most vulnerable in society, and many, many more. I still got a few more months, and I'm still going to battle. I've been a payer as an employer, and as an elected who worked on a JPA, purchasing health insurance for employees of the city. And I'm a consumer. So I'm seeing it from multiple perspectives. I don't know the exact number. Maybe I had plenty of time to look it up, but I didn't. CHCF did a study, and I believe the number is half or more of all Californians have put off health care because they're afraid of the cost. Half. And that leads to real challenges, and I'm ignoring that thing back there, by the way. That leads to real challenges because inevitably, when they do get health care, it is more expensive. And I think we all know that. My wife is an example. My wife was a single mom, raised 2 adult kids. They're adults now. We still cover one of them on health insurance. And when we got together, she had a Covered California plan for which she paid a fortune. High deductible. She was terrified to go to the doctor. She put off her mammogram. She put off routine care. She finally did. I convinced her to go, and everything is fine. But she's a real living example of what people are facing right now. They're making difficult choices. It is not an exaggeration to say that people are deciding whether to get food on the table or get their medicines or get their needed health care. It is not an exaggeration. This is not an exercise. This is an effort to impact the real life experiences of people that we face in California. The one thing I really wish we had in this process was a way to influence the cost of pharmaceuticals more. We don't have as much as we'd like. And I will tell you, as someone who's worked to try to figure out a way to get our arms around pharmaceutical costs, it's really, really difficult. In Washington, D.C. alone, there are 1,500 lobbyists that lobby for one drug company or another. And I don't know what the number who lobby for pharma here in California is, but it's big. It's big and it's powerful, and they make sure that they get their way. And most of that is just keeping the costs up high. 20% of the healthcare spend is pharmaceuticals. When you add prescriptions, about 7%, and what goes on in hospitals and clinics and infusion centers, it's about 20%, and we've got to figure out a way to get around that. So I'm going to close here in a second. Missing piece of the puzzle here, which I think is critically important, and Dr. Hernandez alluded to this, some sort of data exchange. We have to have data exchange if we are going to realize some of the efficiencies. You can't go to an emergency room in another part of the state outside of your network and get good quality care without information, without that provider having ability to see, did you have an MRA recently? You're unconscious. You need the ability to have a robust health information exchange. And the fact that we have major healthcare players in this state who do not want to participate is really, really frustrating. And I hope that we can come to some resolution on that, this year. Prevention. One of my biggest pet peeves as a dentist is that we as a state do not invest enough in prevention. We spend a ton of money treating diabetes, the consequences of diabetes, and so many other things, but we do not spend enough on prevention. And even in the current budget, there are things that are being eliminated from the budget or proposed for elimination that I believe are preventive. And so we've been fighting for that on our end to try to keep prevention out front and up front there. So finally, your vote is historic. Your vote is absolutely historic. You're sending a really strong, important message to the people of California. And I hope it's unanimous. I hope you're on the right side of history. I thank you for the time.
Thank you.
Thank you. We will now continue to recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. Please keep your comments, if possible, to 2 minutes or less so that we can hear from everyone. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the agenda, except to place the matter on a future agenda. Noting for the record, we have about 122 virtual attendees and a number of hands raised. We will start with the individual at the podium. Please go ahead.
Beth Capel on behalf of Health Access California. We came here today to support 3% with an acknowledgement that change takes time and takes time to implement. When we look at the two motions before you, the amended motion and the original motion, our preference remains 3% or lower. We would, however, support the original motion and ask that you reject the amended motion. It is confusing at best, as you have already heard. We believe it also, because age and sex are already being counted, that in the total healthcare expenditure, that adding an aging adjustment partially or completely double counts. It's hard for us to do this on the fly. Age as a factor. We would also point out, as Board Member Lewis pointed out earlier, that about half of Californians are in coverage where the rates are set. That is Medicare or Medi-Cal. And the other half are in some form of commercial coverage where there is not the rate setting. This is part of why in our letter we raised the importance of enforcement by segment and the recognition of the very different rate setting mechanisms by segment. Commercial coverage by its nature cannot set rates because we don't allow payers to collude among themselves to price fix. What you are doing is setting a target, not a cap, that we will hope that the handful of payers and the relatively small number of physician organizations and health systems in each region can reach or exceed. You have already, all of you, referred to the testimony you've heard. You can see behind me a line of more people who want to offer their testimony. You've heard from people with MS who hit their maximum out of pocket. You've heard from small business owners. You'll hear from lots more. And as Board Member Mitchell said, people who have taken a day off work to come here and tell their stories. So as Assemblymember Wood just said, it's a historic vote, and we're happy to be here for that historic vote. The one other point I'd make, the study you heard presented at an earlier meeting, the share of premium plus median deductible for family coverage in this state is now $10,400 when the median income is $85,000. I don't know how anybody spends $1 out of $8 on healthcare and affords the other things they need to have.
3 minutes.
Thank you.
Thank you. Looking virtually, noting we have 118 virtual attendees and over 6 hands raised. Bill Barcel, please go ahead. Bill, you should be unmuted on our end. You might need to unmute on your end.
And then thank you.
All right.
Bill Barcelona, America's Physician Groups. Thanks to the OCA staff and this board for its work and discussion today. We're supportive of the adoption of the phased-in cost target with population adjustment. Our members have essentially 30 years in their prepaid capitated model. As we've stated in numerous meetings before this board and the advisory committee, the current trend for professionally capitated providers, as reported by health plans to the DMHC in its periodic premium rate filings, appears to have increased to approximately 5% since the advent of the COVID pandemic. It's uncertain how a 3% statewide cost target would be implemented within the market, and whether it means all contract renewals between health plans and capitated delegated physician organizations would necessarily be renewed at lower rates than even the adopted cost target. And if so, that would represent a sharp decrease in capitated rates at present of over 40%. Just want to remind everyone that stability of the delivery system is just as important as cost control. As the other provider representatives have pointed out in prior meetings and in their letters, the states that monitor their statewide cost growth have been increasing their cost trend projections in recognition of this current market reality. California currently falls in the middle of all 50 states in per capita spending. We acknowledge that it is difficult for a regulator to hit the sweet spot between a target number that produces meaningful relief for consumers without undermining the very delivery system that serves the consumers. While California was initially guided by the experience of the other states that adopted these cost growth targets in formulating its OCA, we suggest that it pay close attention to the actions of those states at present, including their increasingly conservative approach. In light of these factors, APJ suggests that the OCA Affordability Board consider the alternative proposal that Secretary Ghali has put forth and has amended, considering the more conservative trend across the country. Thank you for the opportunity to provide comment.
Thank you. To the individual at the podium.
Good afternoon. Cesar Lara with the California Labor Federation, 2.3 million members, and really appreciate Dr. Ghali and Dr. Wood, especially Dr. Wood, talking about working with organized labor as an organization that collectively bargains for our healthcare. Most working families do not have that opportunity since healthcare is tied to employment so often. And we want to rise with our 2.3 million members and the rest of working families that we need to be clear. We came here, like the previous podium speaker said, to support the recommendation option 1 of 3%, but are happy or not happy, but okay with your recommendation. To be clear, in politics and in policy, there's organized money and organized people. I'm happy to stand with organized people. I'm asking everybody here to stand with organized people. As we move forward in California, sometimes the 5th largest economy in the world, we're having this discussion is unfair for our working families. And we need to be clear, like Ian said, what we're going for. And so we want to recommend the motion made by Dr. Ghali, not the counter motion. We want to be clear that this is only phase 1. Phase 2 is counties like Monterey County that our costs are so high that whatever you do, there's some action that needs to happen there. So looking forward to moving forward with this motion and tackling the harder issues in other communities, because at the end, working families are dying because of healthcare affordability. That should not be the case in the 5th largest economy of the world. Thank you.
Thank you. Going virtually to Aaron Plotke. Aaron, you're unmuted on our end. You might need to unmute on your end.
Thank you. Healthcare Affordability Board members and staff, thank you for the opportunity to provide these brief remarks today at this critical moment in implementation of California's statewide spending target, a critical authority of California's Healthcare Affordability Board. It's an honor to be with you this afternoon. My name is Aaron Plotke. I'm a senior policy analyst with Families USA, a leading national voice for healthcare consumers. Californians and Americans across the country are experiencing a severe healthcare affordability and quality crisis. In the work of this office, all the work that you're doing is urgently needed. Every person and family should have high quality, affordable healthcare that prevents illness, allows them to see a provider when needed, and helps to keep their families healthy. Yet over half of all Californians have had to skip or postpone needed healthcare due to the high costs. And while nearly 2/3 of Californians reported high levels of worry about unexpected medical bills and out-of-pocket costs into the future. And California residents are not alone. Families and healthcare consumers across the country are suffering, with over 40% of American adults, or 100 million people, facing medical debt. A leading driver of this crisis is high and rising healthcare prices, and in particular, hospital prices, which are causing millions of Americans to go into debt, as well as helping drive wage stagnation, income inequality, resulting in thousands of dollars in lost wages over time due to rising healthcare premiums. In California, hospital prices have increased a staggering 76% in just the past decade alone, increasing more than 3 times faster than both household income and inflation. Californians are grappling with some of the highest healthcare prices in the country, with California hospitals charging up to 450% of what Medicare pays, and too often charging far and above, sometimes over 1,000%, what is needed to cover the true cost of a given service.
2 minutes.
What exists in California and across our nation is a fundamental misalignment between the business interests of the healthcare sector and the health and financial security of our nation's families. That is why we strongly support the work of California's Healthcare Affordability Board and strong implementation of its statutory mandate, including the original motion establishing a cost growth target of 3% with no phase-in or further adjustment to immediately begin holding the healthcare sector accountable to delivering the high-quality, affordable, and equitable care that Californians need and deserve. Thank you very much.
Thank you. To the podium.
Hello, my name is Regina Chagoya. I am the Vice President of Berkeley Federation of Teachers. I'm also the Vice President of K-12 Northern California for CFT. I'm also a school board member for Emory Unified School District, but most importantly, I'm a first grade teacher. For educators, healthcare benefits are a recruitment and retention tool schools uses to hire world-class educators for this state. However, the increased cost has made the profession unattractive, leaving schools and staffing shortages. So whatever you read in the media, your local paper, or your neighbors who might be teachers, any percentage of increase like compensation, whether it's 1% or 5%, gets eaten up by healthcare costs. This is why CFT supports staff's recommendation of a 3% spending growth target for the years 2025 to 2029. Thank you.
Thank you. Going virtually, Selene Diaz.
Good afternoon. Selene Diaz with the California Pan-Ethnic Health Network, representing the Having Our Say Coalition, a coalition of over 30 community partner organizations, including grassroots organizations and healthcare clinics. We are in strong support for slowing the growth of healthcare spending to help those in our communities who frequently delay or forego necessary care because of high costs. Many are forced to rely on alternatives, such as home remedies, instead of seeking professional care, compromising their health further. Members of our coalition who work closely with community members often hear about the tough choices people face, deciding between basic necessities like food and rent, or essential medical care and life-saving medications. These stories are not uncommon, and they underline the urgent need for action. We urge the board to adopt a 3% or lower spending target, the first motion without a phase-in, to help control rising healthcare costs. Thank you.
Thank you. To the podium. Is your microphone on? Do you see a green light?
Sorry. Thank you. Hello, my name is Miria Gutierrez, and I am from a small town in Monterey County. I am a member of the Salinas Valley Federation of Teachers, and I am here representing the California Federation of Teachers. As an educator, the cost of healthcare in California has created a loss of income that impacts the bottom line for our families. Encroaching health insurance premiums are reducing household expenditures, causing educators' families to enjoy life less, all the while paying more and more for their total healthcare expenditures year in and year out. Just to give you an example, recently, earlier this year, I was mailed a bill that was like thousands of dollars for my emergency room visit that I had to take my daughter to. She's a 3-year-old, and you know, 3-year-olds get sick really like often, and sometimes you don't know how serious it could be. And I'm actually next month, I'm gonna be paying it off finally. But I ended up getting COVID earlier this month. which means that I now have another bill. I just got it last night, which is thousands of dollars. So just to show you how you can pay off a bill, right? Take months to pay it off, and then all of a sudden you're like unforeseen circumstances, you have to pay another one. Not only that, now I am going to have to go to the dentist, and I already got the bill or the estimate bill, and it's thousands of dollars again. So if you take all that total and how much money teachers make, I know that it's gonna be a difficult summer. I had planned not to work this summer after 10 years of working summer school, and I'm debating whether I should actually work. So unfortunately, I'm in that position right now. This is why CFT supports staff's recommendation of a 3% spending growth target for the years 2025 through 2029. Thank you.
Thank you. Virtually, Tim Madden.
Tim Madden on behalf of the California chapter of the American College of Emergency Physicians and the California chapter of the American College of Cardiology. Thank you for the opportunity to provide comments. Both organizations continue to have concerns with the proposed growth rate and time frame. The phasing approach in option 2 with the proposed amendment is preferable to option 1, but may not consider actual costs of providing healthcare and does not include many changes in the healthcare market that will be impact spending growth. I am hearing from physicians feeling they will be pressured to reduce providing medically necessary care, as well as thinking twice about making investments in their practices. Recently, a cardiologist was asking me how their practice would reevaluate purchasing new imaging equipment. They feel it would be great for patient care, but the cost with that equipment may put them over and beyond that target rate. They feel over time the equipment would lead to reduced healthcare costs, but the upfront costs may push them over that target rate. I appreciate the comment made earlier in your discussion that this may be viewed as a mitigating factor, but we feel this should be taken into consideration while setting the growth rate, providing more assurances to practices. The healthcare spending target should also take into consideration increased costs and investments as a result of new laws such as SB 525 and its phase-in healthcare minimum wage increases, as well as the significant investments in Medi-Cal, which is currently severely unfunded. To wrap up, the concern I've mentioned in the past with the emergency physicians, for them, the need to have a target rate that doesn't lead to providers reducing care is critical. As you know, emergency departments are already experiencing tremendous volumes, the result of patients currently struggling with access to care. We appreciate your consideration of our comments.
Thank you. To the podium.
Good afternoon. My name is Nelly Vaquera Boggs. I am a bilingual teacher from the Central Coast in Santa Cruz and Watsonville area. I am also the president for our local. I represent just over 1,100 families. And I'm also a vice president for the California Federation of Teachers Executive Council. I liked the comment that Cesar made earlier that I'm on the side of the organized people. That I'm for ensuring that the people we represent are able to live in the spaces where they live. We happen to live in an incredibly expensive area, Santa Cruz County. And one of the leading causes of bankruptcy for educators is crushing medical debt. Not only are premiums significantly increased annually, the covered benefits are also reduced, leading to educator medical debt and in many cases, bankruptcy. California students deserve educators who focus on them and do not deserve educators focused on personal financial disasters. My family, my older sister, she was a single mother, and healthcare is expensive. And as a single mom, it's doubly so. She did not attend to her health when she should have. And eventually, when it got to the point where she was not feeling the best, she learned she had a stage 4 cancer and lived for another 3 months to get some things in order for her child who, my nephew, who we took in. That's just one of the many stories that I can share on how healthcare has impacted the working class person. My sister was a highly educated individual herself, but healthcare does impact our income,
2
because
minutes.
as Regina stated, our income, we have to pay for our healthcare, and that comes out of our salaries. So this is why the CFT supports staff recommendation of 3% spending growth target for the years 2025 to 2029. Thank you.
Thank you. Virtually, Kelly Brooks Lindsay.
Hi, good afternoon. Kelly Brooks on behalf of the California Association of Public Hospitals and Health Systems. Public healthcare systems strongly support improving affordability for patients and consumers. However, we are concerned with the spending target proposals being contemplated and the potentially detrimental impacts they could have on patients and access to care. Should an unattainable target be adopted, we anticipate there could be reductions in preventative and outpatient care and staffing in ambulatory care settings, overburdened emergency departments and inpatient settings from a lack of access and more appropriate care settings, increased wait times and acuity of patients, and inability to make needed infrastructure investments to create a safe space for patients and workers. We understand and can empathize with OCA's interest in connecting the target to a measure related to consumer affordability. However, we would strongly encourage the board to consider a more realistic and attainable target. Otherwise, there could be blunt and harmful impacts to healthcare access in our state. We support the incorporation of an adjustment to the target to account for how the aging of our population will impact the need for healthcare services and consequently necessary spending, and that target would be continuously updated. In addition, although we recommend the adoption of a 1-year target, if the board chooses to adopt a 5-year target cycle, we strongly encourage it to be phased in over time and for it to be revisited on an annual basis. Successful cost containment efforts could take significant upfront investments, and providers will need time to plan and make changes in a thoughtful and intentional way to really move the needle and without causing harmful consequences for healthcare in our state. A number of state-level policy decisions will also significantly increase healthcare spending in immediate future years, and the spending target should reflect this. Last week, we urged for providers to be held to the same standard when enforcing the spending target in Medi-Cal and Medicare as payers. Thank you for your consideration.
Thank you. To the podium.
Members of the board, staff, and public, Steve McDougall with CFT, a union of educators and classified professionals. I'm a leader of CFT at the state level. I'm a leader in Salinas, former leader of Salinas Valley Federation of Teachers, still on the executive board there. I'm a school board trustee in Spreckles Union School District, and I wear many, many hats and many, many projects. 15.96. 15.96. Friday evening, I got a text message from the executive director of MixSig, a JP that delivers health benefits to public employees, mostly educators. I happen to be the president of that board. 15.96. It's what the actuary says we need to raise rates by to stay afloat for 2025. 15.96%. 3, age factor, whatever, we're broken. I'm not sure you can help us. I know this amendment's going to somehow get us somehow, some way. And I'm not sure where the motivation for that is, but I have some idea. 15.96%. I didn't sleep. I've been agonizing. I look at the state budget. There's no new money for schools. Educators are going to take a pay cut in Monterey County next year. A pay cut. 15.96%. It's disgusting. Thank you for your work. Stick with the original motion. I'll acquiesce to Dr. Gailey's original motion. CFT will acquiesce to that. Begrudgingly. 15.96%. Thank you.
Thank you. Going virtually to Elena Santama.
Hello, my name's Elena Santamaria, and I'm a policy advisor at Next Gen California who has been supportive of OCA's work and the 3% annual spending growth target for 2025 to 2029 based on median income in 2002 to 2022 and not on the growth of the economy. The rest of my comments are not on behalf of my organization, but as a healthcare consumer. In 2009, my sister had a seizure at the age of 22 and was admitted to the Ronald Reagan UCLA Medical Center. Her hospital stay emergency care and the surgery that she needed to remove the brain tumor that was impacting her that we later found out was stage 3 cancer. The healthcare costs were outrageous and it continues to be a huge burden to my family. Her emergency room alone was $150,000 and her surgery was over $200,000. To see 15 years later, minimal progress has been made for families is excruciating. And to listen to the discussion at this meeting, I can't help but feel frustrated that although these goals here are admirable and this vote is historic, people will still experience outrageous healthcare costs unless drastic action is taken. I appreciate the work of this board and what it continues to do, and thank you for your time.
Thank you. To the podium.
Buenas tardes. Mi nombre es Joaquín Benítez. Trabajé en Monterrey Ties durante 14 años. Soy voluntario llevando comida a los hogares de familias necesitadas y a las personas sin hogar. Actualmente estoy desempleado debido a restricciones médicas. En el 2017 tuve un derrame cerebral y fui 2 veces al hospital. Tuve que pagar mucho dinero. Pagar esa factura me limitó a ayudar a mi familia en El Salvador. Estaba ayudando a mi hermana Rosa, que tiene diabetes. Contaba con mi apoyo económico para sus facturas médicas y medicamentos. En consecuencia, perdió 2 dedos de un pie. También tuve que usar el banco de alimentos para llevar comida a mi mesa. Después que me salvaron la vida en el hospital, me impactó mucho ver cuánto iba a pagar. Siento que el costo del hospital en Monterrey está afectando a familias trabajadoras. Quiero pedirles a todos que vengan a Monterrey y vean por sí mismos cuánto están luchando las familias para sobrevivir. Con el sistema tal y como están las cosas, la vida de las familias trabajadoras están en riesgo, ya que evitamos ir a los hospitales por los altos costos. Incluso un objetivo del gasto del 3% es demasiado para el condado de Monterrey. Por eso necesitamos que voten hoy por la opción 1. Gracias.
Thank you. And virtually, Travis West. Oh.
I will translate what Joaquin just shared. Good afternoon. My name is Joaquin Benitez. I used to work for Monterrey Ties for 14 years. Currently, I am a volunteer to bring food to needy families in my community and homeless people. Right now, he's unemployed due to medical restrictions. On 2017, he had a stroke and went twice to the hospital. He had to pay a lot of money. Paying that bill limited him from helping his family in El Salvador. He was helping his sister Rosa, who had diabetes. She counted with his support financially for her medical bills and medicines. Consequently, she lost two toes from one foot. He also had to recur to food bank to bring food to his table. After his life was safe at the hospital, he was shocked to see how much he was going to pay. He feels that the hospital cost in Monterrey is hurting working families. He wants to ask you to come to Monterrey and see for yourself how much families are struggling to survive. With the system as it is, working families' lives are at risk. They avoid going to the hospitals because of the high cost. Even with a 3% spending target is too much for Monterey County. We need you to vote today for option 1. Thank you.
Thank you. Looking virtually, Travis West, go ahead.
Thank you and good afternoon, everyone. Travis West, Regulatory Policy Specialist with the California Nurses Association. Thank you to the OCA board and staff for your work on this issue, and to the working people and other members of the public who are here today for your engagement and for sharing your stories. We want to comment in support of a 5-year, 3% spending target as initially recommended by OCA staff. And we encourage OCA to adopt this standard without a phase-in or glide path and to do so as soon as possible. As we've just heard today, a clear and effective spending target is crucial to address access problems that consumers are already facing now under our current system. We also encourage OCA to adopt a spending target without adjustments or exemptions, including age-based adjustments, before or after assessing the individual performance of entities. Thank you.
Thank you. To the podium.
Okay. Hola, buenas tardes a todos. Mi nombre es Celia Flores. Trabajo para Google en una cafetería por 6 años. Estoy aquí para apoyar a mis hermanos y hermanas del condado de Monterrey. He escuchado que ahí los costos del hospital son muy caros. Yo soy una sobreviviente de cáncer. El año pasado me hicieron una cirugía en un hospital de la Bahía, en San José, California, el cual me espanté del bill que me llegó, que fue muy caro, pero gracias al seguro que tengo, mi seguro pagó la mayoría. No me imagino realmente lo que me hubiera infartado nuevamente en cuestión de ver el costo que tienen ahí los compañeros de Monterrey. Yo de la cirugía, yo solamente pagué $200 y mi bill era de $85,000. Es una locura realmente el saber por lo cual están pasando la gente de Monterrey. No me quiero ni imaginar. Siento que deberíamos de apoyar, está en sus manos de todos ustedes, en que sea el menos del 3% para el seguro médico. Gracias por su apoyo y créanme, ustedes están aquí y con todos ustedes yo los invito a que sigamos apoyando a la causa para que esto se refleje y podamos ayudar a la gente que está a menos que nosotros, a más que nosotros, pero necesitamos de su apoyo y los invito a que por favor voten hoy por la opción número 1. Gracias.
I will summarize what she said. Good afternoon. Her name is Celia Flores. She works at Google Cafeterias for 6 years. She is here supporting her brothers and sisters from Monterey County. The hospitals in Monterey County are extremely expensive, even with insurance. She has an experience. She's a cancer survivor. So she had a surgery last year in a hospital in San Jose, and she thought what the health insurance paid, it was a lot of money. But after finding out the prices in Monterey, she thinks they're insane. She had only paid $200 from an $85,000 bill, so her payment was only $200. So she asked all of you to approve the option number 1. Thank you.
Thank you. Looking virtually, noting for the record that we have an estimated 104 attendees and seeing no hands raised virtually. Going back to the podium.
Buenas tardes, mi nombre es Catalina Hernández. He trabajado en Haya de Residence de Monterrey por 18 años como recamarera. Mis compañeros y yo pensamos que el 3% es absolutamente el máximo. Creemos que esta mesa debe poner un objetivo más bajo para Monterrey, ya que los precios ahí están demasiado caros y altos. El año pasado, dinero que íbamos a recibir de nuestros aumentos, de nuestro aumento, se fue al seguro médico porque está demasiado caro. Recibimos nada. Si hubiera recibido ese aumento, lo hubiera tenido suficiente dinero para comprar alimentos que son demasiado caros. Tenemos miedo de perder también el aumento que debemos recibir en agosto que viene. Los invitamos a venir a Monterrey a investigar qué está pasando en el condado de Monterrey. Por favor, votar hoy por opción 1. Gracias.
Good afternoon. Her name is Catalina Hernandez. She worked at the Hyatt Regency for 18 years. She's a housekeeper. She and her coworkers think that 3% is absolutely maximum for a target. We think that the board should set a lower target for Monterey since the hospital prices are already too high. Last year, the money that was supposed to go to raises instead had to go to health insurance increase. That means that they didn't receive any increase. If she will have a raise, she will have enough money to buy food for her family. She fears that this coming raise that was supposed to come on August, that they lose it again to go to the health insurance. She is inviting you guys to come to Monterey to investigate what is happening in the hospital prices in the Monterey County.
Thank you. Seeing no hands raised virtually, going back to the podium.
Buenas tardes, David. Buenas tardes, me llamo María Santos y trabajo en el Hyatt de Monterrey.
Is the light green on the microphone? Great.
Oh. Buenas tardes, mi nombre es María Santos y trabajo en el Hyatt de Monterrey. También estoy hablando por del cuidado de médico. No tuvimos el aumento que teníamos que tener y porque se fue al seguro médico. Y estamos muy impactados porque nos aumentan nuestras rentas y no nos queda para nuestros alimentos. Tenemos que ocurrir al banco de comida para un poco de comida. Y les pido de favor que también chequen en el condado de Monterrey que el 3% no es suficiente para nosotros. Por favor, vota por la acción número 1. Gracias.
Good afternoon. Her name is Maria Santos. She works at the Hyatt Regency in Monterey. She's talking about the same what Catalina said, that they didn't get an increase last year for their wages. She said that they're struggling. Their rent is getting higher and higher, so they have to go to food bank to have enough food on their table. They are so impacted for that increases in pricings. So she's asking you to come to Monterey too and to vote today for option number 1. Thank you.
Thank you. Seeing no hands raised virtually, going back to the podium. Please go ahead.
Good afternoon. My name is Esteban Rodriguez. I'm a bartender at Monterey Tides. I'm also a proud union member in Unite Here, Local 19. We have negotiated in our contracts for good health care. We're in negotiations right now as well. However, the prices of the hospitals in Monterey, all the money in our contracts goes to healthcare, and raises are now going just strictly to the healthcare. Last time I was here, I presented a bill that I had in 2020. I have made a difficult decision of bringing my daughter with me here today on her birthday. To show how important this is. The decision you're going to make today is very important, as you've heard before. 3%, I feel like it's still kind of high. Living in Monterey specifically, going through that process. Also being now, I posed that to the public, mentioning how high Monterey hospitals has been compared to the rest of the state. Where most recently I have been denied medical care, MRI to be specific. We only have these 2 options at the moment. Out of these 2 options, I still feel that the motion 1 is the best out of the 2. Again, I brought my daughter to see the importance of this because that's going to affect her as well. Yes, you see us, you see all the adults here in this room. Get that. But we also, many of us do have families as well. Thank you.
Thank you. No hands virtually. We'll go back to the podium.
Thank you. I'm Bill Kramer, Senior Advisor for Health Policy at the Purchaser Business Group on Health. My comments are also informed, however, by my past experience as a CFO of a large healthcare system, as a private consultant in healthcare business strategy and finance, and my current work as a member of the Oregon Health Policy Board, where I'm the liaison to the Oregon Cost Growth Target Program, very similar to the program under consideration today. First, I want to thank the board and the staff for the tremendous work that's been done and the robust discussion on these important issues. It's important to, it's impossible to overstate the seriousness of the healthcare affordability crisis for patients, consumers, and employers, especially small businesses and the small not-for-profit organizations. The testimony you've heard already today is compelling. I'll just say my mother was a public school teacher. My father was a labor organizer. I work now for an organization that represents large private corporations and public sector purchasers, but our interests are aligned about the need to address the affordability crisis. A few comments on the earlier issues that were raised. The technical arguments, for example, about whether there should be adjustments made for aging or other factors driving up costs, are interesting if you're trying to forecast what spending growth will be under the status quo. But I'll ask the board to stay focused on the key goal, which is not to forecast future spending, but in fact to improve affordability. We recognize there are many factors driving up healthcare costs in hospital physician groups and health plans. Improving affordability, quality, and equity is hard, but we also know two things. One is that the status quo is unsustainable, and second, that there are great opportunities to improve quality and affordability. In fact, we have examples of health systems and physician groups
2 minutes.
Who have achieved lower costs and improved quality. We can learn from those best practices, help to spread them more broadly, and achieve the healthcare spending targets. Finally, it's important for us to act now. The affordability crisis is hitting patients, consumers, and employers right now. The sooner we set appropriate targets and get to the work of improving affordability, quality, and equity, the better. Thank you.
Thank you. No hands virtually. Back to the podium.
Thank you, Secretary Galley and members of the board. Nick Luizos on behalf of the California Association of Health Plans. We just want to reiterate our support for a statewide multi-year spending target that is done thoughtfully and subject to annual review. We're here today in support of motion 1. With all due respect to the alternate motion, we haven't had time to take that back to our membership, so we only have a position on motion 1, which we're supportive of. We do support that option because it does give our member health plans some time to plan. One thing to take into consideration is that our health plans have multi-year contracts with providers and facilities, so changing cost structures in year 1 would be very difficult. So, but we do support the concept of ramping up or down, if you will, to a spending target in the first enforcement year. It's still aggressive and will be difficult to reach, but we are willing to work with OCA on that. So, our members do support the mission of this board, and we do stand with those who are in favor of more affordability in healthcare and achieving that for consumers. Once a reasonable and thoughtful approach is achieved on the spending target, we do think, we need to go to work immediately on other issues, including the sector-specific targets. And as we embark on that pathway, our members do seek clarity on some really important issues to make that effective, specifically, data submission, collection, and how that data is going to be characterized, I think is important to our membership. A little bit of focus and more clarity on the considerations. If an entity doesn't meet the specific spending target, and then how Medicaid and Medicare costs factor into the work that we're doing here at the board. So supportive of motion 1 and look forward to our continued work.
Assistant Deputy Director of Fiscal and Financing.
Okay.
Alec Klimek.
To the individual at the podium, please go ahead.
Good afternoon. My name is Stephanie Dansker, and on behalf of the Hemophilia Council of California and the California Rare Disease Access Coalition, as well as thousands of patients that we represent, I want to express our concerns regarding the proposed target of 3% spending. By prioritizing cost containment over patient needs, OCA risks setting a dangerous precedent that could further marginalize individuals with rare diseases. Rare conditions already cost 3 to 5 times more per person per year than common health conditions. For conditions that lack effective treatments, there's more than a 20% increase in the total cost of care per person per year. When treatments are available, the annual cost of these medications or medical procedures often increase by more than the 3% target. We urge OCA to consider its approach and prioritize the needs of patients with rare diseases, which collectively affect 1 in 10 Californians. Please consider that in your target process. It is imperative that any spending target be developed in close coordination with patients to ensure it's based on data and analysis and considers the underlying drivers of healthcare costs. By doing so, OCA can ensure that California healthcare system remains accessible, high quality, and equitable for all residents. Thank you.
Thank you. Looking virtually, we have one hand raised. Angela, please go ahead. Angela, you are unmuted on our end. You might need to unmute on your end.
Okay, am I unmuted now?
Yes, we can hear you.
Perfect. Good afternoon, everyone. My name is Angela Gilliard. I'm the Director of Health Policy and Regulatory Affairs for the University of California. The University of California health system shares the same goals as OCA to provide accessible, quality, affordable, and equitable health care to all Californians. As a public hospital system, we agree with the comments made by Kelly Brooks and on behalf of the California Association of Public Health Systems. The UC academic health centers treat the most challenging and complex cases and provide tertiary quaternary care to patients across the state, including half of all organ transplants and 1/4 of extensive burn care in California. We urge the board to consider the more complex health care needs of California's aging population and the increasing trend in patient acuity when setting the spending target. Like many other hospitals, UC Health's case mix index has increased over the last two decades as the population continues to age. UC Health has notably higher CMI, case mix index, than other hospitals because of our role as a provider of tertiary quaternary care, serving patients with more serious or complex ailments. While we support OCA's goal of increasing investment in primary care, we must emphasize that Californians, particularly seniors, persons living with disabilities, and patients with complex health conditions, will always require specialized care, and spending targets must support quality and equitable access to that specialty care as well, particularly for those who are disproportionately impacted by health disparities. We understand this is an important decision, but transparency and clarity in understanding the motion before us today and the proposal would vote toward a next month's decision. The statute gives you time until June 1. We urge balancing affordability with quality, equity, and access to care for the range of healthcare needs of Californians. Thank you.
Thank you. To the podium.
Good morning, everyone, or should I say good afternoon. My name is Derek Kunze, and I'm a proud member of Carpenter's Local 46 in Sacramento. Like so many other people, I'm finding it harder and harder to pay for my basic needs: gas, groceries, rent, utilities, and even more. I understand that costs are also rising for healthcare providers as well. But when I read that Kaiser is willing to spend $5 billion to acquire other medical groups, or that members of the Kaiser Permanente Consortium violated the False Claims Act by submitting inaccurate diagnosis codes for its Medicare Advantage plan enrollees in order to receive higher reimbursements. It tells me that this is a behemoth that must be reined in and better regulated. This regulatory board is the last line of defense for struggling families seeking access to healthcare against greedy CEOs. Raising rates for healthcare is not only morally questionable, but also economically short-sighted and detrimental to public health. I feel it is essential to prioritize affordable and accessible healthcare for all members of society to ensure a healthier, more equitable, and prosperous future for everyone. I'm asking this board to please approve the 3% spending target and stand up for working class against these unfair rate hikes. Thank you.
Thank you. Back to the podium.
Hi, good afternoon. My name is Rob Martin. I'm a proud member of Carpenters Local 46 in Sacramento. Access to healthcare is a core tenet of the Carpenters' core values, and is extremely important to me and my family. I'm the sole provider of a family of 2 and my stay-home wife. I'm trusting in the board to do the right thing and approve the 3% spending target on premiums. Thank you.
Thank you. Back to the podium, please.
Hello, my name is Julie Nielsen, and I'm here on behalf of the National Union of Healthcare Workers. NUHW represents 19,000 healthcare workers throughout the state of California. Every day, our members treat patients who have delayed care because of the barrier of unaffordability. Costs have continued to rise far above inflation. People who can afford the least pay much more as a percent of income, and those who need more care pay more in terms of copays and deductibles. When patients who have delayed care are finally seen, their conditions have worsened, they are much more difficult to treat, and their health more expensive to restore, and the problem is just getting worse. Now, our members are don't only witness this in patients as healthcare workers, they are also experiencing rising healthcare costs firsthand, as the mounting price of their own coverage puts more and more pressure on wage negotiations and severely exacerbates our state's challenges in attracting and retaining the healthcare workforce it needs. As we speak here in Sacramento, workers at Center Care for Psychiatry are on strike because of insisting on significantly increasing healthcare costs, even though the company reported 477 million operating profit in 2021 and 22. And last month, more than 400 NUHW workers members struck Seton Medical Center because the healthcare workers were they're being forced to pay up to $6,000 a year more to keep access to the doctors and have a health plan with so few participating doctors, they had to travel an hour. And when Hazel Hawkins Memorial Hospital declared bankruptcy last year, the first impositions it made were steep increases in workers' own health insurance premiums with the explicit goal of reducing the amount of care the employees and their families receive. None of this is acceptable. For all of these reasons, NUHW strongly supports the recommended cost growth target of 3% for 2025 to 2029. Thank you.
Thank you. Looking back virtually, noting we have roughly 110 attendees, seeing no hands raised. Back to the podium, please.
Good afternoon, ladies and gentlemen of the board. My name is Chris Martinez. I'm a proud carpenter out of Reading, local 1599. It's with great urgency and purpose that we gather here today to address the crucial matter affecting each and every one of us, the issue of escalating healthcare costs. Our union stands united in support of the statewide spending target of 3% in healthcare. Consider for a moment the staggering reality that all of our hardworking members, we have over 35,000, are already spent millions of their hard-earned dollars are already gone to the healthcare. The financial strain on our workers has reached a breaking point. Enough is enough. It's time to set limits that of what can be extracted from the hardworking class. We commend your diligent efforts of the OCA board and its dedicated staff in their pursuit to relieve the working class. Your work is vital, and we express our deep appreciation for their commitment to this cause. Therefore, we call upon you to swiftly adopt and propose 3% spending target in healthcare. The time for action is now. Every working individual is desperate need of relief from this relentless surge of healthcare costs. Our prices shouldn't go up so they can put a name on a sports stadium somewhere. The time is now. We need change. Thank you.
Thank you. To the podium.
Hi, Miranda Dietz, UC Berkeley Labor Center. I'm a health policy specialist. We appreciate the board's careful consideration of and focus on what this vote means for working families in California. And we are reassured that, as noted on slide 33, bullet 2, OCA is already planning to adjust for age and sex composition when they report total healthcare expenditure, THCE data. We think this adjustment after the fact is simpler than the proposed amendment and is appropriate. Some complexity under the hood is inevitable, but there should be a clear target that the public can understand. By adjusting for aging on the THCE side of things, the reported growth in statewide total healthcare expenditure would adjust for aging. So even if total healthcare expenditures went from 100 to 103.5 in actual dollars, right, the kind of weeds that I would get into as a researcher, the reported growth adjusted for aging would be 3%. Another advantage of adjusting on the THCE side is that it's entity specific. So aging trends will differ by entity. For example, a children's hospital should not have the same aging adjustment as the hospital that serves my mom and her retirement community. We think OCA's plan to make these adjustments on the back end when reporting THCE makes sense. Thank you.
Thank you. Continuing.
Good afternoon, everyone. My name is Matthew Beeston. I am a representative for the NorCal Carpenters Union. First, I would just like to express my appreciation for everyone who gave their testimony today, all my fellow Californians. That is upsetting, but also motivating, I must say. I represent more than 45,000 either active or retired members in the NorCal Carpenters Union, the majority of which rely on Kaiser for their health care. These exorbitant costs that we have experienced over the last 20 years, Kaiser has quadrupled our rates. These rate increases, they threaten the wage increases that our membership has bargained for, and they also threaten the affordability simply of retirement for my retired members and for those who are considering retirement in the near future. State-of-the-art healthcare it's a right. And frankly, in this day and age, in the fifth largest economy in the world, it's a basic human right that absolutely needs to be acknowledged and taken care of. However, the cost of funding that care should not be deferred to the working class citizens, especially when Kaiser is paying its chief officers tens of millions of dollars a year. I stand proudly with my union brothers and sisters today. We're here to fight this injustice, and we will continue to stand to fight for this injustice like we have many others in the past in our nation's history. It's upsetting. It truly is. I am motivated here, and I'm a newcomer to the staff here for the organization, and this battle has only just begun. NorCal Carpenters Union and its members, we are fully in favor of the originally proposed spending target, and we look forward to further regulations. I would like to just add one more thing. It was mentioned earlier, the fact that government has had to get involved in this situation. Yeah, that's upsetting in itself. However, now the public is here. You cannot ignore us now. We will be a part of this discussion. Thank you.
Thank you. Continuing in the room.
Hi, my name is Harvey, and I'm a member of Carpenters Local 713. Thanks to the board and all the staff, our unions enjoyed taking part in this process. Despite all the upsetting aspects of it. Bringing it back to basics a little bit, we're here fundamentally because the market isn't working. For whatever reason, healthcare is primarily, in many respects, a business in America. For me personally, that's something that I find hard to swallow. But so be it. It is what it is. And if we are to accept that healthcare is a business, and by extension that we are consumers, then it's clear that something's not working, and it's definitely not working for consumers. In any industry where you have concentrations of market power like you have in Northern California and opaque consumer price hikes, that would always compel regulatory scrutiny like we're seeing now at some point, including the introduction of new regulations to curb any potential abuses of market power. So in a roundabout way, that's what we're seeing happen here. And this is a regulation we need to try and implement thoughtfully to bring some relief to consumers, not implementing it on the back of workers, but implementing it on the back of corporate excess, of which there are many examples in the system. And we need to bring relief to consumers, including our members who've worked very hard to build up California, and now they need California's help, including its state institutions such as OCA. I like the legislative policy change ideas we saw earlier. I hope there's more of them. We need to do something to try to fix this system. So the Carpenters Union in Northern California supports this spending target, and we look forward to participating in the implementation process also. Thank you.
Thank you.
Good morning. My name is Richard Axley. I am.
Can you speak into the microphone?
What's that?
Speak into the microphone or make sure it's got a green light.
Good morning. My name is Richard Axley, and I'm a proud Army veteran and member of Carpenters Local 46 in Sacramento. I'm here speaking today because I'm extremely frustrated at the constant David and Goliath battle between the working class and greedy corporations. Obviously, I'm not getting any younger. Thank you. Obviously, I'm not getting any younger now that I need affordable access to healthcare more than ever. When I learned that they are trying to raise rates on my access to healthcare that I've already had to sacrifice other necessities for, filled me with great anxiety. When I learned that Kaiser CEO Greg Adams makes more than 70 times the average nonprofit CEO salary, which is more than $57,000 a day, it filled me with rage. With so many families struggling to make ends meet today, it sends a wrong message to these families and myself when the CEO of Kaiser makes $15 billion a year. While Kaiser may be a nonprofit, it sure sounds like it is profitable to be Greg Adams. I'm asking the board to act as the stone in David's legendary sling to help us take down the Goliaths of the healthcare industry by approving the 3% spending target. Thank you.
Thank you.
Good afternoon. I'm Joan Allen with SEIU United Healthcare Workers, speaking today on behalf of the 700,000 members of SEIU in California, all of whom share the struggle of the union siblings you've heard from today. At every bargaining table, health insurance costs are an absolute weight on good middle class raises and good middle class jobs. And it is past time for California to act. We applaud the work of the staff and the board to this point that gets us to the point where we are considering real numbers to start to reduce the growth in healthcare spending. That is fantastic. But this is really where those small differences can start to create a long-term split in how the trend is going to go. We would ask the board to reject the motion currently on the table and return instead to the initial staff proposal of 3% for 5 years. We would, as you've heard from some others, understand and grudgingly support the proposal with a phase-in. However, once we're starting to adjust for an aging population, that introduces too much complexity for what should be something that our members can understand. Would additionally align comments with UC Berkeley Labor Center that we're already counting aging within THCE and feel like at the entity level is a much more appropriate place to be counting aging and sex differences in population as they change. So would call on the board to stand strong and stand with consumers and with patients as you move forward, and to get this started so that we can start really bringing that back to our members and show them what California government can do when it really works.
Thank you. Please go ahead.
Good afternoon, board members. My name is Joseph Perez, and I'm a member of Carpenters Local 46 in Sacramento. I'm grateful to have access to the health care for my work hours through the Carpenters Union. In November of 2022, I lost my wife to ovarian cancer. She received treatment at the Morris Kaiser. Excuse me. I consider myself fortunate to have had access to this treatment for her. However, I was very disappointed in the level of care I received. On one occasion, my wife needed to be assistance to go to the restroom, but could not get any nurse to help her because they were preoccupied celebrating a birthday of one of the other nurses. My wife had to be assisted by her roommate, who was also infirmed. I also experienced my wife having her feeding tube not properly inserted and multiple failed attempts at starting an IV. It is devastating to lose your spouse, and I can't help but wondering if Kaiser could have done more for her. Healthcare is already extremely expensive and out of reach for so many people. If I make a mistake in the field, I have to eat the cost of a mistake. I don't get to pass that cost off to another consumer. Please stand up for working class people trying to maintain access to healthcare and send a message to the healthcare giants that members should not have to bear the burden of your mistakes with unreasonable rate hikes. Please approve the 3% spending target. Thank you for listening to me. Have a great day.
Thank you.
Bye.
Go ahead.
Good afternoon. My name is Alexander Hampton. I'm a local 46. I'm also a field representative for the North Carolina Carpenters. First of all, I want to say that the Carpenters Union represents 11 crafts and is the largest construction union in the state. North Carolina Carpenters members mostly enrolled in Kaiser. Healthcare went up through the years. I know it's a burden on us. We get our work hours, and that's how we get our healthcare. It's very expensive, and we have a problem when it's high like that. Of course, with the economy the way it is pretty difficult, especially when the service is not top of the line, like my brother just said. I had an incident myself last year. I was working out, and I had a pinched nerve in my neck. Went to Kaiser. The first thing they told me was, here, take this pill and make sure you don't drive. You're going to be woozy. Well, that's not the response I needed there. I needed some rehabilitation, either stretching or something like that would help me with the problem. We need to definitely change that. The North Carolina Carpenters support the 3% statewide increase, and we urge the board to adopt this spending target without delay. And thank you for your time.
Thank you. Please go ahead.
Good afternoon. My name is Giovanni Ottolini. I'm a proud member of Local 9109 here in Sacramento. I spoke last month and I told my story about how I recently found out that my daughter has scoliosis and had gone unrecognized she's 15 years old, her whole childhood. Well, since then I've been able to get into a scoliosis center, and I found out, and then I was told that there's nothing they can do for her. She's 15 years old. Her plates or whatever are grown, and she's stuck with where she's at. And the emotions that I felt when I was told that, the anger and the rage, because the whole reason I've been grinding for 15 years doing the trade is so that I could have this access to this healthcare to prevent this very situation, maintaining or giving her access to preventative care, the physicals. And I went back and I looked at her physicals, and every single physical, it says her spine is fine. Her spine is fine. And like I stated in my previous testimony, all it took to diagnose this was for them to give her the attention to look at her and evaluate her spine. It didn't take any fancy lab work, didn't take any expensive imaging. It literally just took eyes on her and to give her that time of day. So, a lot of emotions went through me. I channeled that energy instead of doing something destructive and negative, and that's why I'm here again today. And so last night I was thinking, and I asked Alexa, I said, hey, Alexa, are doctors considered fiduciaries? And this is what Alexa said. Yes, doctors can be considered fiduciaries because they are required to act in their patient's best interests. As fiduciaries, doctors must put their patient's needs above their own and make the decisions that are in the patient's best interests, even if it means sacrificing some of their own income or profits. I'm asking you today to remind Greg Adams of Kaiser that he is a fiduciary and support this 3% cap. Thank you.
Thank you. Next.
Good afternoon, board members. My name is Armando Murillo. I'm with the Northern California Carpenters Union. And as most of you are aware, Northern California Carpenter members are enrolled with Kaiser Foundation Health Plan, as I am, and many of whom have been with Kaiser for nearly their entire lives, not to mention their children and their grandchildren. Again, you've heard that the Carpenters Union represents over 11 crafts and is the largest union in the state with approximately 45,000 members in good standing. Our membership already pays hundreds of millions of dollars out of their pay towards healthcare, and the cost continues to rise astronomically. This threatens our wage increase and our pensions alike that unions such as ours have bargained for and worked so hard to earn. We continue to pay these exorbitant medical costs while the standard of healthcare continues to decrease, whether nurses go on strike or not. For example, when my wife was pregnant, it was discovered by her OBGYN that she had a cyst on her uterus, which had to be removed, and it was. Then only a few months later, she started to hemorrhage, so I rushed her to Kaiser, where she had to wait for over 2 hours before she was admitted into a room for examination. Long story short, we lost the baby, and we were devastated. So we sat there with a jar of saline and a baby inside of it, basically. Then this occurred on a weekend, and then the following Monday, she had her examination by her doctor, who conducted an ultrasound, and we were informed that the baby's heart was just fine. Well, this is the first that we knew, that she was pregnant with twins. So we were floored. So how can we allow substandard practices for premium costs of health care without regulation? We need more rules for a healthcare system that is fair to its members. This is why the Northern California Carpenters Union supports a statewide target of 3%. Thank you.
Go ahead.
Hi, Ben Johnson with the California Hospital Association. We believe California has to be affordable while also being there for the people who need it. And unfortunately, OCA's proposed target puts the latter prerogative at risk, jeopardizing whether the right care will be there at the right place and the right time. And we urge the board to reject a flat 3% spending target through the multi-year. CHA has put forward an alternative framework that includes various adjustments that would set the target on a more sustainable and attainable path. And we continue to ask for consideration of these various adjustments. We do support the inclusion of a glide path, which would move things in the right direction in harmonizing California's approach with that of other state spending programs. And we urge the board to incorporate one that is meaningful and gradual in terms of its ramp down. That said, we are concerned that this change alone won't be enough to sustain essential healthcare services in communities around California, given the current inflationary environment, given the accelerating aging of California's population, existing financial distress that threatens providers' ongoing viability, new statewide policies that are going to be costly to bear, and then the enormous unmet needs that are out there that really require investments in the systems rather than divestment. So we encourage continued evaluation of an appropriate target through your statutory deadline, and should action be taken today, we do think that opportunities are needed to reevaluate the target and protect its credibility, and ultimately set the target up to succeed by setting ambitious yet attainable targets. So we ask for that process for reconsideration and reevaluation to be established on an annual ongoing basis as soon as possible. Thank you.
Thank you. Seeing no virtual hands, please go ahead.
Thank you. Teresa Stark with Kaiser Permanente. I do want to thank the OCA staff and the OCA board for all of the work that you have done so far, all of the robust conversations you have had and the time you have taken in weighing this very consequential decision in hearing the very important public comments that you have heard. Kaiser Permanente is in support of motion 1, as moved by Secretary Galley, to start at 3.5 and in a few years get to that 3% level. With all due respect to Drs. Pan and Dr. Kronik, we do think the original motion is the prudent approach. It will help achieve our mutual goals of affordability, but in a measured and achievable way. It gives us a little bit of space for us all to learn and adjust accordingly as the results come in. This proposal is going to be challenging even for us, given some of the input costs that we continue to wrestle with, such as high-priced pharmaceuticals. It is quite strict, but this proposal is aligned with our affordability mission, our values, and our goals, and we are pleased to support it today because we are committed to doing better. We look forward to moving forward together. Thank you.
Thank you. In the room, go ahead.
Janice Rocco on behalf of the California Medical Association. Today's decision is an important one, but it's really only the beginning of the work that we have ahead of us. California is not the first state to adopt a healthcare cost target, and we seem poised to do what other states have done in terms of having a phased-in approach. Today's decision will be followed by a responsibility to keep track of how this decision impacts affordability for consumers, access to care, quality, equity, and market consolidation. CMA supports a phase-in approach, though the information and testimony we've provided previously demonstrates that 3.5% is lower than the increasing cost of providing medical care and lower than median household income in recent years. No one here wants healthcare entities to only be able to meet the cost target by decreasing access to care or increasing deductibles or shutting down healthcare facilities or some of the services they provide. So today's action is only the beginning of the need for all of us to work together to monitor the actual cost of providing healthcare and to ensure that the affordability target does not interfere with access, quality, or equity. We look forward to continuing to work with you.
Thank you.
Hi, good afternoon. I'm Kieran Savage-Sungwin. I'm the Executive Director of the California Pan-Ethnic Health Network. We support a target that is tied to consumer affordability, as you all have discussed. And I really want to appreciate the OCA staff and all of you for keeping the goal of this work front and center, which is not only to make healthcare cheaper, but to make it better. The current system creates and perpetuates racial disparities, which are deep and unacceptable. In fact, the racial gap in life expectancy has widened in recent years. At the same time, consumers, particularly people of color, are burdened by record medical debt and are making daily and untenable choices between healthcare, housing, and food. We know that people with debt live shorter lives. In other words, high healthcare costs make us sicker. If we want a different outcome, we need to change the incentives in our system. We hear about the right care at the right time, but the reality today is that people of color don't have the benefit of much of the promise of healthcare because the cost is excessive. So again, CPAN strongly supports the 3% target, and recognizing, as some board members have pointed out, that doesn't actually make healthcare more affordable, but keeps it from becoming even more unaffordable. And I appreciate Dr. Carlisle's point that the cost of a phase-in is a human cost, and it is right in front of you. You've heard about it all afternoon. And so we would urge that if you proceed with a phase-in, you strongly explore additional policy options to ensure that healthcare entities do put those additional dollars, which consumers will be paying for the next 4 years, many times at great hardship, into delivery system reforms that actually make care more equitable, and not continue for the next 4 years to use those dollars for profit, wasteful spending, and to squander them in other ways. I believe we have an incredible opportunity here today, and we urge you to seize it on behalf of all Californians. And I just want to make one other note that I hope in the future, the state, when you're having meetings, will make sure that your meetings are accessible to the people who are really most impacted by your discussions, and that would definitely include providing appropriate interpretation and translation services. So I appreciate consideration for that in the future. Thank you.
Thank you. Back to the podium.
Robbie Franceschini with Blue Shield of California. We strongly urge the board to vote yes on motion 1. We strongly support a glide path approach. We think that ramping down to 3% over several years really allows for us to not only see some of the baseline data over the first 2 years, but also allow for some adjustments when it comes to provider contracting as well. So we really want to thank the OCA staff for the discussions that we've had over the last 5 months on this subject, and really appreciate all the feedback that you've taken. Thank you.
Thank you. Looking online, seeing no virtual attendees with their hands raised in the room, seeing no one at the podium, that concludes public comment on this item.
Right. Just want to, on behalf of the board, just thank the tremendous public comment and appreciate people who came from close, came from far to share their thoughts, whether virtually or in the room, but particularly those who came from far away to be here with us today in person. We are very grateful. Okay. With all of that said, I appreciate the staff's quick work to have motion 1 and 2 up on the screen. It's been up virtually so that people could see this. Motion 1 was the motion that I put forward, and that was seconded by Sandra. And the motion 2 is really motion 1 with the amendments and that Rick Kronick put forward and was seconded by Richard Pan. So I don't know that there's a rule book on how to do this. There probably is. I'm going to tell you how I would like to do this. I think we are going to take a formal vote on motion 2, and that is the one with the amendment. And depending on how that goes, we will potentially have a chance to consider motion 1. So unless Jean Paul or somebody else has clear direction, otherwise that's, I hope, okay to do. Yes, okay. Wow, I got something right today. Okay, let's jump. I think we had our discussion. I mean, it's all possible. If you would like to make another comment, please go. It has been really important to me, the importance of the decision that the board and the public have a chance to have this good, robust, even if lengthy dialogue. So go ahead, Rick.
Thank you, Dr. Galley. I know it's late. It's been a long day already, and we still have a lot more to do. I am in the ironic position, as are, I think, Elizabeth and Ian and others, of sort of arguing opposite to where we've been in terms of pressure on the industry. That if we were to adopt motion 2 and the graph below, or the box below, is more complicated than it should be. The first row, 2025, should just say 3% plus age adjustment, 3% plus age adjustment, 2.7, 2.7, 2.5. If we were to adopt that motion, it would, I think, put more pressure on provider groups in their negotiations with insurers than motion 1. I mean, the numbers are virtually the same, and so maybe the amount of pressure doesn't really change, but it would make clearer what's expected, which is that a commercial contract should grow at 2.5% per person per year, and a Medicare Advantage contract should grow at 2.5% per person per year, which is, I think, implicitly what's expected in motion 1 as well, but in motion 1 it's only implicit, and probably providers and insurers are smart enough to figure out from motion 1, if we were to adopt it, that actually they have to negotiate 0.5% less to get there. But motion 2 makes it clearer what they need to do to get there. And I argued earlier, I'm concerned that this is on a, will be seen as unachievable and may hurt legitimacy if we're too low. Motion 2, I think, makes it even clearer and harder, but it is a representation of what we're expecting. So that would be my argument for it.
Go ahead, Ian.
I will. Like many people in public comment, I would have preferred the number, the simple 3%. It's clear and it's more in line with what I'd like. I didn't sense the votes were there for that. That's why I didn't propose the amendment. I think the motion 1 is crystal clear, and with that, I'm inclined to support it. And really focus my attention on setting up the enforcement apparatus, which will include age and sex adjustment as we go forward. And I'm really intrigued by the suggestion that we figure out how to prioritize that differential on health system improvements, particularly with regard to equity. So I'll be voting no on the amendment.
Okay. All right. I will move us to a vote. Sorry, but no, go ahead, Richard. I wanted to, it's worth taking the time to make sure everybody's feels ready. Go for it.
Well, first of all, I agree with what Dr. Kroenig said. I do wonder how, I mean, obviously, I agree also with Mr. Lewis that, actually, and I've said before previous meetings, how is this actually, what's the operational way we're going to enforce this, right? And so while we'll be looking at different entities depending on their, their population taken care of, we're having these discussions about attribution. So you're going to look at the particular age and sex of that. But fact is that the total population of California is aging. So yes, you could have children's hospitals would be one group. You could have another Medicare Advantage plan, another, et cetera. But I think that, again, what Dr. Kroenig said is that this is being transparent up front about what's going on in our population and how that impacts the needs of California as a whole, which is why it makes sense to be put into the statewide cost target, and then how we apply it then to individual entities. Obviously we'll take account of the particular population they take care of, but this is about the total. And someone made comment about this is a little bit of future casting, but I think that we are putting a 5-year path, so that is future casting. We're future casting out 5 years, which, by the way, since the legislature is wrestling with the budget, we can talk about some of the challenges of doing that, but at least there are particular factors. And frankly, as someone who chaired the budget subcommittee of Health and Human Services, demographics were important in helping future cast, whether for LAO or Department of Finance, what the needs were for Health and Human Services, including Medi-Cal, including other things going into the future. And if they didn't do that, it didn't make sense. So I would certainly be in support of the amended, motion 2. It's really amended version 1.
Okay. Thank you, everyone. Seeing no other comments, we will go. So just to be clear, it is what is called motion 2 with amendments.
Right. Secretary Dr. Mark Galley.
No.
Dr. David Carlo.
I vote no.
Dr. Sandra Hernandez.
No.
Richard Kroenig.
Aye.
Ian Lewis.
No.
Elizabeth Mitchell.
No.
Dr. Richard Pan.
Aye.
Two ayes and 5 noes.
Okay. So motion fails. Even I can do the math. Ian, maybe. Yeah. And so I think we go back to the original motion. which is motion 1 on the slide in front of us. Please.
All right, on motion 1, Dr. Mark Galley,
Aye.
Dr. David Carlisle,
Aye.
Dr. Sandra Hernandez,
Aye.
Richard Kronik,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Dr. Richard Pan.
No.
I have 1 no, 6 yes.
Okay, so it carries. Just again want to thank the board for all of the robust discussion, and it's appropriate we take a break. We will see what comes next in the meeting, but again, just want to thank the public, thank Dr. Wood and his leadership, the legislature, the administration. It's a pretty important moment, and appreciate the robust conversation. There will be a vote at the end. The public's welcome to join. Who should be chair of this board? I'm more than happy to be replaced after today's performance, but really grateful to everybody. Oh, yeah, we'll come back. Sorry, we will come back in 30 minutes. So welcome. I think we should reestablish quorum to make sure, and then I will sort of lay out my hope for the rest of the meeting, and then we can jump into it. So go ahead.
Great, thank you. Dr. Mark Galley,
Present.
Dr. David Carlisle, Dr. Sandra Hernandez.
Here.
Richard Kronik,
Here.
Ian Lewis.
Present.
Elizabeth Mitchell, Dr. Richard Pan,
Present.
and Don Moltz. All right, all present.
All right, thank you. So I know we have 3 remaining agenda items, and as much as some of you want to stay for all 3, none are, they're all very important, but to get through them today is not critical. We can decide to delay them. So I have asked the team which one of the 3 we will get through today, and then we will adjourn. We will get through it, have discussion by the board, have public comment as we always do, and then if that's sufficient, meaning we don't want to have just general public comment by the at the very end on the whole meeting, we will adjourn. So unless I see serious concerns with that from the board, and I know none of you, well, we haven't said which of the 3 items we're going to do. That was deliberately withheld from you. No, we're going to find out in just a moment. Okay, thank you.
Sure. So good afternoon, everyone. So we'll be focusing on our proposed workforce stability standards this afternoon. The other 2 topics, alternative payment models, we presented to you before in February, and we were planning to propose revisions today, but you have those in your materials, and we'll come back to those. And then the primary care investment benchmark, that is also the first time it would have come to you was today. So we'll come back to that in a future meeting as well. And that one does not have a statutory deadline, whereas alternative payment models and workforce stability do. So we wanted to prioritize this. So getting into what I'll share today. So I'll share our draft workforce stability standards and a set of metrics that we're proposing to monitor workforce stability, which we've developed over the past several months with input from stakeholders and the advisory committee. And joining me online this afternoon is Janet Kaufman from the Institute for Health Policy Studies and the Health Force Center at UCSF, who can help answer questions from the board. And also of note, we are releasing these draft standards and metrics today for public comment. So to start, I'll share an overview of the statute. So OCA's enabling statute mandates that by July 2024, OCA develops standards in consultation with the board to advance stability of the healthcare workforce. So these are non-enforceable standards that will be used to monitor workforce stability, monitor workforce trends, and promote stability as the spending targets are implemented. And we're charged with monitoring workforce stability in a few ways. One, monitoring the effect of spending targets on workforce stability, ensuring that workforce shortages do not undermine healthcare affordability, access, quality, or equity, and promoting healthcare affordability while also recognizing the need to increase the supply of healthcare workers. So the statute also indicates that that OCA may require a healthcare entity to implement a performance improvement plan if spending targets are not met, and that the director shall not approve a performance improvement plan that proposes to meet cost targets in a way that erode workforce stability. So there are workforce stability standards that apply in a performance improvement plan, and there are also general workforce stability, and our current focus today is on those general workforce stability standards. So the board approves these standards that apply in a performance improvement plan, and the general standards we'll review today will likely be used to inform the standards used in a performance improvement plan. So this slide is just a reminder of why our workforce stability efforts are so important. Currently, California faces a significant health workforce shortages for some key occupations, some of which are regional rather than statewide, as recognized by many organizations, including the California Future Health Workforce Commission and other programs that monitor and strengthen the healthcare workforce. So healthcare workforce challenges contribute to a lack of access to needed services, including preventive hospitalizations, delays in receiving appropriate care, and preventable hospitalization. And we know that a stable, well-prepared, and adequately supplied workforce is essential to a sustainable healthcare system that provides high-quality, equitable care. And to date, no other state has included workforce stability in its spending growth target programs. So we're entering new territory with this effort. So as a bit of background on our process to get to this point, we've been working with the Institute for Health Policy Studies and the Health Force Center at the University of California, San Francisco, as I mentioned, to support the development of these standards. And this slide outlines our approach. So after completing background work in summer and fall of 2023, we completed our first draft of standards and monitoring metrics in February 2024. And throughout March, we interviewed and surveyed stakeholders to gather feedback on these draft standards. And then from April through June, we'll continue to solicit input through public comment, the advisory committee, and the board, anticipating final adoption of the standards in June. So I'll walk through our learnings from each of these steps in this process and share our draft standards and monitoring metrics. So this is what we learned, some key takeaways from our literature review at both the organization level and the market level related to workforce stability. So UCSF's review of the peer-reviewed literature and gray literature on workforce stability found that there's no consensus definition for healthcare workforce stability. At the organization level, measures of turnover and retention are most used in the literature with variable definitions across studies. At the labor market level, the literature points to factors such as licensure delays, poor working conditions, low wages, mismatches between population need and economic demand for workers, and exits from the workforce as contributing to labor shortages. Labor costs are also a major contributor to overall healthcare costs, and turnover costs and high payment rates of contract workers are two elements of labor costs that could be reduced when the healthcare workforce is stabilized. So an important conclusion of this literature review is that no literature currently exists that directly evaluates the impact of healthcare spending targets on the stability of the healthcare workforce. So now turning to our findings from our data set and metric review. So UCSF reviewed 17 state government and federal government and non-governmental data sources to track elements of workforce stability at the organization level and another 12 at the market level. So they found that the HCI collected data from hospitals and licensed primary care clinics is of high quality and relevance to organization level measurement. And for example, HCI tracks the total number of hours worked and average wages for several occupational categories for all hospitals, and similar but less detailed data for all licensed health centers and long-term care facilities in California. And other potentially relevant publicly available data sources besides the HCI sources identified were the California Employment Development Department's quarterly payroll data, which tracks employment trends at the organization level, and CMS's payroll journal, which monitors employment in nursing homes. So some of the data sources evaluated OCA would need to develop data use agreements with those entities to obtain organization level data. And there are also proprietary data sources, such as the American Hospital Association's annual survey of a hospital, which includes staffing levels, which would require a memorandum of understanding to access. And at the labor market level, several national sources of data on workforce stability include the American Community Survey and the Bureau of Labor Statistics Occupational Employment and Wage Statistics Survey that could be used to monitor California's supply of unlicensed healthcare workers. And HCI collects license renewal survey data from 21 healing arts boards in California that track supply, geographic distribution, and demographic characteristics for licensed professionals, including from the Board of Registered Nursing. And to monitor health professional trends in the U.S. Department of Education's Integrated Post-Secondary Education System reports on the number of graduates from bachelor's and graduate degree programs and their racial and ethnic diversity. So again, overall, this review demonstrated that public data sources exist to track several valuable workforce stability metrics. And now we'll turn to a key part of OCA's interpretation of statute in terms of who the workforce stability standards apply to. So OCA's enabling statute refers several times to non-supervisory healthcare workforce and the frontline healthcare workers. And based on this language, OCA has interpreted the statute to mean that the supervisory healthcare workforce, such as physicians, dentists, and pharmacists, are excluded from the workforce stability standards. Several interviewees suggested that OCA should include these supervisory workers, pointing to issues such as primary care provider shortages and the fact that increasingly physicians and other providers are employees of large health systems and do not function as independent practitioners. For now, OCA will collaborate with HCI's Office of Health Workforce Development to understand trends in the physician workforce, and we may consider broadening our scope of the standards in the future. So as I mentioned, we conducted initial interviews to get a variety of perspectives on the OCA's workforce stability standards. So we completed a series of 23 interviews from mid-October to early January with content experts, including academics and health policy organizations like the National Academy of State Health Policy, and stakeholders representing diverse perspectives, including hospitals, public and private delivery systems, consumer advocacy groups, and organized labor. And a list of these interviewees is available in your appendix. And so we used these interviews to gather input from all of these organizations to inform the development of our draft workforce stability standards. So this slide lists a few key takeaways from those interviews. So one of the major themes was the potential benefits of the standard, such as identifying factors that are contributing to workforce challenges and shortages, as well as their potential to identify organizations or healthcare entities who might be responding to the spending growth targets in a way that negatively impacts both patients and the healthcare workforce. Additionally, several interviewees noted that a more stable workforce could reduce healthcare costs, therefore benefiting the entire healthcare system. Interviewees also highlighted challenges of the standards, including applying a single set of standards to a diverse array of healthcare entities, ranging from small rural clinics to large health systems, and the potential for these standards to inhibit innovations in care delivery. Reporting burden was another potential challenge raised, especially for hospitals and publicly funded clinics that are already subject to significant state and federal reporting requirements. And another theme of the potential challenges was the lack of enforceability of these standards, which could pose challenges in their adoption and implementation. And interviewees were divided in their opinions about whether OCA's workforce standards should apply equally across settings and occupations or focus on specific settings or professions. So some interviewees suggested focusing on high-cost, large employers such as hospitals, while others suggested prioritizing settings that employ predominantly unlicensed, non-unionized workers such as skilled nursing or long-term care facilities. And then even others suggested prioritizing specific professions like behavioral health providers and community health workers. And other stakeholders suggested that OCA focus on settings with little current regulatory oversight, such as physician offices. So moving to our approach to the workforce stability standards. So based on all of the learnings from the literature review, the data set review, and these initial interviews, we developed an approach to the workforce stability standards that focuses on standards as best practices for organizations to adopt and on monitoring workforce stability metrics using publicly available data. And we developed a set of guiding principles to inform our development of the standards, and the full set of those guiding principles is in your appendix, but a few we wanted to highlight were incorporating flexibility to acknowledge differences in workforce structures across settings and occupations, and tracking the impact of spending targets on vulnerable workers and communities. So our current approach to the workforce stability standards frames the standards as best practices, and we strongly encourage organizations to implement the standards, including monitoring a set of key performance indicators to assess their effectiveness in achieving a stable workforce. So while there are no financial penalties for non-compliance, these standards will be used to inform the development of the standards that may apply in performance improvement plans for entities that exceed the spending targets. And we currently propose an approach of monitoring workforce stability using publicly reported metrics that provide insight into workforce stability at the organization and market levels. And I'll discuss in the following slides, OCA is investigating the possibility of collecting new data from healthcare entities to enhance existing public reporting. We may introduce performance expectations in future years after establishing baseline data on proposed metrics, and OCA will report on the workforce stability metrics at the organization and market levels in our annual reports. So these, on the next two slides, are our 6 draft workforce stability standards. And given the absence, as I mentioned, of evidence to support setting specific benchmarks, at this time we are defining standards as best practices for organization behavior. So the first standard directs healthcare entities to monitor a set of key performance indicators for workforce stability. Some example indicators that stakeholders emphasized included turnover and retention rates and time to fill vacant positions. And we're not aware of existing public reporting for most of these indicators, so for the immediate term, healthcare entities should monitor these indicators. And as I mentioned, OCA is exploring options to collect data and report on these key performance indicators in future years. And the second draft standard emphasizes that healthcare entities should develop formal processes to adapt to changing workforce conditions. The third standard focuses on investing in training opportunities for healthcare workers. The fourth is increasing the use of interdisciplinary healthcare teams and other care delivery innovations to improve affordability, access, quality, and equity. The fifth is to center culturally and linguistically competent care. And the sixth is to monitor and address workplace safety and violence. So before I review the metrics that we are proposing to monitor, I wanted to note that we plan to monitor workforce stability metrics at 2 levels, as I've been discussing, the organization level and the labor market level. So employee wages and contract nursing hours are example of organization level metrics, and then at the labor market level, We can monitor metrics to inform the overall functioning of the healthcare labor market across various occupations and regions. So the number of new graduates entering the job market and demographic characteristics of workers within an occupation are examples of market level metrics. And wanted to note that we're mindful of the important interactions between the market level and organizational level forces that together shape the overall stability of the healthcare workforce. So these next few slides provide just some examples of the metrics we're proposing to monitor at the organization level and the market level. And in your appendix, there's a full set of the metrics we're proposing to monitor by setting. So at the organization level, we have included a few examples of the workforce metrics we plan to monitor, selected from data HCI collects in its annual hospital financial disclosure reports. For example, we'll monitor average hourly pay for various occupations within a hospital, including nurses and food service staff. And these metrics allow us to consider various indicators of job quality and workforce adequacy in California's hospitals. And to the extent data are collected, we'll track similar metrics for nursing homes and licensed community clinics, also collected by HCI. And again, the full list of metrics is in your appendix. And for the market level, similarly, we're proposing to track metrics from a variety of state and national sources. For example, California licensure boards records and HCI's license renewal surveys can tell us about the demographic characteristics of licensed professional. As I mentioned earlier, the U.S. Integrated Post-Secondary Education Data System reports on the number of degrees conferred, including the racial ethnic makeup of graduates across the state and region for many health professions. So we propose to track several data sources specifically for registered nurses, as nurses are the largest licensed occupation in California. And these market level metrics, which are listed in full in the appendix, allow OCA to report on workforce diversity and the appropriate workforce supply, and to identify trends that reveal potential future shortages, giving state agencies such as HCI and others the opportunity to intervene. So now that I've walked through our proposed standards and metrics, I wanted to share in just a few more slides some of the themes of the feedback we got from the advisory committee when we presented these standards and metrics, and also we re-interviewed 10 of the interviewees that we originally interviewed and got their feedback on these draft standards and metrics. And then we also, we re-interviewed 13 of those initial interviews and surveyed another 10. So here, this slide represents key themes from the workforce stability standards feedback. So several of those include, regarding the 6 standards, stakeholders stress the importance of creating clear and measurable standards. They also emphasize addressing workplace safety and several also proposed including physicians in the workforce stability standards. So in response, we have refined the standards to improve clarity based on our first draft that we shared with our interviewees. We've also reviewed all of the metrics we propose to monitor to ensure that they are connected to the standards, and then added a standard for measuring work or promoting workplace safety. And as I mentioned earlier, we'll collaborate with HCI's Office of Health Workforce Development to better understand trends in the physician workforce. And in terms of our standard number 1, we also received a lot of feedback regarding the key performance indicators. So many stakeholders highlighted the need to implement or to use standardized definitions for these indicators to ensure consistency across entities, as each of them may define some of these key performance indicators differently. And opinions on whether OCA should require reporting on entity performance on these key performance indicators varied. So some advocated strongly for mandatory reporting, while others preferred relying on existing publicly available data. And there was widespread consensus that turnover, retention, vacancy rates, and contract labor use rates were important indicators of workforce stability to track. And additionally, there were recommendations to address issues related to burnout and moral injury within the healthcare workforce. So in response, we're proposing to explore options to incorporate these key performance indicators into existing HCI data collection processes, and I'll discuss that more in a moment. And we've enhanced the employee engagement key performance indicator to include indicators of burnout, moral injury, and job satisfaction. We also added a new key performance indicator to emphasize the importance of each entity monitoring their use of contract labor as suggested by stakeholders. So, and for contract labor use, unlike the other key performance indicators, OCA can assess contract labor use at several different healthcare entities using the HCI data, but it was still raised by our stakeholders as important to highlight as a key performance indicator. And then in terms of the metrics, wanted to review some of the key themes of the feedback received and our proposed response. So some of the key themes here included expanding the monitoring efforts by incorporating more unlicensed occupations such as community health workers and doulas and violence prevention specialists. Stakeholders also recommended expanding on monitoring to ambulatory care settings, particularly primary care offices and behavioral health settings. Additionally, we heard about the importance of monitoring worker safety through measurements of workplace injuries or labor violations and reporting on mass layoffs that might occur as entities attempt to meet the cost growth targets. So in response, we'll ensure that our metrics capture the suggested non-licensed occupations to the extent that data are publicly available. And additionally, we're actively evaluating options to address data gaps in ambulatory settings to ensure more comprehensive oversight of those settings, such as the primary care settings and the behavioral health settings. We're also assessing additional data sources that could allow us to track worker safety and layoffs. And I just want to note that we greatly appreciate all of the wide array of perspectives that has informed these draft standards and metrics. And we also recognize that these standards and metrics are a starting point and that we have more work to do to ensure workforce stability and achieve our statutory mandate. So getting to in response to stakeholder requests in terms of mandating reporting on those key performance indicators I mentioned in Standard 1, we are currently evaluating the necessary steps and timeline to update existing HCI data collection mechanisms or forthcoming HCI reports to include those key performance indicators. And we're collaborating across HCI to conduct this evaluation. We're also exploring several recommended external data sources that would have organization and market level data for us to analyze and report. So using the suggested data sources from some stakeholders would require a memorandum of understanding or a data use agreement, or substantial resources would be required to extract and analyze the data in some of the sources proposed. So we're conducting that analysis currently. And due to the complexity of these data, the data evaluation needed, the timeline for completing this work will extend beyond the July 2024 deadline for OCA to adopt its initial workforce stability standards. But we are continuing to move forward with this evaluation. And this last slide shares our next steps. So we're soliciting feedback on these draft standards and metrics, which, as I mentioned, are open for public comment from today continuing until May 24th. And we plan to present these draft standards to the advisory committee again in May, and we'll incorporate feedback into the standards and present final standards proposed at the June 2024 board meeting. We also plan to report to the advisory committee and the board in fall 2024 on our progress towards identifying additional data collection mechanisms that could be used to for future reporting on the workforce stability standards, especially those key performance indicators. And so now I'd like to open it up for feedback and questions on both the workforce stability standards and the metrics.
All right, thank you, Margaretta, and everybody who helped us get to this point. I know a lot of other meetings, feedback that we've received, comment letters as well. David, you're first. Go for it.
Well, thank you, and great presentation. And this, of course, is one of my favorite subject areas to talk about. I did have one comment, though. I like the standards and the metrics. I think they're very appropriate. But I think one thing is actually kind of missing. And it may not be from the perspective of a delivery system or organization, but more from a public health or state health system perspective. And that is, do we have any metrics that kind of describe the failure of the healthcare system or the workforce to serve underserved areas? And when you think about challenges in California, the canary in the room, or the tunnel, the mine, is the underserved areas in California. And if you break your leg and you're way up in Modoc County, you can't see an orthopedist for hours, if not days. If you need a referral to an eye surgeon because of a traumatic injury, you can't get that in places in the Central Valley. And so, our urban areas and our big systems are well staffed, they're well populated, but our state system is failing because the workforce in the peripheral areas is kind of unstable. So I might add some consideration of how to measure this in underserved areas across a variety of professions.
Sure, thank you. That's an excellent point. And we are able to track many of the metrics by region or geography. And Janet, I see Janet on the line. I don't know if Janet wants to add or anyone else from the HK team.
So, no, I think, Margaretta, Dr. Carlisle, completely agree with everything you've said. And, I know in our conversations with Margaretta and the OCA staff is certainly their intent to track, at regional levels for those occupations that OCA has deemed to be under its purview.
And as you know, Dr. Carlisle, and you know better than I, we have the MIPSA data and the HIPSA data and the primary care and the population. So, we're very lucky to have the primary care office here within HCI, and we'll be sure that we're collaborating with that part of HCI's team.
I'll just give a shout out to my friend, Dr. Kaufman, also. Hello, Janet.
Thanks, David. Really important comment. Richard, you had your hand up as well.
Yeah, thank you, and appreciate the presentation. Someone who actually has published original research on workforce, so is interested in what we're doing in this regard, and has written policy papers in this area as well, national policy papers. So first of all, just to add on to what Dr. Carlisle was talking about, there are also issues of, certainly rural communities, specialty access is a challenge. But for example, Los Angeles, which is a very big city with a lot of healthcare providers, I know that the Asian American community, the Chinese community, has had frustration where they can't get access to in-language physicians who actually exist. So it's not that they don't exist, but the health plan, the Medicaid health plan doesn't contract with them. Or physicians in areas of LA, where actually local physicians who are actually, interesting enough, I've heard from Black physicians who complained that they couldn't get contracts to take care of patients in places like Compton and other, areas where there was a high density of. So from an equity standpoint, are we also going to look at some of those? So there's some structural issues, certainly I understand, for rural areas, and we should be figuring out how to get access there. But it's not just enough to say, well, by the way, we have doctors and they got this, and there's doctors there. But what happens is that they can't see people who are in language or who are culturally attuned to what's going on, or even within their own community. And I get people are trying to control costs by doing narrow networks, but actually what happens is that in some senses that also becomes a barrier. This is an access issue. So is that something that I just want to put a pin on that, because as we talk about equity, but how do we look into that as well? Are people building networks that actually allow people to see providers who actually they can actually communicate with directly instead of having to have an interpreter at the visit? So I guess that's one point. Yeah. Another thing is that I will point out, as someone who helped draft the statute, we say frontline healthcare workers. Frontline to me is someone who actually spends a lot of their time laying eyes on and touching the patient. And that includes physicians, dentists, and pharmacists. So it's kind of interesting. Yes, there are some physicians who are supervisory. There are some nurses who are supervisory, right? But I would say for the vast majority of nurses and the vast majority of physicians and pharmacists, as someone who is actually a dues-paying member, a union member of a physician-dentist union, it's kind of shocking to me that we'd actually interpret physicians and dentists as not being frontline healthcare workers. And obviously, same with pharmacists. My good friends at UNAC, represent pharmacists and both the hospital as well as an SAU. So I am a little confused that the statute's interpreted from the perspective of frontline healthcare workers, and frankly, many of them are not necessarily supervisory either, as well. So in the terms of non-supervisory and frontline health workers, I can get it where you say, hey, by the way, if you're a physician and you're in this position, or you're a nurse and you're in this position, that doesn't. But to just take the whole profession and say, oh, by the way, you're supervisory when you're not, and you're definitely a frontline health worker, to me, the stability standards should apply.
Okay, Ian.
Yeah, in a similar vein, and I want to disclose I was one of the people that the team consulted with in this process. I agree with much of that. I do want to underscore kind of the last bullet point you put up here, that this is going to be an evolving process. The metrics are so key. I think your point number 1 and maybe your point number 6, so there's a clear path to the right metrics. 2 through 5 are more woolly, and there's going to be a lot of work to do to put real metrics to those. I think the emphasis in the draft right now is on facilities, which is, I think, because that's where the lion's share of the data is that we have access to today. But the statute gives us the ability to obtain the data we need, and I think we need to look beyond facilities to integrated care, to physician groups, and to plans generally. I am concerned about the almost exclusive focus on employees here. I'm thrilled you're adding contract labor. Just to put a fine point on it, for instance, we talked about the behavioral health workforce, a huge portion of which is contracted, and the dynamics there really showcase what you described, Marita, about the interplay between organizational and labor market dynamics, where underpayment of certain categories leads to inequities in access, especially culturally and linguistically competent care, and geographic. So obtaining the data to tease those out is going to be essential to our job here, which is to make sure we're not having any adverse impacts and identify the opportunities for improving the system. And to that end, I brought up in the interview, I think one key overlooked area is the network adequacy lists. Obviously, there's a lot of work to do to improve the accuracy of those lists and the data that is available connected to those lists. But such a big portion of our workforce is represented on those lists. I think it's worth doing, and that's why I think this is also going to be a conversation we revisit and improve upon regularly.
Great. Other comments, Sandra?
Yeah, thank you, Marguerite. A lot of good work here. Janet, of course. On the standards, we have, as was pointed out, I guess the first standard, those are terms that we are familiar with and that generally are captured. I'm sort of struck that if you look at the stability standards 3, 4, 5, and 6. Some of it is about investment, some of it is about increasing interdisciplinary care. And then we sort of talk about center culturally linguistic competent care. And so I'm just trying to figure out your terminology here for standards. Some of this is about investment, some of this is, I don't know really, are we talking about more investments in culturally competent care as Dr. Pan and Enid referred to? So the nomenclature is something I'm just trying to wrap my head around a little bit better.
Sure. So in general for these standards, that these were kind of key or major themes that came out of our interviews that are not currently being addressed by the metrics we have available. So, you know, how are organizations investing in training opportunities? How are organizations increasing the use of interdisciplinary care teams? So these were all best practices that came out of our interviews as ways to promote workforce stability or to have a more stable workforce. And they're all kind of at all different levels. So those were kind of, that is our approach currently, is that these are best practices, including, you know, increasing investment or monitoring your investment in training, increasing the use of interdisciplinary team members. You know, if you have not already developed formal processes to adapt to changing workforce stability for your organization. So that is our approach, and we understand some of these are more general or more broad than others, and so that's definitely something we can work on improving over time.
Thank you. Go ahead, Richard. Yeah.
Just to sort of follow up on what Dr. Hernandez asked, it is kind of interesting that you go, you know, monitor, develop, invest, increase, center. I'm not sure what center is supposed to mean, right? I mean, it should be access to, right, or patient access to culture and linguistic, or some language that's a little more active than center. I mean, center says it's a goal, it's a desire, but doesn't seem to give it the kind of weight that the other ones have. So I'm hoping we can think of some language that gives it more equal weight to, in addition, you know, in comparison with the other ones. Thank you.
Other comments? I want to add a couple. First, really associate myself with what David and Richard said just about how we focus on some of the equity principles that carry out here and the focus on different regions. And I know we'll have a chance to do that. This was the conception of what we're doing today was one of the first things when I took my job I became involved in. And one of the key conversation points during those early times of conceiving what we just voted on today about a cost target was that some of the work to hit a cost target would come at the expense of a workforce that's stable and needed. And I just don't want to lose that point in our conversation about how we come down to, you know, specific metrics and this idea that this conversation is deeply connected to the decision that the board made this afternoon. I almost said morning, but that would have been a complete lie. This afternoon. So in our just review of the content today, keep that in mind, because I think that's important that we don't forget it. And then the other point, just coming back to a comment you made, Richard, earlier about continuity. I think the continuity principle is in part, didn't say king this time, or queen, but the continuity principle is premised on having stable, not just like in number, but that this notion of retention, that the relationships that become formed to help support the value of primary care and some other sort of upstream proven interventions depends on keeping the workforce somewhat the same. Now, people retire, people leave, but when the practices shift that aren't driven by sort of those conditions, I worry, and I want to make sure in whatever we do on this workforce stability piece that we are trying to support the ongoing ability to support continuity in whatever form that looks. Oh, go ahead.
Go ahead, Janet. Thank you.
Just a couple, I mean, super useful, thoughtful discussion here. Just to Senator Pan's point, OCA will have access to the data that HCI and the licensing boards are collecting on the languages spoken by providers. So they will have that. And I realize that doesn't, I think, answer your very important question about provider networks. I mean, it's certainly important. I do not think at this point OCA has the greatest data source for that, but that seems, I think, Margaretta, something that is worth exploring as part of this ongoing exploration of data sources. And then to Dr. Galley's point about stability, one of the things that we learned in doing this work is that we don't have from existing HCI data sources a great standardized measure of turnover, but that is something that is clearly important, and I think is one of the things that, at least at the staff level, to discuss how OCA might be able to, in the future, collect that data and obtain it in a standardized way across providers. So, just a few thoughts there, and really want to thank the board members for their thoughtful input.
Yeah, please.
Thanks. Yeah, and following up on Janet's last comment, it does seem that the turnover and retention are, I mean, you have many key performance indicators. I would have those close to the top of the list of stability standards. And I wonder, I can have not been involved at all, but I can imagine the discussions about, is OCA going to require new data to be provided by organizations or not? And at least so far, it sounds like you've gotten to a not yet or not clear. Can you get from EDD the data needed to measure turnover and retention in some more or less comparable way across organizations?
So I think, I'll jump in. I mean, I think one of the things that has been suggested and is useful, at least, is the layoff, the WARN notices, and those are publicly available. I think one of the, and it's not by no means an insurmountable challenge, but one of the things for to be aware of is that the way those notices are issued is sort of layoff by layoff. So, we, for example, this past week heard a lot about Tesla. Well, if you're in the media, that's a very useful way to get the information. If you at OCA are really wanting to track this across facilities, regions, and time, the way the information it comes out is not in that database manner. But it is there, and so that becomes okay. What are OCA? To me, Margaretta, not to put you on the spot, that this or Vishal is, if that's a high priority, how could OCA allocate the human resources to turn one-by-one notices into a data set that could be used for workforce stability?
If I can clarify, I wasn't thinking of layoff notices, but I'm assuming or imagining that an employer has to file with the state information about who is working for that employer every quarter for tax purposes. And it seems like, at least in principle, those data could be used to track, that last quarter there were 100 home health aides or nurses or pharmacists. Pharmacists. Actually, a different comment. I know you've already heard a lot of response. To me, it also makes sense that pharmacists and physicians should be part of this. But in any case, in principle, I imagine some part of the state is getting information on a person-by-person basis who's working there, and that if the MOUs or DUAs could be in place, could be used to track turnover.
Oh, okay. Yes, and I think you're absolutely right. And those, I think this is what Margaretta alluded to in terms of exploring additional data sources and having the conversations with EDD to see if EDD is amenable to entering into an MOU that, if not at the individual level, at some useful level of aggregation to let HCI look at the data. So I think the answer is yes, but work to do to make that possible.
Thank you. And I guess the sort of timing of figuring out what you can get from existing data sources, and then when and if it would make sense to require additional information to be provided. I mean, and again, turnover and retention, I would think would be near the top of my list. I know many other people have been working on this. If you can't get that from EDD, then I would think you would need to go out to providers and say, this is really important, and we need it from you in some standardized fashion.
Ian?
Yeah, I just want to say, yes, EDD and Franchise Tax Board have that data. So does the IRS by way of the census. Obviously, there's non-disclosure agreements, and I don't know what the provisions around those would be. But the other point I'd make is just about every employer of any size that I've ever met pays very close attention to those metrics. So it would not be onerous to get that data that they're already collecting anyway by classification.
Helpful to know. That's important. Okay. Other comments? Go ahead. Yeah, Richard.
Yeah. So, for example, when it comes to layoff notices from EDD, is there a way to have them EDD flag them if they're a healthcare entity, so that you're not trying to go through the morass? Or the flip side is that if you're a healthcare entity that's regulated by us, you have to send us a copy of the notice as well as to EDD.
Yeah, we would just have to evaluate the staff resources for that. I mean, I guess that we could look into an interagency agreement with EDD, or I think, we will end up having to do some regulations on this. And just to the point about where we are, we do have to adopt the workforce stability standards and understand the interest and need to have the clear standards and clear data submissions. And so I think we're evaluating, you all know we get hospital data today, we get the hospital financial data, we get the utilization data. We're still have a work group that's just starting about hospital costs. And so we're evaluating what is the information we need. We have to, of course, define the terms so we're getting consistent data, and then assess where is the best place to get that data. And that will involve adopting regulations, which is just going to take us some time.
Okay, thank you.
Thank you.
Let's make sure we get public comment on this item.
Great. We'll now take public comment on this agenda item. If you are attending virtually, please raise your hand. In the room, please step to the podium and go ahead.
Good afternoon, Joan Allen with SEIU United Healthcare Workers. Really appreciate the board sticking around after a long day for this item, and because I really want to uplift what Dr. Galley said, that the OCA statute focuses on the need to make sure that the cost targets are not done at the expense of frontline healthcare workers. We saw in the COVID pandemic what happens when we have a brittle, understaffed healthcare workforce. At that point, we have to start bringing in healthcare workers from other states. Contract labor costs spike. We don't have the resources. We end up shuttling patients around the state, not because we don't have the beds, but because we can't staff those beds. We have to close primary care clinics, not necessarily because we can't staff them, but because the workers in those care clinics are getting collapsed into the hospitals of those systems. And we represent members both inside and outside the walls of the hospital. And some of our members who have always worked on the clinic side, all of a sudden we're working in the facilities. And not every part of the healthcare system has that flexibility, and that's flexibility that we should not have to use. And so these workforce stability standards are critical to ensuring that as we transform the healthcare system, we do so in a way that is supportive of the healthcare workforce and ensures that healthcare jobs are good, high-quality jobs. I look forward to the ongoing process of these standards and the recognition that what we have in the draft is not standards. They are public data sets and voluntary best practices. And so we have a long road ahead of us getting to actual standards that we see will require additional data from regulated entities, including all of the good ideas that we heard here and more. Because as we see care moving to different settings, that's going to be reflected in movements of the healthcare workforce. We're going to need to understand where that culturally and linguistically appropriate care is badly lacking now and going to get worse if we aren't uplifting those healthcare workers and finding ways to measure and then move toward implementation of some sort of standard that gets to those equity questions. So it's great to hear that you're seeing a regs process in the future. That is very helpful. And we look forward to being helpful along with all of the other unions representing healthcare workers and consumer groups around the state. Look forward to being part of that process.
Thank you. Looking virtually, noting we have roughly 60 virtual attendees. Seeing one hand raised. Travis, you are unmuted. Please go ahead.
Hi, thank you. Travis West, Regulatory Policy Specialist with the California Nurses Association. Thanks to the OCA board and staff for all of your hard work on this. With respect to the workforce stability standards and specifically the recommendation to invest in training opportunities for healthcare workers, we applaud OCA's focus on affordability, access, equity, and culturally and linguistically competent care, and the shift away from encouraging the use of technology simply for technology's sake, which can lead to greater workforce instability by pushing healthcare workers further from their patients, the bedside, and the actual practice of healthcare. We're concerned, however, that there's still an outsized focus on working at the top of scope and through team-based care, which management often uses as an end run around safe staffing requirements and to dangerously shift nursing care to non-nurse workers. We encourage OCA to remove these portions of the workforce stability standard, and instead, the standard should increase staffing to reduce moral distress and ensure that nurses and other healthcare professionals have the resources and time to provide safe and effective care. We also encourage OCA to make the monitoring of key performance indicators by providers, which is currently just suggested in the current draft standards, mandatory, and that OCA collect and include this data among the metrics that it's using to track it, to track workforce stability. Thank you.
Thank you. Continuing public comment to the podium.
Hi, Ben Johnson, California Hospital Association. We just want to thank the office for what we think is a thoughtful, comprehensive, and actually really workable approach on these standards, and only suggest looking into, as several board members have mentioned, looking into that physician workforce, as it's a critically important area of providing healthcare for hospitals as well as for patients in California. Thank you.
Thank you. Looking virtually, seeing no hands raised, looking to the room, no individuals at the podium. This concludes public comment on this item.
Okay, I know the board's had lots of chances to weigh in. I want to give a few minutes again to public comment for general public comment before I move to adjournment.
Okay, if you'd like to make general public comment at this time, please step to the podium. If possible, please keep your comments to 2 minutes or less. And while the board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during public comment that is not included on the meeting agenda, except to place the matter on a future meeting agenda. Seeing no hands raised online, to the individual at the podium, go ahead.
Good afternoon. My name is Riley Parker. I am giving you a story from Ohana from the Parker perspective. I'm a Montage employee of 20 years, currently working in infection prevention. I have the ideal American family. All three of my children have utilized services from Ohana. The younger twin dropped out after several months at 16 years old, saying, "I can do this, I got it." My 14-year-old was diagnosed with emotional dysregulation. He no longer received services after 3 years, with 3 to 4 times per week and staying in an outpatient facility in Southern California for 8 weeks. There was a time when I wasn't sure if he was ever going to succeed in life, given how much he struggled at his lowest. Ohana was the biggest influence and supporter. It was because Ohana services that he's thriving today. The biggest impact on my family, however, was during a family session when my oldest, a 17-year-old twin with cerebral palsy, was not receiving services. It was recognized by the staff for a need for immediate services. She was always a self-advocate for herself and an A student. She was quickly diagnosed with an eating disorder and suicidal, truly a parent's worst nightmare. After a 5150 hold and 3-month eating disorder in San Diego, she's thriving. Through the support of Ohana, she is now finishing her 2nd year at Fresno State. My family would be severed if it was not for the persistence services of Ohana. Although the road was financially costly, physically and mentally difficult, battles with insurance, scheduling, and weekend trips to San Diego and Oxnard from Monterey County, the outcome was the reward. Excuse me. We were not able to always receive services readily available in Monterey County. However, through the persistence of Monterey, through Ohana, they were able to help bridge the gap to provide those services necessary for the best outcome of my children. I understand that not all stories have my ending. As parents, we want to thrive to provide the best we can for our kids, and I was lucky enough to have the support and guidance of excellent Ohana therapists along the way.
2 minutes. Thank you. Looking virtually, no hands raised. Back to the podium.
Hello, everyone. My name is Mia McKernan, Community Health Program Manager with Aspire Health, which is an entity of Montage Health in Monterey County. As an employee of this organization for over 7 years, my focus is on population health, specifically opioid overdose prevention in Monterey County. Today, I won't dwell on the well-known severity of the fentanyl epidemic and the lives it has claimed. Instead, I'm here to share how our team is actively engaging and empowering Monterey County's community members. Through the Montage Health Prescribe Safe initiative, we're dedicated to reducing opioid and fentanyl-related fatalities. Our multifaceted approach begins with early education, targeting youth from middle school onwards. We equip them with insights into the impact of substance use on brain development, strategies on saying no, and ways to take control of their well-being. Prescribe Safe has a strong partnership with the Monterey County Office of Education, supplying them with student-facing materials such as fentanyl awareness posters distributed in all the public schools, and a toolkit for district leaders and principals on the importance of equipping their schools with Narcan, which is a life-saving intervention for opioid overdoses. Additionally, we actively participate in community events, emphasizing the importance of carrying Narcan and raising awareness about substance use. Our program is entirely free to the community, supported by the Montage Health Foundation, reflecting our commitment to public health. My pride in Montage Health extends beyond its dedication to patient care. It's a workplace that deeply values its employees. As both an employee and a patient, I've experienced this firsthand. My family's choice to work here and the exceptional care and top quality care that I received during the birth of my son at Community Hospital further solidifies my allegiance to this remarkable organization. Thank you for your time.
Thank you. Go ahead at the podium.
Good afternoon. I'm Jessica Moon, Director of Operations at Ohana and a licensed clinical social worker by training. At Montage Health, we believe emotionally healthy children can take on the world. That's why we created Ohana, Monterey County's mental health program for kids, teens, and parents. With a campus designed to heal, we'll be offering a full continuum of care, from crisis and residential services all the way through outpatient care. And what I am honored to share most about is the preventative care we provide at no cost. As a former clinician, I was drawn to the concept of how Ohana prioritizes prevention, giving back to our community and working towards moving the needle in our mental health system. At Ohana, we're providing weekly free classes and groups to educate our community for expecting fathers, mothers, and supporting parents in building resilience in babies, children, and teens, as well as highlighting the importance of mental fitness, harnessing the power to shape our mental health by leaning on simple habits of the body, mind, and heart. These tools will support youth and adults to develop and sustain lifelong mental fitness by building skills to manage common mental health issues like depression and anxiety. This year to date, we provided 43 groups serving 883 community members and have gone into our local schools across the peninsula serving 191 students, all of this at no cost to the students and their families. I feel honored to work for Montage Health, which prioritizes mental health, giving back to our community, and providing hope that together we can not only support with treating the mental health crisis, we can work with our community and their loved ones to provide early intervention and outreach before issues arise. Thank you.
Thank you. Continuing with the individual at the podium.
Good afternoon, everybody. Thanks so much for hanging in there. I'm Kevin Causey. I'm the Chief Development Officer in Montage Health. I brought them along here today to just let you know that there is actually a lot of really good news happening in Monterey County, contrary to what you may have been hearing. The hospitals are coordinating every possible effort together to both reduce the costs of healthcare and bringing those reductions straight to our patients. A couple of examples are that we recently forgave over 29,000 medical debt accounts that were accrued during the COVID pandemic, just forgave them in total. We, on average, do $3 million plus a year in hard cost forgiveness of medical care for folks who meet a distressed financial criteria. We established a $5 million fund with the Community Foundation to give teachers access to be able to reduce their healthcare premiums. All the while supporting all of these efforts that you just heard about here and many others. When we look at the cost of healthcare and look at a hospital's return, in our particular case, there are two net revenue streams in our entire system, and that's the hospital and the foundation. Every other thing that we do is a net negative to the organization. Our physicians group lost last year $37 million. We have 95 physicians, and the reason we lose that much money is because we take care of everybody who comes in the front door, regardless of their insurance status. By definition, when you're paying a good salary to physicians and APPs and NPs and everybody else, and a big chunk of your client base has no or limited ability to pay for those services, it's a net loss. We're happy to take on that net loss. So we like to feel like we are trying everything we can think of innovatively to work with employees. And in fact, Salinas Valley,
2 minutes.
Montage Health came together to create Trio HMO with Blue Shield. It's the first HMO that Monterey County has had in 25 years. So just want to let you know that we're with you. We really do care deeply about the work that we do and the people we care for, and are trying to make that as inexpensive as we can. Thanks for letting me go over 23 seconds.
Thank you. All right, continuing at the podium, seeing no hands raised online.
Hi, Eva Krejcinovich, Unite Here Health. We're the Taft-Hartley Trust Fund who pays for the care of the Monterey workers who you heard from earlier. I wasn't going to say anything today, and then I couldn't resist after hearing that they're happy to pay for all of these things in Monterey. Well, they're happy to pay because they're paying with the monies that would have gone to those hospitality workers who didn't get raises last year and look like they won't get raises again this year. Steve McDougall, I think very eloquently impressed upon you earlier today, the number 15.96. I want you to remember 531. That's the percentage of Medicare that we paid CHOMP, the Community Hospital of Monterey Peninsula, which is part of Montage, last year. It was 559% of Medicare the year before. At those astronomical rates, sure, they have money to do all sorts of things in the community, things that frankly they should be doing as any good nonprofit hospital should be doing. I don't think there's anything special about what they're doing. This is about healthcare affordability. That means it's about the prices. And I'm so glad that you passed a very clear spending cap, because entities like CHOMP don't get it. We have been talking about this for a year. The prices have not changed. And they need to get that message. All they do is come here and continue to talk about all the great work they're doing in the community. We have never once complained about the quality of care. We're happy that our folks have a good place to go on the peninsula for care, but we cannot do it at the expense of everything else in the workers' budget. There is absolutely no reason that we are paying 5 times what the cost of care should cost and at more than double what the statewide average is for inpatient care at the community hospital in the Monterey Peninsula. I hope that the vote that you took today gets them to think about that and gets them to start reducing prices. We don't need a 3% cap. We need like a 50% decrease. That's how bad the situation is. And I hope that you can come to Monterey and see the situation for yourself. Thank you.
Thank you. Seeing no hands raised, noting we have roughly 55 virtual attendees, no hands raised, and no one at the podium. That concludes general public comment.
Okay, and we're close to concluding our meeting. I want to just thank the board again, the staff. I really want to thank the public, especially the public who came in person and the public who came in person unpaid to be here, right? Who took a day off of work, who came at the expense of themselves, their families. I just want to recognize that because that is always particularly powerful along with the stories. Just 3 final points. I'll just end the meeting by saying it was a historic day, very important day. I think the work ahead is as important, if not more, than what we decided today. The second point for the board, especially apropos of the last bit of general public comment, we had discussed a trip to Monterey. I want to make sure that the board does make that trip. I know it's been difficult to imagine how to do it, respectful of the budget situation that the state's in and not piling onto the costs, but we will maybe as soon as next month, not to threaten something we can't deliver, but to at least look at whether we could pull it off and have the board there to have a conversation about some of these very important issues that, although a small part of California, a very important one, as we've all learned. And then had I been here at the very beginning, I just want to acknowledge that we're here today because of a lot of work of a lot of people who came together even before I even knew that I would be in this role, that we're discussing this for years and decades. And one of those people is Anthony Wright. And I just want to acknowledge you. As you plan to take all that you've learned and done in California and challenge the national stage. We're proud to have you move on to that. And I know there's still weeks, months to go, but it's important on the heels of that news, our first meeting since that announcement was made, to acknowledge both your role in helping us get to this day and the work you'll get to do watching us, challenging us, but doing it not from so close necessarily, but thank you for your work over time. And just to everybody who's stuck around online and in the room, we're grateful. Have a good rest of your afternoon.